welcoming all of you the last day of the National Head, Neck and Thyroid Cancer Congress 2025. We are so delighted to welcome you all here in NIENT. It feels amazing to see so many curious and patient faces here today, and thank you so much all the delegates and honorable faculty members for present out here. Our Congress is themed on shaping the future of head, neck and thyroid cancer. As you already know, our whole program is divided into three sections. The first day covered several important topics related to the oral cavity and oropharynx, and yesterday it was all about larynx, which provided valuable insights and discussions, and of course, the live surgeries. Today is the third and last section, and we will explore the most exciting areas in head and neck region, that is the thyroid gland. Now we are going to enter today's scientific session. Beginning, let us enjoy a short video presentation on next part of the session. Next part of the session will be chaired by Professor Dr. Mohammad Abdullah sir, Professor Dr. Mohammad Jaidul Alam sir. This session will be moderated by Dr. Abdullah Mamun sir. And moderator sirs to come up on the stage. Our profound thanks goes to our distinguished chairpersons and the moderator and speakers for their valuable contributions. I would like to request the honorable sirs to take their respective seats in the audience and enjoy the rest of the session. Thank you.
হ্যালো হ্যালো কি আপ হবে একটু বলুন Assalamu alaikum. Very good morning. We are here at the third day of head neck cancer and thyroid cancer second congress in NIENT Tezgah, Dhaka. This is organized by our respected director Hassan Zafar Rifat, as well as his team and other professor and my friend Abdul Karim Meitu. I'm really grateful to them, as I am here as a moderator of this session. Today is the last day, but it is a very attractive session today. All of the session, all of the presentation and video as well as. I'm Dr. Abdullah Mamun, Associate Professor, Mugda Medical College. Here with you for the next 2 hours. I'm really very much glad to see here Our chairperson of this session is my beloved teacher, Professor M. Abdullah, as well as Professor Jadul Alam sir. Both of them were director of this institute. Really, this session is very good start, I think. Today, first session and first presentation by Professor Gregory Randolph. He is Director of Thyroid and Parathyroid Endocrine Surgery Division, Massachusetts Eye and Ear Infirmary, Harvard Medical School, Boston, USA. This presentation is a video presentation. We will be observe it, and I think it will be very beneficial for us in the journey of thyroid from very small to monster thyroid, from benign to malignant extensive. I think it will be very much beneficial for us. Okay, we will continue by video presentation.
Hello, everyone. This is Dr. Randolph, Greg Randolph. I'm a professor of otolaryngology, head and neck surgery at Harvard Medical School. And I would very honored to speak at this conference and want to thank my good friend Abdul Karim for the kind invitation. Today, I'm going to be speaking on advanced thyroid cancer treated with neoadjuvant therapy. This is the combination of chemotherapy prior to advanced thyroid cancer surgery. These are my disclosures. This is the Charles River right outside the Massachusetts Eye and Ear Infirmary where I work and operate. Much of this work relates to the inner circle in yellow, my research group. The outer groups are my colleagues with whom I work with on a regular basis and whom I thank for all of their contributions to this and other projects. Today, I really want to talk about these three subtopics for neoadjuvant therapy prior to advanced cancer: the definition of advanced disease, neoadjuvant therapy that is agnostic to NGS testing, and then something called the Lazarus effect. So first, definition of advanced disease. In order to study the utility of neoadjuvant therapy in this space, you really need to define the disease. We kind of know when we see it that this is advanced disease, but so this sort of disease that's involving the skin had 900 millicuries of radioactive iodine and multiple surgeries with CAT scans showing bulky disease extending to the mediastinum and with skin needing to be resected as part of the surgery. This is certainly advanced disease, but there are many different types of advanced disease. This is a 12-year-old with an MTC RET fusion-driven cancer with tracheal obstruction because of bulky region 6 lymphadenopathy. This is an aggressive pediatric cancer. This is a 77-year-old with hobnail variant differentiated cancer. That left lateral neck mass required a true radical neck dissection in order to excise all of that disease. Also, here is a 26-year-old female with a RET fusion-driven differentiated thyroid cancer. This was an 11-centimeter node. And so the definition of advanced cancer, I've just showed you a few different types, is really focused on this white paper written by ITOG and the Head and Neck Society in the U.S. With a multidisciplinary group of endocrinologists, medical oncologists, surgeons, basic scientists, and pathologists to help to define the different lenses that can be used to define invasive aggressive disease, advanced disease. You have structural or surgical definitions, like, for example, some of the patients that I showed you showing on axial scanning bulky disease. You can look at biochemically advanced disease with TG or calcitonin doubling times that are high. You can look at molecular definitions of BRAF and TERT mutations, for example, or a high mitotic count or tumor necrosis present on path report. So there are histologic and molecular definitions of advanced disease. This paper says that for all of those different definitions, you really want to get next generation sequencing so that you can really determine what are the driver mutations, so that you can determine what is the best treatment for that patient. For anaplastic carcinoma, there's a specific focused and rapid molecular screening that specifically focuses on the presence of BRAF mutation in anaplastic. And the reason we need to know this information, we need to have these definitions for advanced disease, we need to have these knowledge of the molecular drivers. We now have many druggable options available for the different genetic abnormalities in the leftmost column, and then in the third column, the drugs that are available that are specific or more focused option for the specific disease with the molecular signatures as described here. So really a more focused approach, a uniform definition of advanced disease, and then a molecular definition of the advanced disease so that treatment can be rendered. And we're lucky that thyroid cancer is really one of the highest solid tumors that has many druggable targets available. So let's look at the neoadjuvant therapy for advanced disease with that background. This is important because it occurs in up to 50% of differentiated thyroid cancers. The recurrent laryngeal nerve is involved in 50% nearly of cases. We know that we can identify by preoperative history exam and imaging patients who have advanced disease, and we can understand that this extrathyroidal disease is important because of the surgical complexity, surgical morbidity, and decreased quality of life that it is associated with for patients. There's limited information on R0, R1 rates for differentiated cancer without neoadjuvant therapy. There are older and newer studies, some shown here, that show the signal in this older literature is suggesting we don't do very well when we take patients untreated with neoadjuvant therapy with advanced disease to the operating room. So can we get better margins? Can we potentially even do less surgery to treat these patients? There is a signal for cytotoxic chemotherapy in the past used for DTC in a neoadjuvant setting, suggesting at least a signal that R0, R1 resections may be improved with the addition of this cytotoxic regimens prior to surgery. But now we have a tyrosine kinase inhibitor and more focused options for therapy. So how might that be helpful in advanced thyroid cancer? We know that lenvatinib given prior to cytoreductive nephrectomy is tolerated well and not associated with increased complications, and also there's utility for neoadjuvant therapy in pancreatic cancer. So let's look at can we think about neoadjuvant therapy before advanced cancer surgery. And so I want to look at a group of patients that we treated in both Sydney and at Harvard that we joined together. Marika Russell was the first author in this paper, and this is an accumulation of 2 centers' experience with neoadjuvant therapy. And these were the primary and secondary outcomes. And so these were 17 subjects with a range of histologies and a range of molecular alterations that were treated with neoadjuvant therapy. And here you can see the Skanke plot of MMM score. MMM score is a global composite score that relates to the degree of invasive disease. And you can see at presentation, then during neoadjuvant therapy in the middle, and then at surgery, a downshifting of the degree of invasive disease during neoadjuvant therapy leading to surgery. You can also, if you classify patients with invasive disease into 3 different classes of invasive disease, unresectable, severe invasion, and very severe and severe invasion, you can see also a downshifting during neoadjuvant therapy application to these patients prior to surgery. And you can look at this individually at cartilage, esophageal, and neural interfaces. So 65% of these patients underwent surgery for local clearance. And this is the waterfall plot looking at the tumor volume reduction in these patients through neoadjuvant therapy. We can see that look at the application specifically of lenvatinib in advanced DTC. So this is a 3-center study at Harvard, MSK, and MD Anderson. Lenvatinib is an agent that has a broad tyrosine kinase inhibition, including it has some VEGF activity, which can lead to fistula and bleeding. This is the pattern of inhibition that lenvatinib has as on the human kinome as compared to sorafenib. And this is really the idea of using this agent for neoadjuvant therapy is really based on the SELECT trial, but Dr. Martin Schlumberger used showing this is the protocol for that SELECT trial for distant metastatic disease. And this is the impressive result of lenvatinib showing it's very effective in causing overall response rate of 65% in patients with distant metastatic disease. It turns out also that shrinkage of volume of tumor in distant metastatic disease from the SELECT trial all occurred within the first 2 months of therapy. So this is very much in line with application in a neoadjuvant setting from shrinkage of tumor that is engendered by lenvatinib in the SELECT trial. There are also side effects, but only about 15% of patients required cessation of therapy. So overall, it tolerated well with a removal from the study of only 14%. So this led us to our clinical trial on neoadjuvant lenvatinib prior to advanced thyroid cancer surgery. This was a joint three-center trial at Harvard, at MD Anderson, and Memorial Sloan Kettering, and I thank my colleagues for working with us on this phase 2 study, neoadjuvant in the setting of patients presenting with advanced invasive thyroid cancer. All inclusion criteria are listed here. Patients were basically defined as deemed at risk for R2 resections, that is either nerve, muscle, cartilage, esophagus, or vessel. And patients received up to 6 cycles of lenvatinib prior to surgery and were restaged at the end of cycle 2, 4, and 6. Lenvatinib, given that it does have a VEGF activity, was given a washout period of 7 to 10 days prior to surgery. This is the schema for the study. Again, this is for adults with locally advanced DTC judged at risk for R2 resection. The primary endpoint is the rate at which we could achieve an R0, R1 resection, which is considered a success in the setting of DTC, and to evaluate the surgical morbidity and complexity score and to look at the overall best response radiographically prior to primary surgery, to look at these parameters both overall and in subsets of target interfaces, muscle, cartilage, esophagus, nerve, and major vessel. We also were looking for alteration in laryngeal function and also the safety profile of lenvatinib used in this neoadjuvant method. This is the MMM score. This is a score that we have made up with our colleagues at the Anderson and Memorial Sloan Kettering, and really is a listing of those things that may need to be resected surgery. And so a point score is assessed as to the amount of tissue that needs to be removed, its functional significance, and the surgical complexity involved in its resection, and the surgical morbidity of that resection. So this MMM score is really looking at, you get certain points saved, like as the arrow is indicating, if the strap muscles are resected, you get so many points because that's non-thyroid tissue that is resected. But if the nerve is resected, that you get more points because that's non-thyroid tissue that's removed, that's significant functional impact. If both nerves require resection, then that is, you get even more points because that is tremendously accelerated, advanced surgical morbidity from that resection. Similarly, if a long segment of trachea is removed, you get many points, and if the carotid artery needs to be resected, then you get significant points. And so this is a blended score looking at the anatomy of the invasion, the functional consequence of the tissues that are invaded, the surgical complexity and reconstruction complexity that's involved, and the patient morbidity associated with that resection. This is the eligibility criteria. We did not involve patients that were had past history of radiation therapy, carotid encasement, or frank tumor in the airway. The 28 patients were enrolled, average age 61 years. We had both 2/3 primary invasive disease and 1/3 recurrent invasive disease. And the majority had PTC invasive as the histology. The mean time on lenvatinib was about 5 cycles. Of the patients enrolled, 82% tolerated the neoadjuvant therapy and underwent surgery. These are the reasons for the 5 patients who did not undergo surgery. And the rate of surgery was quite similar, whether it was primary invasive disease, where 84% of patients underwent surgery, or recurrent invasive disease, where 78% underwent surgery. Of those patients who underwent surgery, the 82% of those enrolled in the study with advanced disease, 71% achieved an R0 or R1 resection. So we were very pleased with that rate of surgery and rate of favorable margin in patients presenting with advanced invasive DTC. This is the best overall response waterfall plot showing the response of tumor to neoadjuvant therapy prior to surgery. The MMM score, which I discussed previously, which is a composite score. First column, the first entry is the score at presentation. The second one is the MMM score after cycle 2. And then the third entry is the ultimate true MMM score based on the degree of surgery the patient underwent. And there was a significant decrease in this MMM score as the patient presented, underwent neoadjuvant therapy, and then underwent surgery. We are looking at not just R0, R1 resection overall, but we're parsing that out for the different potential R2 interface tissue types, including cartilage, muscle, nerve, and vessel. And so we are evaluating this material as we speak. The paper has yet to be written. An abstract of the results were presented at the ATA meeting, but the paper is still being written. But I want to share with you that at least for the potential R2 interface of the RLN, we had quite interesting results. We had 10 patients in the study who had a potential R2 interface at the RLN, judged by the surgeon based on laryngoscopy and axial imaging. And of those patients treated with neoadjuvant therapy prior to surgery, only 1 of those 10 patients required RLN resection. So we were very pleased that the RLN looks like kind of the poster child as responsive in terms of surgical result to shrinkage from neoadjuvant lenvatinib prior to surgery. The lenvatinib was tolerated well during neoadjuvant therapy, with the worst AE grade 3 was hypertension, and interestingly, despite its reputation as a multiple kinase inhibitor with VEGF activity, that we had no cases of fistula or bleeding during the neoadjuvant therapy, and no cases of fistula, bleeding, or delayed wound healing at surgery. So overall, quite favorable percentage of patients undergoing neoadjuvant therapy undergoing surgery, and 71% achieving what we consider successful margins for the DTC group, R0, R1. Just in terms of surgeons' feedback, it's the shrinkage that you see radiographically with preoperative treatment with lenvatinib is quite minimal. It's maybe about 10 or 15%, but the margin of the tumor becomes much less invasive and more discrete and nodular as a result of lenvatinib therapy, and we think that is the effect of the therapy causing the tumor to shrink back and having its leading edge being much less of a hostile margin at surgery because of the preoperative treatment. And again, it was tolerated well with no fistula or bleeding, despite its history of VEGF activity. Just to show you one patient treated with neoadjuvant lenvatinib, this is a 50-year-old male who presented with a radiographically detected mass that was adherent to the right inferior pole. It was judged to be inseparable for the longus colli muscle with T7 interaction and tracheal and esophageal infiltration, and therefore we felt also that the RLN was a R2 resection. We underwent core and NGS testing. These are the 6 fields that we use for management of patients with invasive disease. These are the 6 fields we feel are most important for the surgeon to understand each time they see such a patient, to make sure that that they know the global gestalt of the patient to optimally manage the patient each time the patient is seen. This is his initial set of scans, and you can see that mass has a blurry margin relative to trachea, esophagus, and prevertebral fascia. This is a mass that is adherent to the endosurface of the right thyroid lobe. And this is after treatment. You can see the mass is not dramatically shrunken, but the margin, the leading edge, is much more discrete, much more nodular, much more pushing. So we went ahead with surgery. The preoperative MMM score was 22. At the time of surgery, the actual MMM score was 2, so a favorable response in degree of surgery. And this is the R0 resection that was done. We did need, you can see the dotted line, the straight dotted line is the unaffected, uninvaded portion of the right RLM. The curved profile is the invaded section of the nerve that was seen at surgery, which required the nerve's resection. But the esophagus, the trachea, the larynx, and the prevertebral fascia were free. So to finish, I wanted to just review one very interesting bit of work that we've done relative to neoadjuvant therapy, and that is in patients who present with advanced disease. One common finding is vocal cord paralysis when they present. And we have found that there are some patients who, when presenting with vocal cord paralysis from invasive disease, actually have a reversal of the vocal cord paralysis with treatment of neoadjuvant therapy. So I'll just briefly discuss this. This is a series of 7 patients that were gleaned from 3 different centers who have been offering neoadjuvant therapy for 3 to 4 years. And so we found 7 patients who presented with invasive disease and vocal cord paralysis, then were treated with neoadjuvant therapy, then underwent surgery. And all this is the review of the patients. It's a variety of histologies, mainly anaplastic, 1 invasive PTC with a range of genetic alterations that are listed here. But all of these patients presented with vocal cord paralysis. And all 7 patients had a recovery of vocal cord paralysis during neoadjuvant therapy prior to surgery. The median time to return of vocal cord mobility was 3 months of neoadjuvant therapy. And of those 7 patients, all presenting with vocal cord paralysis, treated with neoadjuvant therapy, having an improvement or resolution of their vocal cord paralysis, only 1 patient required nerve resection. So quite a successful effect of neoadjuvant therapy, which expands the surgeon's options at surgery, having 1 nerve return its function. So we've spoken about advanced thyroid cancer, its definitions, and the options of neoadjuvant therapy, focusing on our experience both in Sydney and at Harvard on a retrospective series. And then we talked about the preliminary results from a clinical trial using neoadjuvant lenvatinib prior to advanced thyroid cancer surgery, lenvatinib being agnostic to the NGS testing, and so being useful for the large group of patients with invasive DTC who also fail to have any druggable finding on NGS testing. So we've talked about that, and I would like to end again thanking you all for coming to the conference and thanking my friend Abdul Karim again for his invitation. I would like to extend our invitation here at Harvard to the surgery of the thyroid and parathyroid glands, which is next November 20th and 21st in 2026. This will be our 30th anniversary course at Harvard. You can email me at this email address and we can put you on a list. The registration is not open just yet, but will open soon. It'll be a wonderful course, a 2-day course. And then also invite you all to look at this QR code for the our next meeting in the World Congress on Thyroid Cancer in June 23rd to the 26th in 2027 in London. And I would invite you all to that meeting as well. And this is a QR code that will bring you to the website to register as soon as registration is open. Thank you very much for your attention. This is Greg Randolph from Harvard Medical School.
Thank you, sir. Though it is the video presentation, thanks from our beloved Bangladesh Bond. Thanks to you from our conference room. Here in IIT Tezgathaga, I am Dr. Abdullah Mamun, Associate Professor, Mugda Medical College with you. In this morning session, feeling that it is a bright morning because here with us Professor Mazharul Shahin, sir, the running principal of Sir Solomon Medical College, and with me, my respected teacher, Professor Jihadullah sir. He was a director of this NIENT, and I passed my MS and take my MS degree by supervision of him in Sir Solomon Medical College. Really, I am grateful to him. And here also my former principal of Sir Solomon Medical College, Professor Abdullah sir, and he was my direct teacher of undergraduate as well as the postgraduate. And he was the former director and founder director of NIENT. Really, in good morning and bright morning, I am requesting the audience a big clap for the audience, my chairperson. I am with you for the next 1.5 hours. Now, our second presentation, my beloved teacher, Dehan Mahmood Hassan. He is the professor of BISS General Hospital, Bangladesh, Diabetic Association. I am also passed about more than 2 years with him in Narangan's 300-bed hospital, as well as I also direct student of him in Sir Solomon Medical College, and he was a consultant of Sir Solomon Medical College. I am requesting Dr. Dehan Mahmood Hassan sir here to present his session, Active Surveillance for Papillary Microcarcinoma in Bangladesh, Hurdle and Hope. Dehan Mahmood Hassan sir.
তারপরে স্লাইড দিয়ে স্লাইড সরাবো
Back.
Good morning, everybody. Assalamu alaikum. I am really delighted to be here in this wonderful meeting. And I am feeling lucky to be connected with friends and colleagues from home and abroad. My topic is active surveillance for papillary microcarcinoma in Bangladesh, Hurdle and Hope. From Randolph to micro, Hassan. These are my few affiliations with professional bodies, nationally and internationally. So I'm going to start with a case, a 65 years old man, no morbidity, no major health issues. Carotid ultrasonogram found an incidental thyroid nodule. Ultrasound report, a single 1.1 centimeter nodule, FNAC papillary thyroid carcinoma. So what may be the treatment plan? Treatment option, active surveillance, radiofrequency ablation, immediate surgery, any of the above, none of the above. If you choose none of the above, probably you are in a wrong meeting. And if you choose all of the above, probably the answer is correct. So thyroid treatment is still controversial. But we have more areas in common. And we must celebrate our controversy. Our controversy must not create a battleground among us. Rather, differences should be workbench of progress. Fortunately, this controversy is not like, hen fast or egg fast. And possibly this controversy will continue till our death. I will have to skip some slides because of time constraint. Then what is the problem? Problem is in last 3 decades, the incidence of thyroid carcinoma has increased very rapid. very exponentially because of increased detection of small papillary thyroid carcinoma. We are detecting more and more small cancers. We are detecting one variant, that is papillary variant, and we are detecting a small size, that is 1 to 2 centimeter size. We are not detecting much follicular, much medullary, much anaplastic. Many recent studies have revealed that papillary microcarcinoma equal or less than 1 centimeter has become about 50% of the thyroid cancer cases. But mortality remains stable. Is it something better? How to manage this huge workload? Overdiagnosis and overtreatment of small micropapillary carcinoma is a big challenge. So Professor Miyuchi and Professor Ito, they are from Kuma Hospital, and Professor Sigetani from Tokyo Hospital, they proposed in 1993, they proposed a clinical trial that is observation without immediate surgery. Because most papillary carcinoma remains small. Of course, some will grow. We have to find out which are the cases that will grow. So observation without immediate surgery is the answer. This is Professor Miyochi during our visit in Japan, and we are fortunate Professor Ito visited Bangladesh as a guest. So this trial later being called as active surveillance. What is active surveillance? Monitoring of intrathyroid papillary thyroid carcinoma without performing immediate surgery or other intervention until there are changes in tumor or patient preference or other issues that would result in intervention. So our lingo and our jargon is less is more. Delayed therapy, watchful waiting. Why active surveillance? Because we are treating many small tumors that we don't need to treat actually. Treatment delay does not adversely impact outcome. Risk of thyroid surgery is low, but it's not zero. So this presupposes two things. Delayed surgery is just as good as initial immediate surgical intervention. And whenever we start and offer our treatment during active surveillance period, result will be as good as initial approach. This is Japanese data. This is amazing data. They started with 1,235 patients. Look, the last line, 1,000 patients had no disease progression. And the first line, number of patients, after 10 years of they published their first presentation after 5 years. This is after 10 years data. After 10 years of follow-up, the tumor enlargement by 3 millimeter was only 8%. Lymph node metastasis is 3.8%. If a patient with papillary microcarcinoma, if we operate on the first day, the lymph node recurrence, lymph node metastasis is 5%. Age less than 50 showed tumor enlargement and more than 60, no tumor enlargement. This is really contrary to our normal belief, present day belief, that if old as a person is attacked by carcinoma, that is bad for him. 35%, 55 patients choose active surveillance and 45% choose immediate surgery. Why active surveillance? Because before 2015, the treatment of differential thyroid carcinoma was one size fits all, one hammer hits all. But after 2015, it is risk-based. It is on risk-based strategies. So, in 2015, American Thyroid Association has accepted the active surveillance for micropapillary carcinoma as a good alternative for immediate surgery as a standard of care. But they have put some points. The tumor should be a very low risk tumor without clinically evident metastasis or local invasion and no convincing bad cytology. High surgical risk because of comorbid conditions. Expected relatively short lifespan. Concurrent medical or surgical issues that need to be addressed prior to thyroid surgery. So key factors in decision making. Patient is, we prefer to select shoulder disease. But it's a new thing. He, included all ages. It's better. Ideal cases are above 50. Better cases are more than 50, more than 40. But we are not ready to include pediatric age groups. Anxiety. Anxiety is into twofold. Anxiety for surgery and anxiety for taking cancer in body. Which tumor? Size and location is very, very important. At the outset, the size cutoff was 1 centimeter. It's a trend. That in more size. It must be below 2 centimeters. 1 centimeter, 1.5 centimeter, and in now most centers, they do active surveillance on 2 centimeter nodules. And location. Location is very important. If it is subvascular, if it abuts to returning a nerve, or if it there is a chance of tracheal invasion, these cases are not good cases. When transition to surgery, medical team, we need experts, thyroid surgeon or endocrinologist and sonologist. Sonologist is very, very important. Sonologist has a very important role to play in active surveillance. And when transition to surgery, increase in volume by 50% in 3 years. The different study shows that it is 8 to 15%. And spread outside the lymph node. And the rate is less than 5%. However, it is a mistake. Request to stop surveillance. Patient might request to the surgeon or to the team to stop surveillance at any time. Follow-up plan. Follow-up plan is really flexible. 6 monthly for 1 or 2 years, and then yearly for 1 or 3 years, then after 2 or 3 years. I will have to skip. These are barriers of active surveillance. I will have to skip some slides because this is a pan-Canadian study. Bangladeshi perspective. That is my main focus. I'm a surgeon and I prefer doing surgery. And I do surgery with precision and perfection, with love and care. But we must do surgery on a proper patient for proper cause and up to proper extent. And a best surgeon knows when not to do surgery. And as a surgeon from Bangladesh, when I consider active surveillance, I must consider risk-benefit balance between immediate surgery and active surveillance. And as a surgeon from financial constrained country, we must consider economic consequences of clinical decision from patient and healthcare system of Bangladesh. This is the data from Japan and USA. 10 years, total cost of immediate surgery is 4.1 times higher than active surveillance. There are different studies. Quality of life seems better for physical features for active surveillance versus immediate surgery. Cancer, worry, and anxiety are controversial, but many studies shows it is less with active surveillance. So if we want to do active surveillance in our country, we have to think of 4 key issues. That is patient, provider, health system, and social level interventions. Patient, we have to assess our patients. Our patients, what is their income level, what is their expectation from the surgeon, what is their lifestyle, what is their education level, what is their anxiety level, how to relieve their anxiety. These are very important issues we have to address. And we have to use different languages. So look, it's not malignancy, it's suspicious. We are suspecting that you are having malignancy. Till we do surgery and till we do histopathology, we cannot say it's surgery. And delaying surgery is not, it's not going to harm to you. And shared decision making. Involve patient's relative, involves patient friends. So that because there are studies at the outset, 50% patients agree to do active surveillance, but when they go home, they meet their friends, family, come back and no, I'm no more interested in active surveillance. So not only patient, involve patient's friends, patient relatives, patient provider. It is very important because we are the people who will, provide this service. So what is our attitude and what is our belief and how far we are ready to provide active surveillance? That is very important. So I have made a plan to make a survey, and these are the questionnaires. Very within 2 months, I will conduct this survey, inshallah. So about health system, we have two kind of health system. This is health system is not like America, not like Japan, not like Italy. We have our public health system. Any patient, any people have access to any hospital, any government hospital. So lot of patients are there. Unfortunately, they are mostly poor. They don't have education level is not high. So sometimes difficult to arrange multidisciplinary meeting. Boss has gone to the examination room. Boss has gone for meeting. Really difficult to create a good multidisciplinary meeting in government setup, and sometimes difficult to get dates for periodic ultrasonogram, and difficult to get same ultrasonologist for the same patient in many times. Doctors are awfully busy, so it's difficult to allocate adequate time for the patients. In a private health system, there are good things as well bad things. So patient have to pay everything by his own. But advantage is that limited result. Advantage is that patient can choose any doctor, and the patient most of the hospitals have high-tech ultrasound machine, high-tech sonologist, very good sonologist, and dropout from follow-up is minimum or close to zero. Patients are mostly educated, patients are rich. Social level interactions, if we want to expand, we need social level interactions. Yes, it is possible in our country. So most studies are similar results. It's not that our study will be same, our result will be same, because of genetics, because of food habit, because of environment, all that. So we have to make a study plan by our own. I will request appeal to health, head neck surgery, head neck society, Ministry of Health, Medical University, and top ranking UT surgeons. Juniors. I will tell. Let's sit together. Let's formulate an idea. Let's formulate something that will be good for you, good for us, and we can start a structural program, not sporadic like P2 is doing, I am doing, Mamun is doing. It's not like that. So that after 10 years, we can publish a big data. What is our problem? What is the Asian problem? What is the difference between Asian and American problem or other developed countries? Conclusion. We hope that future AI and machine learning will be used to judge nature of tumors. FNA will be used for molecular diagnosis to identify tumors with rapid growth or metastasis potential, may improve the effectiveness and safety of active surveillance. Multidisciplinary decision to formulate the preferences and risk of individuals to choose between immediate surgery and active surveillance for papillary microcarcinoma management. Lastly, when things goes well under surface, we hardly realize the efforts and pains taken by a group of people. Me too, Dr. Mamun, my friend Professor Shafiullah, Professor Rifat, they put a lot of efforts to make this program a success, both electronically and physically. I thank them. And people on the dais, my teacher, Professor Abdullah, Professor Jahidul Alam, my friend, Principal Sasson Medical College, they are not only kings, they are the kingmakers. And you are the kings. So let's start together. Let's start together, and I think we'll be successful. So thank you for your kind attention, and I welcome you all to attend our Asia Pacific Society of Thyroid Surgery meetings. Please be a part of international program. Present your paper. Show your work. With these few words, I say you thank you. Thank you, Mr. Chairman.
Thank you very much. Thank you, Dayan Mahmood Hassan, sir, for a brilliant and nicely presentation on behalf of the active surveillance. Really, we have fear, a patient fear of cancer, and how we will reduce this anxiety of this patient is the very important point he highlighted here, because we are not only doctor, not physician, not surgeon, we are also the psychotherapist and psychologist also. That's why it's very important by surveillance we may reduce the fear of the patient for the cancer and cancer of the thyroid surgery. Thank you, Mohammed Hassan sir. Again, in this moment, Professor Mazul Shahin sir have a talk, please.
I want to congratulate Dr. Hassan for his idea of taking initiatives to have a study or to have a proposal on perspective of managing this sort of small thyroid tumors. Sometimes we find in as an incidental finding, which is regarded in books as incidentaloma. So in the books, what we are going in the present books, sometimes we go for ultrasound for any other purpose, but sometimes we go for CT scan for any other purpose. We find a small lesion in thyroid. Maybe it's a very 1 centimeter, 5 millimeter, or 1.5 centimeter. But the patient did not have any complaint with this issue. In last edition of Berry Lab, they mentioned that this sort of incidentaloma, if it is less than 1.5 centimeter, you need not to do anything. You just need not to do anything. If it is more than 1.5 centimeter, or there is a history of familial thyroid cancers, or there is history of radiation, you can go for a single FNC. If there is no malignancy in FNC, you do not do anything. If there is malignancy and the lesion is 1.5 centimeter or more, you do something. You explain it to the patient. Even you can go for a simple follow-up. Go for a simple follow-up, relieve the anxiety of the patients, and continue continue being in contact with the patient so that it doesn't go spread more. So I finally want to tell that you have the ability to perform a thyroid surgery, preserving the recurrent energy loss, preserving the parathyroid is not the only indication to go for a surgery. Thank you.
Thank you, sir. Again, point is anxiety, anxiety, anxiety. I think we will be all doctors, psychotherapists.
Thank you on behalf of the chairpersons. This very good morning. Today we have initial presentation, the video presentation, which was about the extreme and recurrent cases. And second presentation was minimum and conservative cases. So I appreciate regarding this targeted therapy of probability levatinib. Levatinib is very promising, and it is tyrosine receptor blocking agent. So it is giving hope to us that in case of inoperable or extensive disease, we can do something. Dr. Hassan has mentioned, and also our principal, now the time has come to conserve and to observe judicially the minimally invasive cancers. Thank you very much.
Okay, thank you, sir. Actually, our program is continuing. Here, now, a presentation from Siddhartha Shah. Siddhartha, please, consultant head and oncology surgeon, Jadis Cancer Hospital, Ahmedabad, Gujarat, India. His topic is evaluation of the thyroid nodule. Evaluation of thyroid nodule. Thank you, Mazul Shen, sir. Evaluation of thyroid nodule by Siddhartha. Next, our presentation from USA, Professor Ashok Shah. Now, Siddhartha.
Very good morning to all. So we had a brilliant talks in the morning from the experts and stalwarts. So we come back now to the basics. जमीन पे आ जाते हैं वापस. So this is a very common topic, and since we have a lot of youngsters in the crowd, and it is very important how we deal with the thyroid nodule. We start with our evaluation. There are a lot of concerns or maybe dilemmas of how do we actually start with our investigation. So I'll take you through this. what our goals of evaluation? Basically, to identify our clinically significant nodule, stratify it by clinical imaging and cytological risk factors, avoid unnecessary surgeries for benign nodules, and triage nodules for surveillance. We had a brilliant talk on surveillance. So let us take a case. That's a very good way of kind of discussion. So it's a 42-year female for the no complaints, presented with a clinically around 2 centimeter thyroid nodule. It's a hypothetical case. I'm just taking a hypothetical case. There are no other symptoms. So how will you proceed? Okay. So the first thing is, of course, it doesn't go anywhere. You have to thoroughly clinically evaluate, take the entire history, try to find out if there are any warning red flags for this thyroid nodule, whether this patient is having something which needs an urgent intervention or attention in terms of like change of voice, difficulty in swallowing, or some pain or firmness or any other nodules anywhere else in the neck. You do your Hopkins evaluation for a baseline vocal cord documentation. Next important step is how do you start your thyroid evaluation is to do a biochemical evaluation by doing a thyroid stimulating hormone. Now that is going to give you the roadmap of how to go further. So you do your thyroid stimulating hormone, and if it is low, normal, or high, there are the three options that you will get. So if it is low, that means you have to see that the thyroid hormones are very actively working in the body. That means the condition of hyperthyroidism. And by default, none of the nodules which are hyperthyroid are going to be malignant. That is a very clear rule. So then probably at that point you may refer this patient to an endocrinologist or a medical physician for management of the hyperthyroidism. But if it is normal or high, that means it's an hypothyroid state. You will have to further evaluate whether you need to do something for this patient or it can be left for active surveillance or follow-up. Now, if there is any clinical suspicion of by symptom-wise or history-wise, you may calcitonin for evaluating whether it is a medullary CA or not. Say, for example, our case had a normal TSH value of 1.4. How do we go further? Then you have to go for the morphological assessment. Why? It is a 2 centimeter nodule. You had a normal TSH. So now you are going ahead with the morphological assessment. That's a gold standard. Uniform reporting system is there. Dr. Suman is going to take care of the entire in-depth evaluation of this. I will just briefly run through it. It basically describes the echogenicity, margins, calcification, and shape. So it helps us to characterize this nodule and predict the risk of the nodule being malignant. And it also helps us to guide from which area of the nodule you need to take the biopsy or you should be biopsying. So this has been defined ATI criteria of thyroid nodules, which are suspicious, which are benign looking, or which needs attention. So if it is cystic, a thyroid nodule is cystic, you probably are dealing with benign condition. Probably you may end your evaluation at that point if the patient is not apprehensive. As you go in, the difference in the characteristic spongiform is still under benign condition, but the moment it starts giving a solid component, then probably your level of investigation enters. So the solid cystic, solid with irregular margins, and solid with more irregular, regular and irregular margins, they are the areas where you probably would like to intervene and investigate. And they kind of grade it, give some criteria on the basis of this, all the parameters, and they score it, and that is known as thyroid scoring. So they get 1, 2, 3, 4, 5, or 6, more than 6, more than 4 to 5, or something like that. So on the basis of this, they characterize the thyroid nodule. Say our thyroid nodule was thyroid 4. Now it meets the criteria. So here again ATS defined which nodule should be FNAC'd, which category of nodule should be FNAC'd. So they have given certain criteria based on the thyroid grading and the size of the nodule, correlating it, and the history of the patient. So this is the defined criteria. And say our patient had a thyroid nodule of 1.5 centimeter, the thyroid 4, so it becomes an eligible candidate for going to the further step of evaluating the histology of it. So we did ultrasound guided FNAC, and the result comes as Bethesda 3 or Bethesda 4. Now what? Okay. So then this is the Bethesda is the madam is going to take care of the entire Bethesda system of thyroid reporting. So these systems are basically to make a uniform evaluation of the findings of the pathologist so that it can be communicated grossly, like it is T and M staging. Anybody says T1, T2, and 0, you understand what do you mean by T1, T2, and 0. Similarly, if Bethesda 1, 2, 3, 4, 5, or 6, somebody somewhere else will also understand what we are talking about the thyroid nodule. So it's a uniform system, and 1, 2, 3, 4, 5, 6. So lower bottom 4, 5, and 6 they go fall in terms of malignant lesions, highly suspicious or suspicious. 3, 4 are the intermediate. 2 is benign, and 1 is non-diagnostic. So you might have to repeat, or you can follow up the patient. So on the basis of this, there are recommendations of how to go further. Okay. So now, if there is Bethesda 3 or 4, there is further evaluation that is possible whether you want this patient, because there is no clarity. Pathologists are not able to clearly define whether this nodule is benign or malignant, but there is a probability of this being a malignant also. And the patient is really apprehensive, very high profile, and you want to further find out whether this patient needs treatment or not. If you do the treatment, there is some complication, the patient might come and sue you. And if you don't do, and you said you leave behind, and if that turns out to be malignancy, you are again in a problem. So how do you answer this question? So again, our dear pathologists, they come in, help us here. So there is a molecular testing of this FNSC, which can be done. I'm not going to go in detail of this. Probably madam will try to cover, but there is a rule in and rule out test where the NGS, that is the genetic evaluation of the thyroid nodule, is done. There are panels which have been defined, and that there is a system of sequence of panels that being as a group. So they help us to rule out malignancy or rule in benign. And then similarly, you have this test done, different this thing. And so let us see our nodule was, one molecular test was benign. So then you can take a option or call of doing observation versus doing, if at all, cosmetic reason, you do hemithyroidectomy. So this is one way of starting the evaluation. Now say second case, a 55-year female with 2.5 centimeter nodule, ultrasound was Thyroid 5 irregular microcalcification, FNC is Bethesda 4. So we are dealing with a malignant thyroid lesion. What next? So what we need is, we need further information over and above ultrasound. We need to know the characteristic of the nodule, the relation with the thyroid surroundings, the important vital organs, great vessels. You need to understand whether there are nodes, any retrosternal extension. Is there any involvement of the surrounding structures like trachea, esophagus? So you need more cross-sectional imaging. So you will do CT scan more commonly. MRI is not a very preferred otherwise. That will help us to evaluate the thyroid nodule, evaluation of the neck, as well as evaluation of the thorax, because papillary CA will have a lung metastasis possibility. So you want further information about the extent and the spread of the disease. PET-CT not done as a routine evaluation of the thyroid, differentiated thyroid cancers, but when you are suspecting medullary CA, probably you might do to find out the distant spread. Then you do a MDT, and say for our example, so what is the algorithm? I don't know. I had a talk which was different. So in our case, probably we decided to do a hemithyroidectomy because it was a localized disease. There was no nodal metastasis, and finally it is papillary CA classical. So follow-up and surveillance is very important. For a benign condition, you may patient on 6 monthly follow-up, check the size of the, when we are actually doing an active surveillance, do it 6 monthly ultrasound, just monitor the size of the nodule. If there is more than 30% increment in the size, probably you might still reinvestigate if that patient needs any further evaluation. This is one slide on active surveillance. When you know the patient has a microcarcinoma and you want to actively serve, which are the ideal candidates you would like to keep patient on surveillance. So there are certain red flags: posteriorly located, medially located in TO group. These nodules are not ideal for active surveillance. This is one thing that you need to understand. Anything which is in the midline or eccentric or lower pole, probably they are candidates if you want to kind of do an active surveillance. And one small part on the incidentalomas. We don't always need to investigate incidentalomas, as Sir had already discussed about incidentalomas. There are also fixed criteria and guidelines given by ATA. How do you evaluate and investigate more than 1.5 centimeters? Only you would want to investigate with ultrasonic morphological features showing some abnormality. So finally, you always begin doing a TSH, which is a baseline biochemical evaluation, which will further help you find the further roadmap. Thank you.
Thank you, Siddharth. Really a good, brilliant guy. Is for guidance to the evaluation of the thyroid nodule from starting point to the surveillance as well as everything. Thanks. Okay, now our next session, anaplastic thyroid cancer, shifting paradigm and airway. Membrane Sloan Kettering Cancer Center. Now video will start. Later he will join with us from USA.
Good morning.
Good morning.
I'm very much lucky to say a few words about Professor Ashok Shah. He's a famous teachers and teachers of the teachers in the world. And he's one of the important members of the organizing committee of the World Thyroid Congress in United States. And there's one of the important words there's Professor Ashok Shah said, good physician should treat the disease and great physician treats the disease as well as the patient also. He was born in Bombay. He has got a lot of papers. He was in 1991-92. He was doing his training in the Tata Memorial Hospital. After Tata, he went to United States Memorial Sloan Kettering Center. He has got 600 publications, more than 400 papers. He is the teachers of teachers. Thank you very much, a patient, for hearing Professor Ashok Shah. Now they delivered the lectures.
Thank you, sir, for your evaluation of him. Okay, start, please.
Is one of the most complex subject in thyroid surgery, anaplastic thyroid cancer. Clearly, we have made a remarkable progress in last 10 years in the management of anaplastic thyroid cancer, especially related to the molecular analysis, and there is clearly a ray of hope for all of us, and mainly for our patients. I just want to give you a little idea about the epidemiology. The overall incidence of thyroid cancer is about 1.6% of all thyroid cancers. In the United States, we see almost 1,200 new cases. Unfortunately, the 5-year survival is 1 to 7%. That's a real problem. Majority of these patients die within a matter of 3 to 6 months. Amongst all the lethal human tumors, this is the worst of the worst. This is worse than the pancreatic cancer. And unfortunately, in the olden days, majority of the time, patients died of suffocation, which was extremely difficult for the patient and the family. If you look at the thyroid cancer, it's a continuum of diseases. At one end of the spectrum, we have the best human cancer, papillary thyroid carcinoma. Then comes the tall cell. Then comes the moderately differentiated, followed by poorly differentiated, and the worst of the worst is anaplastic thyroid cancer. And they have been able to figure out at one end of the spectrum there is classical PTC with a survival of 99%, while at the other end of the spectrum there is anaplastic thyroid cancer with a mortality of 99%. It's not the survival anymore. We also learned in last 10 years the radioactive iodine avidity goes down. However, the PET positivity goes up. So if you are dealing with a poorly differentiated or anaplastic thyroid cancer, the PET scan is of great help. Now, I just want to show you this complicated slide, but it is very important to understand the biology and the molecular analysis of anaplastic thyroid cancer. And here you will see a variety of different molecular analysis in differentiated thyroid cancer, where you get the RAS, the BRAF, which is present in about 60% of the patients, the RET fusion in follicular thyroid carcinoma, it's mainly RAS, and in Husserl cell carcinoma, again it is RAS. As you go on to from well differentiated to poorly differentiated and anaplastic thyroid cancer, clearly there is a loss of differentiation here. The majority of these may be BRAF and TERT positive. And you can see here the P53 is positive more than 60% of the patients. So this understanding of the progression of disease is very critical in the management of anaplastic thyroid cancer. Now we can target, based on the molecular analysis, a particular mutation, either RAS, BRAF, or TERT, and attack the tumor and get the best results. Whenever we talk about anaplastic thyroid cancer, there are many differential diagnoses. Poorly differentiated, very rarely the medullary thyroid carcinoma can be confused with anaplastic, lymphoma, melanoma, and sarcoma. They can be easily confused because these are all small cell tumors. And there it is very important that we have a dedicated and devoted pathologist who can distinguish. Now with the immunohistochemistry, it is not very difficult to distinguish what is a good thyroid cancer and what is a bad thyroid cancer. There are three different types of anaplastic thyroid cancers. Eno, which is giant and spindle cell anaplastic thyroid cancer, where the prognosis is extremely poor. Then comes the well-differentiated thyroid cancer transforming into anaplastic, which happens with over a period of time. If the patient has recurred, it is not uncommon to see the transformation from well-differentiated to anaplastic. And the last, which is very rare, a benign goiter transforming into anaplastic, that's pretty rare. It is quite likely there is a small element of well-differentiated thyroid cancer which has transformed into anaplastic. This is a classical example. There's a young lady who had best of her life. She went on a cruise 3 weeks before, came back with this big swelling with airway problem. And soon after I saw her, within a matter of an hour, she got intubated because she could not breathe because of the vocal cord paralysis and enormous compression on the neck. Remember, good judgment comes from experience. However, in a life, experience comes from bad judgment. So what are the issues that we're going to talk about? Making a correct diagnosis is very important. And there are different ways. The classical way is the fine needle biopsy. But in the olden days, the fine needle was not very easy to distinguish between different types of thyroid cancers. And now with the immunohistochemistry, with a good pathology and cytology, we can use the fine needle as a definitive diagnostic tool. In the olden days, we used to do core biopsy, very common. Open biopsy is extremely rarely used now because the tumor literally fungates through the skin and it is not easy. You have to take the patient to the operating room, airway problems. Liquid biopsy, I don't think we have big data on that, but that will be the future. Do the DNA analysis of the serum and see if you can make a diagnosis of anaplastic thyroid carcinoma. We'll talk about the types of anaplastic thyroid cancer, the role of surgery, where do we go with that, and then we'll talk a little more about the airway and what is the role of tracheostomy, because that is the current debatable subject. Now, if you look at the definition of the anaplastic thyroid cancer and the TNM staging, as you know very well, all the anaplastic thyroid cancers are stage 4 tumors. The stage 4A is quite rare, which is intrathyroidal anaplastic thyroid cancer. That happens only in 10% of the patients. Majority of them are having distant metastasis, what we call stage 4C tumors. Now, if you look at the survival, the overall survival is extremely low, but it is best in intrathyroidal tumors, the worst in tumors 4C, tumors with distant metastasis. Now, it is interesting to understand the development by the American Thyroid Association with the guidelines. This was the paper that was published in 2012. I happen to be one of the co-author in the national recommendations. There were 65 recommendations with 126 references. This changed quite a bit in 2017 to 2021. And you can see here, this is the second task force by the American Thyroid Association. I'm here. Now, very important, whenever there is a picture or the photograph to be taken, make sure you stand in the middle of the photograph. It's very important. You can see this was taken in 2017, and in 2021, it took about 4 years to publish these guidelines. It is an enormous work by a large number of people. You can see here a large number of people. There were 4 surgeons. I happen to be one of them with the recommendations from surgical point of view. There were 31 recommendations. For the first time, we came up with 16 good practice statements. And now you will see here there were 330 references compared to about 150 in the previous edition or previous version. So what are the steps in the management of anaplastic cancer? The first and the foremost is establish the diagnosis. The second, very important, engage the team. Whenever we see a patient with anaplastic cancer, there is a flurry of emails goes in the institution, and everybody knows there is a patient with anaplastic cancer coming in. The MD Anderson called this facilitating anaplastic thyroid cancer specialized treatment. That is, they call it fast STIM. At Memorial, we do the impacts. To the pathology department for impact analysis. It is integrated mutation profiling, actionable cancer targets. That's why we call this impact. Determine the extent of the disease. The surgeon's role is to evaluate extent of the disease. And more importantly, to make a decision, is there a role for surgery today or in the beginning? Majority of these patients come with advanced disease, locally advanced disease, or distant metastasis, and are not candidates for surgical intervention. Evaluate the surgical options, surgical decision making, the simple question to go or not to go. That's the decision that the surgeon has to make. And the last but not the least, as we did in both the anaplastic guideline studies, that you need to have the ethics department involved. And the hospice and end of life care is also very important. It is also important for the patient and the family to understand that this is an advanced disease. We don't have a definite modality to treat you, and the life expectations. I think that's very important. What are the patient and the family expectations? And now I'll show you in the next 20 minutes how we have made a progress with BRAF mutation. And again, I just wanted to show you how the clock moves very fast. Everybody gets involved, including the surgeon, the radiation oncologist, the medical oncologist, bioethics, everybody gets involved. What are the guidelines to accomplish key steps? Most important, initial staging is very important. And I like a CT scan with contrast. I think I can interpret it very well, and I understand that compared to MRI. The whole body PET scan is also very important, and people like to do the MRI of the brain to make sure there's no metastatic disease. Again, very important to do the mutational analysis with BRAF. The minute the patient comes into us, our institution, We do a repeat needle biopsy. By the time you get the slides from outside, it may take forever. We do a needle biopsy, FNA, and send it for immediate BRAF analysis with the immunohistochemistry. And we can get the answers within 24 hours, so we can start treating patients. The surgeon's role is also very critical to do a laryngoscopy and evaluate extent of the disease and the airway situation, what is happening with the airway and the vocal cords. Now, I just want to show you this recommendation 20 and recommendation 21. Whenever we deal with aggressive thyroid cancer, the first thing is to find out if it is BRAF mutated. You can literally divide the anaplastic thyroid cancer like the oropharynx between HPV and non-HPV. The same here. Is it BRAF positive? Is it BRAF negative? Because the recommendation and the treatment choices are quite different and very efficient. If it is BRAF positive patients, the survival has improved now from 3 months to average survival of 3 years or more. I just want to show you this example. This is a 60-year-old gentleman, had an open biopsy outside, which we will never do now, or rarely do it. You can see the tumor fungating through the skin, that there is a hematoma and a bloody leak. And you can see here, I just wanted to show you the CT scan, very extensive tumor, going right up to the innominate. You can see this is surgically incurable. You cannot resect this. And this is the needle biopsy. You can see here, actually this patient had an open biopsy outside, and these are the slides. You can see tumor necrosis and anaplastic thyroid cancer. So what did we do when the patient came to us? We started the patient on the BRAF related treatment, which is dabrafenib and trametinib. There was a mild elevation of the LFTs. Majority of the patients handled this very well. Obviously, you have to watch for the side effects and complications. Sometimes there is a stiffness of the knees, occasional cough, but nothing serious that we need to stop the treatment. We continued the treatment for 3 months, and I just want to show you, look at the CT scan pre-treatment and the post-treatment. Majority of the tumor has condensed or almost disappeared. I just want to show you another picture. You saw this picture before, and now there is hardly any tumor here. This is an ideal response to BRAF patients. And again, I think there is definitely a ray of hope and paradigm shift in management of anaplastic thyroid cancer. Subsequently, patient underwent total thyroidectomy and central compartment dissection. And what was interesting, we were able to preserve both the nerves. The parathyroid function was satisfactory, and the patient recovered from surgery very well. What is more interesting is, in this specimen, there was no residual anaplastic thyroid cancer. No necrotic tissue was seen. So this was the best result we saw in this patient. There was a small area of microcarcinoma. There were 3 positive nodes, most of which had papillary microcarcinoma. And this is the surgical pathology. You can see here, this is the residual papillary thyroid carcinoma. This patient did extremely well. You can see the surgical pathology here, and he's alive more than 3 years now. So this is clearly a definite advance in the management of anaplastic thyroid cancer. So what are the major surgical issues as a surgical group? Is it resectable? How do we do the airway management? Remember, nutritional support is very critical. The minute the patient walks in, you think, is he going to have trouble swallowing? And should I put the NG tube or do a gastrostomy now? Consideration of surgery after BRAF-directed treatment. There's always a debate whether excellent response with BRAF, should we operate or should we just send the patient for radiation therapy? MD Anderson gets a lot of credit. Their surgeon, Mark Zaffario, did a fantastic job in operating on these patients, and we have been following the same routine. Surgery after the complete response. Obviously, the hospice and ethics are very important. I wrote a paper many years back about the airway management in anaplastic carcinoma. This was a personal experience. Every time we did tracheostomy, it was life-threatening in the operating room, number one. And number two, the tumor grew through the tracheostomy opening. The tumor grew around, it bled, and the patient's life was miserable. And we sat down and started thinking, are we helping the patients or hurting the patients? Yes, we prolong the life by a few weeks or maybe a month, but with suffering of the patient. This is a classical example of the tumor growing all around the tracheostomy. You can't put the tracheostomy tube. Majority of the patients will die of airway distress. Uh, this is one of the nice paper from MD Anderson, upon which I had an opportunity to write editorial. This is a large single institutional experience. Patients were treated with neoadjuvant treatment, that dabrafenib and trametinib. Interestingly, they also add immunotherapy with that, pembrolizumab. We have not tried that at Memorial, but I think there is always a future. And I'll show you some data from MD Anderson showing excellent results with dabrafenib, trametinib, and pembro. You can use neolimumab. It is a matter of your practice. Patients showing only residual papillary carcinoma did the best in this group. And this is a classical example you can see here. The overall survival was very poor from 2000 to 2013. When they added the dabrafenib and trametinib, you can see the survival improved remarkably. Just wanted to show you the patients who underwent surgery after all this treatment, dabrafenib, trametinib, the BRAF-directed treatment, they did remarkably well. Take a look here, survival, compared to those who did not undergo surgery. Also, it is very interesting to notice the BRAF patient post dabrafenib and trametinib. You can see here within 3 to 5 months, majority of the patients responded extremely well. The patients who underwent surgery, if there is a residual anaplastic thyroid cancer, they did not do as well compared to those who had residual papillary thyroid carcinoma. Again, I just wanted to show you the neoadjuvant targeted therapy. Now, from 2017, you can see here the remarkable progress. Those before who did not have surgery or did not have the BRAF directed treatment did very poorly. At the end of 12 months, there was barely 25% survival. Now you can see here the survival goes up to 36 months. Remarkable progress. Clearly, with the immunotherapy, as I mentioned to you before, you can see here, this is again the data from MD Anderson. You can see here the survival is much better with immunotherapy as compared to those without immunotherapy. So what is the take-home message? The take-home message is BRAF status is very critical in these patients. Neoadjuvant targeted therapy is also very important. We also need to study a little more in details regarding the immunotherapy and its side effect. Is there a ray of light? Absolutely yes. I'm convinced that this is one disease where we have made a major progress in the last few years. Unfortunately, in the non-BRAF positive patients, they don't do very well. This is the patient with the non-BRAF, you can see here. However, with the unresectable tumor, the radiation therapy and chemotherapy, there is some response, not enough compared to BRAF positive patients. As I mentioned to you before, I had an opportunity to write an editorial on the paper from MD Anderson, and I titled it as Shifting Paradigms, a Ray of Hope. So what are basic philosophies of Ray of Hope? Number one, develop a multidisciplinary And we don't give appointment to these patients. They come to our clinic and we see them right away. Nobody will refuse to see them, our medical oncologist or our radiation therapist. Evaluation by all specialties concurrently. There is no like, one appointment, another appointment, the appointments go for a month. No. Surgical evaluation for a surgeon is very important about the airway. Confirmation of the diagnosis with repeat needle biopsy. Don't waste time. Appropriate imaging, which is a CT scan and a PET scan. Communication with the pathologist to do the BRAF studies within 24 hours. Targeted therapies, postoperative pathology is very important. And you need to talk to the pathologist. So when you send the specimen after second surgery, they need to know what is going on. And you develop your institutional protocol. Again, I want to repeat about the involvement of the ethics and the social service and what are the patient and the family expectations. Keep in mind, a good physician treats the disease, but the great physician treats the patient who has the disease. Treat the patient, not the disease itself. This is our multidisciplinary team with medical oncologists, radiation oncologists, and obviously the surgeon. I just want to conclude by saying, when you come to the operating room as an attending surgeon, what do? We adjust the light, we adjust the position of the patient, put on the new drapes, make a big incision, and what is ideally we like to do is complain about everything. That's one of my aphorism. Complain. That's what the surgeons do when they come to the operating room. During the difficult part of the operation, step out of the operating room for emergency phone call. If the tumor is stuck to the carotid artery, let the fellow handle it. Because if he makes a hole in the carotid, it is his problem, not your problem. When you don't know what to do in the operating room, use irrigation. When you don't know what to do in the ICU, use steroids. Thank you very much. Appreciate your attention, and I'll be happy to answer any questions. Thank you.
Okay.
Thank you, sir. Thank you for your great uh, talk, great physician, Professor Ashok Shah. You sir. We are highly appreciate your time. We feel great honor, sir. This was our outstanding presentation, sir. You people always love to do at go bed at 8 p.m. Although New York time is almost 11 p.m. Thank you, sir. Thank you. If
No
you
problem.
have any questions, sir, please, Abdullah sir or Jai
If there
sir.
is any question, happy to answer.
Professor Dr. Lubna Mariam, Associate Professor Radiation Oncology. You have a question to you, sir.
Yes, sir.
Sir, it was overwhelming to have you with us. So just one question. You have shown the study with BRAF indicated treatment with targeted therapy plus immunotherapy. But the overall survival is almost the same because it's down, straight down the same line. They goes the same line. So is it the immunotherapy or it is the yeah, what is the
It, uh, Anderson uses immunotherapy, either Pembro or Limumab. Morial don't use it. Medical oncologists are convinced that dabrafenib and dabrafenib is quite satisfactory and the results are excellent. So one thing I just want to point out that the survival curve has improved remarkably. The patient that I showed you with the tumor fungating through the skin, normally in the old days would be dead within 3 to 4 months. And that's what we used to do to the family. Your survival is very small. Go, go home, at home, or get admitted to the hospice and wish for the best. Now, if it is BRAF positive, our average survival is more than 2 years. And that's why I mentioned in the beginning, this is a remarkable progress.
Sir, thank you, sir. Uh, at least at this moment, we people always think about anaplastic carcinoma, that is survival rate is only 4 or 5 months or 6 months. Okay, when you diagnose the anaplastic carcinoma, we people advise that patient go home, take good food, and we will try to explain all his or her relatives. But after your lecture, we will you show a new ray of hope. Thank you, sir. Thank you, sir.
Absolutely. I think I'm convinced in my heart that the BRAF positive anaplastic cancers do remarkably well. And don't be scared with them. Uh, I think what has changed is don't see patients dying of airway problem now. There is a big difference. And I think this is commendable for the best quality of life.
Hello. Thank you, sir. This is Colonel Azad from Bangladesh. Could you remember me, sir? The last in August, I was with you in Memorial Sloan Catering. I enjoyed your surgery. So today we enjoyed your lecture as usual. You are our hero. Thank you so much. One small tips for our so many trainees and postgraduate trainees over here. During coming with the big, huge thyroid with anaplastic thyroid cancer, it's a great issue for doing emergency tracheostomy. Can you give some tips to
Yeah.
rescue the life of the patient so that we should not leave the life, we should not rescue, we could rescue the life of the patients. Your long journey of experience, can you give us some small tips to tricks and tips to rescue the life, how to do the manage and how to do the tracheostomy, especially these types of patient? After that, we'll sit together to save the life for surgery or neoadjuvant chemotherapy, whatever may be. Thank you, sir.
Great questions. I remember you very distinctly. You spent some time with us and enjoyed having you. And I enjoyed Karim. He has been with us before and see him in all the meetings. So very appreciative. Let me make it very simple about airway. There was a time when tracheostomy was a common practice for anaplastic throat cancer. We realized soon, and that's why I wrote a paper some 15 years back, the role of tracheostomy in air with the airway distress. Now, what happens is when you do tracheostomy on these patients, tumor fungates through the tracheostomy hole. It is bleeding. The tube comes out. You can't get the tube in, and they suffer. So the question is: are we prolonging the life, or are we prolonging the suffering? And we concluded that I think in majority of the patients we are prolonging the suffering. However, let's say the patient that I showed you, she came on Friday night. Within an hour, she was intubated. Now, what are you going to let her die? The family is not prepared. They want something to be done. So, those are patients we do the tracheostomy to make sure they live a reasonable amount of time with family. Now, that is more hypothetical. There were we had a lot of debates at Memorial. Dr. Spiro, one of our champions in anaplastic blood cancer, was furious if we would do the tracheostomy on anaplastic blood cancer. Now we do it very rarely. If the occasionally, if it is BRAF positive, you can intubate the patient and start the treatment, and you may be able to extubate the patient within a week or so. Now, if you decide to do the tracheostomy, bring these patients to the operating room intubated. Don't try to do the tracheostomy awake. You will write a death certificate. Bring them to the operating room and tell the family that we may lose the patient in the operating room during intubation or during tracheostomy. I may not be able to find the trachea. There is a huge tumor in front of the trachea. And if you really want to do something airway protection, do a cricothyrotomy. Because if you find thyroid cartilage, you can slide on it. Find thyroid cartilage, do cricothyrotomy. Try to do the real trachea. You will go through tumor, you will not find trachea, and it will be a very difficult situation in the operating room. You can't find trachea and the tube in. So do the tracheostomy after intubation. Have confidence of your anesthesiologist to do after intubation or awaken put patient to sleep and do a standard intubation. If the anesthesiologist is very scared, do a fiber optic intubation.
2016 with Nina Nawatri of Indonesia. I have
Yes,
two questions, sir. Number one, uh, do you think there will be some difference after publishing 8825 treatment with RAIR, RAIR, with anaplastic? Number one. Number two, in our scenario like Bangladesh, before starting treatment of anaplastic carcinoma, a lot of sequence to follow, like BRAF testing, before that like RAI negative, etc., etc. A lot of time will take, but by this time, patient will deteriorate. So, in our scenario, what is your suggestion to do?
If you talk to your pathologist, they will be able to do immunohistochemistry on a fine needle biopsy in 4 to 48 hours. Talk to your pathologist. Tell them, when you do the immunohistochemistry, it is very simple. The simple technique of immunohistochemistry. That's not the most ideal. The ideal will be FISH and IDELA. But if you do the immunohistochemistry, the concordance is very high. So that is number one. The number two, your question about the 2025 guidelines. I think the 2025 guidelines adhere to the biology of thyroid cancer. For memorial people, this is not new. These are the guidelines which we have been following past 50 years. They remain consistent, mainly surgical intervention. The radioactive iodine does not help much, even in well-differentiated thyroid cancer. So there is an enormous shift in United States to use less and less radioactive iodine. The place where it works best are the children with pulmonary metastasis, where radioactive iodine helps control the disease in the lung. Rest all the areas, it has very little effect. Also remember, there is always a problem or the side effects of radioactive iodine. Number one, chronic sialadenitis. I won't go in the details. Number two, which is very important, is slightly higher risk of radiation-related tumors, sarcomas, carotid tumor, parathyroid tumors, and leukemia. And once you get the equation, the role of radioactive iodine is very little in well-differentiated thyroid cancer. That's the main reason. The great question. You will have tough time from medical oncologists to agree with that. They are very particular because what they don't want to do is start the treatment empirically and then change the treatment or say, oh, the result. So it is not inappropriate to wait for 48 hours, get the report, and then start the treatment. You will have tough time from your medical oncologist. They would not agree. Believe me.
Sir, last question from our young star, Dr. Shaswell. Dedifferentiated thyroid cancer, it is common, not common. It is almost frequently we get in this Bangladesh. Dedifferentiated, that means patient get radioiodine ablation 3 times, 4 times, then recurrence. At that scenario, what you suggest?
Okay, so if the tumor has recurred and there is dedifferentiation, the most important aspect is, can I resect it surgically? That's the number one. So the surgeon's role is paramount. If the surgeon feels I cannot resect it because of the location of the tumor or adherence to the thyroid cartilage, then go for other treatments. And there are some newer treatments with targeted therapies based on molecular analysis or external radiation therapy. Don't discount external radiation therapy. And I was glad you do have a radiation oncologist in the room, and she was asking excellent questions. So talk to her. I'm sure she will be very happy in selected patients to radiate patients with recurrent dedifferentiated thyroid tumors.
Okay, sir, can you take another? Another issue, differentiated thyroid cancer. We have done total thyroidectomy, neck dissection. Patient is under follow-up, but
Yeah.
after 1 year or 2 year, patient developed a single lymph node. But EG is normal, thyroglobulin antibody is normal. Patient have no complaint. What your suggestion at this scenario, sir?
This is a great question. The reason it is a great question is this is the commonest area we see. Patient has total thyroidectomy, radioactive iodine, neck dissection. Now just sit down and think a little bit seriously. You've done a neck dissection, there are 10 positive nodes. Deep in your heart, you know there is a node I missed. And it is time that will make that node become apparent. So is this a recurrent disease? No. It is a persistent disease that we didn't appreciate at the first operation and was not cured by radioactive iodine. So what is our principle? Number one, do a good imaging studies, good ultrasound, and don't be shy. Do a cross-sectional imaging. The CT scan. As a surgeon, you really appreciate location of the tumor. What is it adherent to? Is it at level 2? Is it in the paratracheal area stuck to the trachea and esophagus? That's a different problem. And then make a decision, do I want to do the needle biopsy or not? In mind, the minute you do the needle biopsy and that is positive, the patient and family and his all the members of the team are going to push you to operate. Now, if the tumor is very small, below 1 centimeter, believe me, you cannot find it at the time of surgery. It has happened to several of our patients. We operated, couldn't find the disease. And probably we were pushed by the patient and the family to operate. So, what are our decisions about surgery? Number one, don't be in a rush to operate. Monitor the patient. Tell the patient, I will do another ultrasound in 3 months or 6 months. Tumor has not grown, there's no need to rush into surgery. Keep in mind, the second surgery does not mean you're going to cure the patient. That patient may need third surgery, may need fourth surgery. So rather than doing second, third, and fourth surgery, consolidate that to one surgery. Sometimes it is good for tumor to get little bigger so you can find it at the time of surgery.
Okay. Sir, is it better we would never advise FNSC at that scenario? We just wait, and if disease is progress, then you advise FNSC.
Yes, if the tumor is growing in size, yes, or it is more than 1.5 centimeter, I would advise, because if you don't do the needle biopsy, the patient will go to some other place and get a needle biopsy. Say, hey, Dr. Karim missed my thyroid cancer. No, you didn't miss it. You were waiting for the best time to intervene.
Thank you, sir. Thank you.
Thank you very
We
much.
have another question. Our foreign
Yeah,
faculty,
sure.
Dr. Siddhartha from India.
Good evening, sir.
Sure. Happy to.
There are two case scenarios that I would like to point. One is we have done a total thyroidectomy for a known CA thyroid and did a
Yeah.
neck dissection. And in one of that report, it turns out that patient has a mixed carcinoma, like it's a papillary component as well as an anaplastic component within the thyroid. Another incidence is a thyroidectomy done. The thyroid specimen is papillary CA, but the nodal feature has some anaplastic features. How would you kind of further treat these patients?
They are all treated as anaplastic surgery. Papillary carcinoma with a small focus plastic, it is to be considered as anaplastic third cancer. Now, the second scenario you gave, where the primary tumor is well differentiated and the metastatic node is anaplastic, is extremely rare. That can patients who had undergone surgery, another surgery, recurred, older patient, yes, that can happen. But the second area of well differentiated thyroid cancer, just disease to the lymph node anaplastic, is very rare. The first scenario that you said, there was an element of anaplastic throat cancer. Consider this as an anaplastic throat cancer. Do the BRAF analysis and treat it accordingly.
So, will you go for adjuvant iodine therapy or a radiation therapy?
Okay, so if it is BRAF positive, I would go for the newer targeted therapy, dabrafenib, trametinib, and pembro. If it is BRAF negative, then I would go for radiation therapy.
And any role of doing a PET at this stage for any evaluation?
Yeah, the PET scan, we don't use it as much. In the patient with anaplastic throat cancer or advanced medullary throat cancer, it gives you a sense of satisfaction. It has not gone to the bones or the lung or the liver. Because if it is a bone metastasis, then obviously the insulin will be sky high. You will be paying more attention to the systemic disease than primary neck disease.
And so last question, if it is T4A and 0 anaplastic, I mean,
Yeah.
it's a rare, maybe less common, but if you get this kind of a situation, T4A and 0 completely resected and neck, so how will you clinically follow up this patient?
Yes, I would still treat the patient as anaplastic throat cancer and with the BRAF analysis, dabrafenib, trametinib. If it is negative, I would give external radiation therapy. The risk of recurrence in that group, which is T4A, where you have surgically resected disease, is extremely high.
Okay. Thank you, sir.
Sure, my pleasure.
Sir, another philosophical question a bit. For thyroid surgery, especially for differentiated thyroid carcinoma,
Yeah.
less is more concept was prevailing, especially suggested by you. Nowadays, a section of patient, we cannot reaching any conclusion by doing so many investigations like genetic testing and treatment also very much costlier than previous. So in future, what is your thought? The previous less is more will exist or not?
Yes. So I'm going to make it very simple. Thyroid cancer, thyroid nodules, thyroid disease is a clinical problem. Clinical judgment counts. Good evaluation, a good examination of the patient with the two imaging studies which are very important. One is ultrasound. Remember, the ultrasound does not include only thyroid. It also includes the neck nodes and a cross-sectional imaging with a CT scan. That will give you the idea about the extent of the disease. If the tumor is limited one side of the thyroid, even up to 4 centimeters, I feel very comfortable doing a lobectomy. Mind, by doing a total thyroidectomy and radioactive iodine, it is very unlikely you will change the course of the biology of thyroid cancer in that patient. You feel good. I did a bigger operation. I gave radioactive iodine. But would that change the outcome of the to the patient? No, very unlikely. So we have remained consistent in doing a lobectomy in low risk and the low risk of the intermediate risk group. There is a nice paper published by our group, our endocrinologists. They have divided the intermediate risk group into the low intermediate and high intermediate. So in the low intermediate, which means tumor more than 4 centimeters, few positive nodes, one or two areas of vascular invasion, we are very comfortable monitoring the patient. What we have never put in the equation is the quality of life of this patient. Just think, it is your family member, 25-year-old girl, undergoing total thyroidectomy and be on thyroid medication for remaining 75 years of her life. And God forbid she gets into nerve problem or permanent hypoparathyroidism, which happens in 2 to 3% of the patients. We are hurting that patient more. So quality of life issue is very critical in this patient.
Thank you, sir.
Sir, we have lots of questions. I think
Anything I can help. I don't want to interrupt your program. But I'm happy to answer any question.
Thank you, sir. We have a last question, sir. Then our director, sir, will talk with you. Dr. Syed Farhan Ali Rajib, he also visited in next month, hopefully, visit in your center.
Thank you, sir. Thank you, sir. Good morning, sir. I'm Dr. Syed Farhan Ali Ajib. I'm coming to your institute next month as you have selected me for 1 month observership training, sir. I have a small question, sir. Is there any true or active role of external beam radiotherapy on differentiated thyroid cancer? Sometimes we used to face some differentiated thyroid cancer, which are very unresectable. Sometimes we, on the operative field, we found tumors is deeply invaded the esophagus and surrounding structures. And we excise the tumor, leaving microscopic tissues because some lack of reconstructive surgeons or anything else. So is there a true or active role of external beam radiotherapy?
I think there are very defined indications for external radiation therapy. Number one, unresected tumor. Two, get the best operation, left cross disease. Three, to the thyroid artery and paralaryngeal musculation, where the risk of recurrence may end total injectomy. Or deep tumors, or tumors which the surgeon feels very strongly when they recur, I won't be able to help the patient. Yes, we would definitely use radiation therapy. Now, in the olden days, a little bit more worried about radiation therapy because of complications of radiation therapy, such as esophagitis and vagus. Not very common now. They're targeted approach and RT or proton therapy. The risk complications of radiation are.
Thank you very much, sir. Thank you, sir. Our director, Professor Hassan Jafar Rifat, will talk.
Assalamu alaikum. I am Professor Hassan Jafar, the director of the National Institute of ENT, where this program is going on. On behalf of my institution, I'm so grateful to being with you, with all of our participants. And we are very grateful to, if we can minimum get some knowledge through your lecture and presentation, though I had that not scopes to come with you and work with you, but 2 days your lecture, we get a huge information and a huge medical sciences. Anyway, sir, we are very grateful, and I think this is a very odd time to awake a senior person like you with us, but we are very happy that you are in a very smiling face, very professional and very acoustic. Anyway, sir. So we are grateful, and I would like to express my heartfelt gratitude to you on behalf of our institution. And I would like to say everybody to give a very good and huge clap to sir. So thank you very much, sir. We hope we'll again, if we do some program here, and will we get you with us. Thank you, sir.
You have been very kind, always for academic was always available. Sir, it doesn't matter what time of the
Thank you.
yes, no problem.
Thank you. Thank you, sir. Sir, thank you. Best of luck, sir.
Okay, thank you, sir. It is a lovely and likely and very good and time passed with you this night. I am Dr. Abdullah Mamun, Associate Professor, Mugda Medical College. I have passed with you the time of 2018 aviation program in Kolkata, and also last Chennai program of FNOS program in February. Really, you are a very lively and loving person, Olaidu is us. Thank you very much for joining with us from the this audience, Second National Head Neck Cancer Thyroid Cancer Congress from Bangladesh. Thank you very much, sir.
Bye-bye. Bye. Good
Bye,
night.
sir. Assalamu alaikum. Good night, sir. We are really running short of time. Actually, we are enjoying a very lively session with Professor Ashok Shah. And now I am requesting Dr. Shuman Kumar. Shuman Kumar on role of imaging in thyroid ultrasonogram CT MRI diagnosis and follow-up. Is a radiologist from Department of Tata Memorial, Mumbai, India. Shuman Kumar, please.
Good morning, everyone. After such a lively lecture from Dr. Ashok Shah, I think it will be difficult for me to match up to him. I'll try to cover up. Okay, my topic is role of imaging in thyroid lesions, and after Dr. Siddharth has mentioned briefly about how to evaluate the ultrasound nodule, I'll explain about the role of imaging. So ultrasound is the primary imaging test done to evaluate thyroid nodule, and most of the thyroid nodules are incidentally found. Most of them are found for investigation of other pathologies. Like, for example, if you do a HRCT test and then the CT scan reports as incidentally found thyroid nodule to be correlated with the ultrasound. So what do you do with this ultrasound? What do you do with these nodules? And how you should proceed with them? Why is not CT not the ideal choice for evaluating thyroid nodule? So, thyroid cancer, differentiated thyroid cancer is the most common thyroid cancer. 90% of the thyroid cancers are differentiated, either papillary or follicular. And imaging is used mainly for primary detection and initial staging, for surgical planning, and to diagnose. So my talk is about description of the thyroid nodules and the current thyroid nodule scoring system and role of imaging in thyroid workup. So So I told you I'll talk about, sorry. Can I play this one? Okay. So this is a CT scan. I wanted to show the image, but on this CT, we are not able to identify this small thyroid nodule which is seen in the left lobe of thyroid. And the same one, if you see ultrasound, that is very clearly seen. If you see this nodule is approximately one centimeter, less than 1 centimeter. So ultrasound has a very good high resolution. So if at all, if you want to evaluate clinically palpable or not palpable thyroid nodule, ultrasound is the modality of choice, not the CT scan. So basic recommendation is and you have to evaluate the central compartment and the lateral compartment nodes in the ultrasound. So this is a curvilinear probe, which is not recommended, and the recommended probe is high frequency linear probe. And the patient position should be important, that the neck should be properly extended with the pillow under the shoulders to expose the neck. And then this is how the thyroid on ultrasound looks. This is the right lobe. These are the thyroid has a uniform ecos and that is hyperechoic as compared to the strap muscle adjacent to this one. This is the trachea, isthmus, right lobe, and the left lobe of thyroid. And these are the carotid arteries. So this is the middle to carotid and lateral to the trachea. So UST again is the key to identifying and stratifying. It has a sensitivity from 55 to 95%. And thyroid scoring system was introduced in 2009, and then it has been evolving over since then. And FNAC is the next modality of choice, where the sensitivity is 65 to 98%, and that it will be based on the expertise of the person who is doing the FNA and the cytologist. So, which nodule should do FNA? How to approach a multinodular goiter? So, it has evolved over a period of time. The Society of Radiologists in 2005, and thyroid classification has come in 2009, and then there's modification. And the latest is the ACR thyroid's white paper, based on which we'll stratify this nodule. These features, which are the features which we'll evaluate, is the composition, ecogenicity, shape, margins. We'll see each one of them. So it's difficult to remember all these points. So even in Tata, what we do is take a printout, laminate the paper, put it in front of us, and then see each feature, then see the scoring system. That is the easiest way to calculate. You see the composition, ecogenicity, shape, margin. Each one will see individually. So composition again, either cystic or spongiform or solid or cystic. Ecogenicity either hypoechoic or anechoic. Shape, whether it's taller than wider, or and margins, whether it's irregular, smooth, or extrathyroid extension. And ecogenic foci, whether they have punctate ecogenic foci, macro or micro calcifications. So if you see each has a one, you have to choose one point from each one. But the final one, the ecogenic foci, if at all, if the nodule has a macro calcification and punctate ecogenic foci, all these things you will add up. So based on the total score, it will be thyroids 1, 2, 3, or 4 or 5. So if you see thyroids 3 is 3 points, thyroids 4 is 4 to 6 points, and thyroids 5 is more than 7 points. So each feature we'll see individually. Composition, whether it is cystic or solid. So if you see, this is a solid nodule. This is predominantly solid nodule with a cystic component. So when do you say predominantly solid? If 5%, if the ATA ACR guideline says that if the cystic component is less than 5%, then it is predominantly solid. And this is a mixed solid cystic. So if you see, this is the cystic component, this is a solid component. And this is predominantly cystic, and this is completely cystic with common tail artifacts. So you can see the solid component, any solid nodule, even though if it is benign or malignant, we are not classifying it as, we'll just give the 2 points, and mixed solid cystic 1 point. And if FNA has to be done, it has to be done from the solid component of this. And once you call it as a spongiform nodule, what is spongiform? It is like a sponge, multiple small tiny cystic areas within. And once you classify it as a sponge, and that it will not go further. So that is the end of the evaluation. Spongiform nodule, there is no further points for anything else. So ecogenicity, again, whether ecogenicity is whether how it is the reflectivity. You will compare it with the adjacent thyroid gland, and you will say whether it's hyper to adjacent or iso or hypo. So if you see, this is hypoechoic. Hypo means dark. If it is darker than the adjacent thyroid gland, then that is hypoechoic. So the darker it is, the more suspicious it is. So the brighter it is, then the less suspicious. So you have a feature hyperechoic or isoechoic. So you need not worry that whether this is iso or hyper. So both has 1 point. So if you are not sure whether it's hyper or iso, you just give it 1 point, and then if it is hypoechoic, you will call it as you will give it 2 points, and if it is very hypoechoic, how do you classify this very hypoechoic? When you compare it with the strap muscles and it is darker than the strap muscles, then that is very hypoechoic. Shape, either it is wider than taller, it is 0, and it is taller than wider. When it is taller than wider, that is, this is wider than taller, and this is taller than wider. So when this is the anterior posterior, this is anterior and this is the posterior. When the nodule goes anterior to posterior, then that is taller than wider, and it has 3 points. That is a highly suspicious feature. So you can see another example where there is a taller than wider nodule, which is a suspicious feature. If it is round, what will it give? So if at all, if it is round, you can call it as wider than taller or not taller than wider. So it will still have a 0 points. Again, margins, if at all, if it is ill-defined or smooth, it is 0 points. So sometimes the nodule can be very ill-defined. You are not able to identify whether it is irregular or smooth. Then you give it 0. If it is well-defined, there is what to say that irregularity here. So that is again 0. Again, this is well defined, and if you see, these are lobulated margins, and if you can see this lobulations, then that is 2 points. And if it is extrathyroid extension, see, this is a the thyroid doesn't have a capsule, so the pseudo capsule is a bright line, and if it is breached, the nodule is going outside the thyroid. That is extrathyroid extension. So echogenic foci, again, echogenic foci, they have classified it, if it is more than 1 millimeter, that is a comatose artifact, which is a benign colloid feature. See, this is more than 1 meter, and this should be in cystic component. And if at all, if you see a very tiny echogenic foci within the solid component, those are punctate echogenic foci, which is a suspicious feature. This is a peripheral rim calcification, and because of the shadowing, you are not able to identify what is inside the nodule. So you will consider it as a solid nodule and give the points accordingly. So echogenic foci, like I said, they are punctate echogenic foci. Now we don't call it as microcalcification, but you call it as PEF, punctate echogenic foci, and this carries 3 points. See, if it is a solid nodule with multiple punctate echogenic foci, this is a highly suspicious nodule. And the calcification, there is no role, I mean, there is no points in the calcification, only it will help us whether it is a solid or it is a debris in a cystic component. So you can see there is a solid nodule with peripheral and central calcification. So this is the various categories which I have explained to you. And when do we do FNA? And these are examples where we give how this is how we score it. So it's better to keep a chart in front of you, just circle it, and then it's instead of giving a descriptive report, you ask for your radiologist that please tell me what is the score and how did you score it. And then you should be able to identify that if he calls it as a hyperechoic and do FNAC, then that's the wrong thing. So what is the size criteria for each one? I'll tell you. So if at all the previous ATA guidelines says low risk or low suspicious. For example, Thyroid 3 nodule, if it is more than 2.5 centimeters, FNAC is recommended. And if it is Thyroid 4 nodule, more than 1.5 centimeters, FNAC is required. And Thyroid 5 nodule, now even though you say Thyroid 5, if it is less than 1 centimeter, you need not do FNAC. Only if you are planning to do a surgery, then FNAC is recommended. If at all, if it is an active surveillance, then FNAC is not recommended according to ATI guidelines. The risk of malignancy is very high if it is solid and hypoechoic with multiple punctate echogenic foci. And the cystic component, as the cystic component increases, the risk becomes low. So FNAC categories are varies, but for 3, if it's a class 3 nodule, then more than 2.5 centimeters only the FNAC is recommended. So again, for a USG features of malignant node, like I said, it's a loss of fatty hilum and echogenic foci within necrosis, then that is again a suspicious node. How do we do FNAC? This is ultrasound guidance, and if at all, if you see the sensitivity of FNAC, it is 97 to specificity is 96%, and the recommended gauge is 25 gauge. The smaller the bore, the better the yield it is. So the wider the bore, the chances of blood going into the needle and causing a false negative, it will be there. So this is how we do FNAC. I'll show you. We have a ROSE technique and in-house cytologist who will be present at the site of FNAC. We remove the sample and give it to the cytologist. And FNAC, 3 passes can be done on the for FNAC. And there's a parallel versus perpendicular technique. I'll show you the techniques. So this is a parallel technique. This is parallel to the probe, where the complete needle is seen. But if the needle is located deep, then you can use a perpendicular technique only where the tip of the needle is seen. So the needle is perpendicular to the ultrasound beam. So aspiration and non-aspiration technique. Non-aspiration is recommended. We need not aspire. Negative suction is not required. So just put in a needle, pass 3 times, and then take it out. The sample will be there. With the capillary actions, you will get the cells. So technique is either whirling technique where you rotate the needle inside and then to and fro motion. So this is called the to and fro motion technique where you pass in the needle and then this is a again to and fro motion. This is a whirling technique where you just rotate needle. So you pass 2 times, 3 times and then whirl and then take it out. The sample will be adequate. So this is the needle gauge, and then studies have been done which is the best needle gauge. 25, the orange color spinal needle is better. And how we do the smear, we prepare the smear on site, and then the cytologist will be there who prepares the smear, and then fixes the smear. And there is one slide which is air dried, and then one is stained immediately, rapid staining, and seen under the microscope, and that's for the sample adequacy. And if the cytologist says that the sample is not accurate, we'll again the sample so that the negative test is very less. So when the cytologist says the sample is not adequate, we'll again reaspirate, and the cytologist write it as adequate sample and send it for analysis further. So for all the FNSs, we do this one. So rapid on-site examination. So again, targeting solid component is important, and the classification ma'am will tell regarding this one. And when do we use CT? When there is a frank thyroid extension, and then you are contemplating anaplastic thyroid or medicinal extension, then the CT will help us. And if you see, this is the ETE grades. The higher the ETE grade, then the chances of infiltration of the surrounding surface is high. So this is an example of the CT. This is the ultrasound. This is the MRI where MRI, if you are thinking that perivertebral fascia involvement is there, then the MRI is recommended. This is a large thyroid nodule, thyroid tumor, which is infiltrating the esophagus, mixing with the tracheoesophageal groove and perivertebral fascia. So perivertebral fascia involvement, we see of the trachea. You see, if it is this is shin 1 and this is shin 2 where the cartilage is involved, and shin 3 where it is extending up to the mucosa, and then shin 4 is a frank infiltration of the mucosa. So these are various examples of shin. So you have in the cross-sectional imaging, grading is important. The number of thyroid cartilages to be removed also will be based on the cross-sectional imaging. And nodal metastasis is we have to see lateral compartment, bilateral or unilateral, and central compartment. The mention of central compartment is also very important so that they will be addressed at the time of the surgery. Post-treatment imaging, again, this is a very difficult topic. You see fibrosis might appear as a nodule, and then you should be able to differentiate it. And this is a recurrent nodule in the thyroid bed. And this is a follow-up case of hemithyroidectomy on the right side, and the left lobe of thyroid has a nodule which was initially detected as benign, but on follow-up imaging you can see there is an increase in size which on FNAC proved to be suspicious. So follow-up of the opposite lobe of thyroid is also very important. And then thyroglossal duct is incidentally found. You also look for a carcinoma in the thyroglossal ducts. This is a thyroglossal duct MRI. And aberrant subclavian artery is very important for the surgical consideration when you are planning to do intubation or non-aberrant, non-recurrent laryngeal nerve. For this, subclavian artery should be there. And then our surgeons always ask for the course of the carotid, whether it's retropharyngeal or parapharyngeal. That also has to be mentioned. So the radiologist plays a very important role. And then you have to demand what you want. Otherwise, the radiology reports will always be suboptimal. So once you know that what is it you want and how you are, if at all, if the report says there is a thyroid nodule and FNS is suggested, you should ask what are the suspicious features based on which your FNS is recommended. So you should avoid unnecessary FNS and then only target those which are suspicious. Okay? Thank you.
Thyroid surgeon or head neck surgeon, we are very much cautious regarding the clearance of the neck nodes, especially central compartment and lateral compartment, if positive, because radioiodine is not working in this neck node. Only thyroid tissue is sensitive to radioiodine. You all knows. But sometimes CT scan, contrast CT scan cannot pick up the posteriorly locating nodes and tracheoesophageal nodes, and sometimes nodes located near the subclavian and communicated behind it.
Yes.
So what is your tips to pick up the nodes in the central compartment so that preoperatively we can uh, cautious so that paraoperative we can easily pick up these nodes? Definitely we are exploring, but there is some problem, morbidity, injury of the parathyroid gland and recurrent laryngeal nerve. So can you please give some tips?
So when there is extensive nodal burden, then the chances of central compartment clearance, you always plan a central compartment clearance. And on preoperative imaging, you don't see any suspicious nodes. Then most of the time in our institute, they call us for intraop ultrasound, where they open up the skin and then ask us to see if there is any central compartment node or not, and then they'll have a sampling of the central compartment, and then if they find anything suspicious or nothing, or they do a central compartment clearance, they ask us to see if everything is clear or not. So intraop ultrasound is a very important tool, and you will find lot more nodes than the preoperative ultrasound, because less than 5 millimeters is very difficult to pick up in a cross-sectional imaging. So intraop ultrasound, you have to develop your intraop ultrasound skills.
Thank you.
Thank you, Shuman Kumar. Good guidance and good things expressing by sonogram as well as CT scan. Now I am going to Dr. Ashwarya Patil. She is a pathologist and professor, Tata Memorial Center, and Mumbai, India. I am welcoming her to express the presentation. Thyroid efficacy and molecular pathology. Thyroid efficacy and molecular pathology.
Thank you very much
Sit
again.
down, please. Sit down, please.
After so many interesting and very informative lectures, my job is kind of easier. I'm just going to take it further with re-emphasis on certain points and few addition of new points. I'm going to talk on thyroid efficacy and molecular pathology. Believe me, trust me, I'm not going to talk of too much of pathology. I know I'm talking to surgeons. But first of all, thyroid FNAC, Dr. Suman has nicely explained you how we do FNAC thyroid in Tata Memorial Center. Most of our FNACs are done under ultrasound guidance, so make sure that we get minimum number of non-direct diagnostic or inadequate FNACs. So it's a procedure of choice for evaluation of thyroid nodule. It is rapid, cost-effective, reliable tool. It helps us to triage the patient, whether patient should go for surgery, whether patient should go to endocrinologist, or can be just active surveillance done in these patients. And accuracy of diagnosis, as earlier explained, it entirely depends on the skill of the radiologist or pathologist or surgeon who is performing FNAC, and skill of the experience and training of the pathologist who is interpreting it. Now, indications, again, not going to go into detail. Dr. Suman has explained it very nicely. Any suspicious nodule that is on imaging, besides that, clinically suspicious nodule. that is some family history of cancer, prior history of radiation, and any node, all FDG PET avid lesions, they can be aspirated. What we expect from surgeons and radiologists for FNAC is give us all this information, what is listed here. This is very, very essential. Let me tell you, because we in Tata, we are privileged, I always say that, because we have EMR, electronic medical record, we go to EMR, get all information, look at the radiology findings, look at the thyroid score. Because of this, if there is any discrepancy, we make sure that we put it in our report that if it is saying thyroid 5 and we are calling it Bethesda 2, which is benign, definitely this is not a representative FNAC. So that's why a pathologist needs all this information. It's not that we are going to make our decision or prepare our report based on all this information. We need this to make sure whether we are in line with that, whether it is discrepancy, and in that case, we can inform the radiologist and the surgeon that there is some kind of discrepancy, please reevaluate. And FNSC procedure, I will not go into the detail. Again, it is explained very nicely. I want to quickly talk about this rapid on-site evaluation rules, which all institute should develop that. We keep talking to pathologists also. This has definitely improved our yield and less number of non-specific or non-diagnostic FNACs, because there, as Dr. Suman explained, the radiologist is performing the FNAC, the cytotechnicians is there who is immediately preparing the smear, rapid staining, and cytotechnologist or a pathology resident is there to look at whether it is adequate or not. This is actually just if one or two passes are not giving you adequate FNA material, the radiologist can go for third pass. If first two passes are giving adequate material, no need to poke the patient again. And thus it reduces number of FNAC passes, a number of FNAC attempts, and number of ultimately cost to the patient. As I said, it involves radiologists, cytotechnologists, and pathology resident. This is our set of, we both at Tata Memorial Hospital, TMH and ACTREC. We have rapid on-site evaluation facility available. Now, we have done the FNAC, and when we get the FNAC in pathology laboratory, there are multiple challenges. We get this inadequate sample. Sometimes it is too hemorrhagic, too much of blood masking all the cellular details. Now, believe me, there are so many overlapping features in many thyroid tumors as well as benign thyroid conditions versus and neoplastic thyroid conditions. And the classification system now, it has evolved a lot, and to the point we may not be able to classify those tumors on FNAC alone. Smaller nodules again sometimes can pose a problem. So what should we do? Previously, I'm sure all of you must be getting this kind of reports. We cannot exclude malignancy and all those descriptive material. The cells are big, the nuclear big, there are grooves, and there is this and there is that. I'm sure from surgeon perspective, you must be saying, don't tell me all these things. To come to the point, tell me what it is and what should I do next. And that's what it was necessary. In pathology nowadays, it's not just description. At the end or at the top, you have to give an impression which is really relevant for the end user, that is clinician or oncologist. So what happened is 2007 to establish a comprehensive interdisciplinary information dialogue between all these specialties. They developed this Bethesda system, which included pathologists, radiologists, endocrinologists, and surgeon. All of them, they came together, they discussed for a period, and they developed this Bethesda system for reporting thyroid cytopathology. Now, remember, this is it's optional, but it is strongly recommended. And definitely, since we have been using it more than 10 years now, 10, 15 years almost, and it has improved our understanding a lot. And this is the book. Now it is third edition. It gives for a pathologist is an excellent book out to as a referral book. So what is TBSRTC or the Bethesda System of Reporting Thyroid Cytopathology? This is a summary document which includes indications, what is the training is required, credentialing, technique, terminologies and morphology criteria, that's for pathologists, ancillary studies, including immunohistochemistry and molecular techniques, that is again for pathologists, and post-FNSC options for testing and treatment, this is for clinicians or oncologists. So what are those categories? The categories, as you see here, the categories are 6, 1, 2, 3, 4, 5, 6. One is non-diagnostic, second is benign, third is area of undetermined significance, which means we really can't say whether it is neoplastic or non-neoplastic. Then follicular neoplasm is 4. Here I want to put an emphasis. We can't go beyond follicular neoplasm. We cannot differentiate between follicular adenoma versus follicular thyroid carcinoma because that requires tissue where we need to look for capsular and or vascular invasion. And number 5 is suspicious for malignancy. Number 6 is malignant. And in malignant, if possible, we try to give you what type of malignancy. It is papillary thyroid carcinoma. Is it anaplastic? Especially important to act on this patient immediately. Or sometimes suspect medullary thyroid carcinoma, so get serum calcitonin levels and so on. Now, how does it help us? And this table clearly gives us what is the risk of malignancy. If you see the central portion of the central column, each category has its own risk of malignancy. And this way, we really know how this Bethesda terminology is useful for us and what to do, usual management. You can see that non-diagnostic needs FNA, 9 needs follow-up, but from AUS onward, still suspicious of malignancy, available at each and every place. And then when to do lobectomy or near total thyroidectomy, diagnostic lobectomy, all these tips are given in depending on Bethesda type of the lesion. So ancillary studies, can we do that? Immunohistochemistry, very rarely can be, we are doing it, especially when we are suspecting medullary thyroid carcinoma. Again, we don't do it. We ask clinicians to get serum calcitonin levels, which is the easiest one, which is required in these cases. Now, molecular studies, it can be done. Now, in our part of world, molecular studies are not commonly used, I know, but sooner or later they will be done. We may not be able, our patient may not be able to use or afford this Afirma and Thyrosec version 3 and further versions. Definitely, in-house molecular tests and in Tata, we do have a small 7-gene panel, which is kind of affordable to many patients, and that can be done if required on FNSs. So let's go to molecular pathology. Here I want to explain the recent thyroid classification. You just, if you can take a look at those entities in the red square, you can see that there are benign tumors, low risk neoplasms, malignant neoplasms. Now, among the malignant neoplasms, these are follicular cell derived and C cell derived. What is the difference? The follicular cell derived thyroid carcinomas are maximum. They are almost more than 95%. What do they include? They include all of this papillary thyroid carcinoma, all the variants, follicular thyroid carcinomas, medullary thyroid carcinoma, poorly differentiated thyroid carcinoma, and anaplastic carcinoma. While C cell derived thyroid carcinomas, these are fewer, but these are medullary thyroid carcinoma. So if you look at the follicular cell derived tumors, you can see that there are 3 classes now based on the outcome. And now, how do we divide in pathology? We take a look at the nuclear features, mitosis, necrosis, and the histologic architecture of the tumor. Now, based on that, if you see first 3 entities, papillary thyroid carcinoma and most of its variants, follicular thyroid carcinoma and oncocytic carcinoma, which was previously called as Hardal cell carcinoma, they all of them have a favorable outcome. Now, there are 2 entities, poorly differentiated thyroid carcinoma, and another one is differentiated high-grade thyroid carcinoma, recently introduced in newer classification based on presence of necrosis and more mitosis. Now, these 2 entities have intermediate outcome. It is worse than differentiated ones, but better than anaplastic. And lastly is the anaplastic, which all of us know, it is poor outcome. Now, coming to the molecular alterations, we had excellent lectures earlier, and just I want to repeat the fact that there are driver mutations, and then there are further mutations which can lead to poor differentiation. If you the driver mutations, usually they involve MAPK pathway. There's most of them are mutually exclusive. BRAF you have heard so far many times, which is the commonest mutation. RAS is another mutation. Then you see red TC and other mutations in thyroid. I'm not going to go into the details of each and every mutation, but how these can be translated in our clinical practice. BRAF-like tumors. Just we can remember there are BRAF-like tumors and RAS-like tumors. This I'm talking about differentiated thyroid cancers. BRAF-like tumors, they are less differentiated. They include classical type and its variants including tall cell type, while RAS-like, these are follicular pattern tumor, follicular thyroid carcinoma, follicular variant of thyroid carcinoma. These are all RAS-like tumors. And these are the different features of both the types of tumors. Red PTC can be seen in the first group again. RAS mutations are infrequent in this. Now, the thing is that the BRAF type tumors, they frequently go to nodes and many times also distant metastasis, while the RAS type, they usually are associated with distant metastasis. Nodal metastasis is very, very rare. Medullary thyroid carcinoma, we know there are sporadic and germline mutations and red point mutations are there, red gain of function mutations are there. They are associated with MEN2A, MEN2B, and familial medullary thyroid carcinoma syndromes. Now, how molecular pathology can help us? First and most important, we heard about in the morning lecture and also later on, molecular pathology is very essential nowadays, especially in selected patient for targeted treatment. And here the tissue or FNSC can be submitted to NGS and targeted treatment. This is a small list definitely, but these are the agents that can be used. There are more and more agents being added. Now, do we need molecular testing for all? As Dr. Shah explained nicely, BRAF immunohistochemistry can be done in selected cases whenever required, and that is very good. But for rest of the targets, we need molecular testing, including NGS. Now, there are different platforms, Thyrosec, Afirma, Thygenex, and then Rosetta. All these are in the outside countries, Western countries. They are not really affordable to majority of our patients, but those who can afford, they can always avail this opportunity. I have given there is this positive predictive value and negative predictive values already included in this one. So what are this rule in and rule out tests? So before I end my talk, let me talk about the rule out test and rule in test. Rule out test is low molecular probability of cancer. That means you are thinking it's you don't want to avoid the surgery, and there the rule out test can be helpful. If it is positive, surgery can be avoided. That is very low molecular probability of cancer. Surgery can be avoided, and Afirma is one of these tests. Now, this can be done on FNSC material. Rule-in test has high molecular probability of cancer, where it tells you that possibility of cancer is more, and you can choose to operate this patient, especially when you have a dilemma whether to operate it or not. Now, this is just a table showing negative and positive predictive value of all these tests when they are performed in FNSs. Again, we have to have very good cellular yield, and this test should be available and affordable. And how they do when you have to decide about whether to go for surgery or not, you can see Thyrosec version 3 performs much better as compared to Afirma, but then each and every platform has its own positive and negative considerations. And this is at the end a last chart. You can see that for benign nodule on FNSE, you don't have to do anything. Observation surveillance is if it's enough. For category 3 and 4, AUS and FN, molecular testing, if available, can be done and go for surgical therapy, surgery or observation depending on the test. For frankly malignant in selected cases, targetable mutations can be identified by molecular testing. So my take-home message is FNS is quite rapid and cost-effective procedure, especially when we use it with the rapid onset evaluation. The adequacy is good. Bethesda system can be, after Bethesda terminology can be used, and it is strongly recommended for pathologists to use them. And molecular studies in selected patient can help us with treatment decision. Thank you very much. Again, our disease management group at TMH and ACTREC. This is Tata Memorial Hospital and ACTREC, and we welcome you to Mumbai in 2026 February. Please save the date. Evidence-based meeting. This is the largest meeting in head and neck and thyroid cancer. Thank you very much.
Ma'am, একটা short question.
Yeah. It is available. Like for us, we have ingrown panel. If you have to get thyroid and all, you have to send it out. Okay. And not many. Those who can afford, they can always send it. I think the surgeons can explain it better because we don't send it any better.
How much cost in India?
India for Tata, we have different categories of patient, and those that get a subsidized treatment still it costs almost 15 to 20,000 rupees. It is possible to do it. It's not in lakhs.
Thank you.
Thank you, madam. Thank you by her. Thank you, madam. By her lecture, we already know that from diagnosis, for the diagnosis purpose as well as for the surgical point of view, we have to go for the next gradually lecture. I am now requesting Dr. Syed Farhan Ali Rajib sir on the dais delivered his speech on the management of differentiated thyroid carcinoma, low risk to high risk. Dr. Farhan Ali Rajib sir.
Thank you, Dr. Mamun, for your nice introduction. Good morning, respected teachers and distinguished faculties from home and abroad, and my dear colleagues and juniors. Assalamu alaikum. I would like to bring my expression of gratitude to the organizers, especially Dr. Abdul Karim Mitu, for giving me the opportunity to be a part of this memorable head and neck conference. So today, actually, I will be talking on updated approach to the management of differentiated thyroid cancer, current guidelines and emerging evidence. So as we know, it's very difficult to discuss whole management procedures of differentiated thyroid cancer in a short period of time. So I'm going to start now. I'm going to skip some slides because this is the basic anatomy of the thyroid gland. Epidemiology of the thyroid cancers. The incidence basically is in UK and US incidence. There's 11 per 100,000 and 13.5 per 100,000. And 44,020 new cases of thyroid cancer in 2024. It is diagnosed in USA. This is the WHO pathological classification of deficient thyroid cancer, as my previous speaker has already shown it. That's low risk neoplasm, malignant neoplasm, that's follicular thyroid carcinoma, invasive encapsulated follicular variant papillary carcinoma, papillary thyroid carcinoma subtypes, and oncocytic carcinoma. This is the true incidence of thyroid cancers that we can show here. The papillary is 81% and follicular 10%, medullary is 5%, anaplastic 3, and lymphoma 1. So differentiated thyroid cancer occupied almost 90% of all the cancers, thyroid gland. So clinical manifestations, thyroid cancer sometimes presents with a solitary thyroid nodule, cervical lymphadenopathy, sometimes pain in the neck, or rapidly enlarged bladder. This slide has already shown by my previous speaker. That's when we find a suspected nodule. Then we advised for ultrasonography, and according to the sonographic features, then we do the FNSC, and then the FNSC is well-known Bethesda system. I'm coming forwards. What is actually differentiated thyroid cancer? Differentiated thyroid cancer consists of a group of malignant tumors derived from thyroid follicular cells. What are the investigations? So serum thyrotropin, that is the first investigation we should advise. If serum TSH is subnormal, radionuclide thyroid scan should be performed. If serum TSH is normal or elevated, a radionuclide scan should not be performed as the initial imaging evaluation. Sonography is already discussed, nicely explained by my previous speaker. And thyroid ultrasound reporting is now increasingly using thyroid imaging and reporting data system. And based on this system, thyroid 1 that is benign, thyroid 2 not suspicious, thyroid 3 mildly suspicious, thyroid 4 moderately suspicious, and thyroid 5 highly suspicious. We operate neck ultrasound to evaluate cervical lymph nodes in the central and lateral neck compartment, as well as for gross extrathyroidal extension is recommended for all patients undergoing surgery for malignant cytologic or molecular findings. When we suggest FNAC or when we advise FNAC, nodule greater than 1 centimeter in greater dimension with high suspicion sonographic pattern. For a nodule with an initial non-diagnostic cytology result, FNA should be repeated with ultrasound guidance and if available on-site cytologic evaluation. Ultrasound guided FNA of sonographically suspicious lymph nodes greater than 8 to 10 millimeter in the smallest diameter should be performed to confirm malignancy. This would change management. And what about neck imaging? It's already mentioned. The preoperative use of cross-sectional imaging, either CT or MRI, with intravenous contrast, is recommended as an adjunct to ultrasound for patients with clinical suspicions for advanced disease, including invasive primary tumor or clinically apparent multiple or Burkitt lymph nodes involvement. These are the sonological features. It's already described by my previous speaker, so going forward. This is the well-known Bethesda system, and based on this system, the risk of malignancy and user management. Then we categorize the risk group for differential thyroid cancer. These are the prognostic factors that age less than 55 and greater than 50, intermediate, low, intermediate, and high. Categorized in 3 categories: low, intermediate, and high, and less than 55 age and 55 or above and greater than 55. Gender, female and male. Male is now put in intermediate category. A size less than 4 centimeter and greater than 4 centimeter. And external intragranular, granular, low grade, high grade. Whether distant metastasis absence or present. This is the AJCC or UICC TNM staging, the 8th edition, as we know it. The T1A tumor less than 1 centimeter limited thyroid and T1 tumor greater than 1 or less than 2 centimeter limited to thyroid. T2, T3, T4. This is the N classification. Here we can see that N0, no evidence of regional lymph node metastasis. It is categorized in N0A and N0B, one or more cytological or histologically confirmed benign lymph nodes. Sometimes we encounter this sort of lymph nodes with differential thyroid cancer. And N0B, no radiological or clinical evidence of metastasis. This is the staging. So what's the basic difference between 7th and 8th classification? So age cutoff used for staging was increased from 45 to 55 years diagnosis. Extrathyroidal extension only on histological examination was removed from the definition of T3 disease, therefore has no impact either T category or overall stage. And N1 disease no longer upstage a patient to a stage 3 if the patient's age is less than 55 years at diagnosis. And N1 disease is stage 1 if age is greater than 55 years, and N1 disease is stage 2. And T3A is a new category for tumor greater than 4 centimeter confined to the thyroid gland, and T3B is a new category for tumor of any size demonstrating gross extrathyroidal extension into strap muscles, like a sternothyroid, sternohyoid, thyrohyoid, and so and so. And level 6 lymph nodes previously classified as lateral neck lymph nodes were reclassified as central neck lymph nodes. In differential thyroid cancer, the presence of distant metastasis in older patients is classified as a stage 4B disease rather than a stage 4C. So what were the treatment options differential thyroid cancer? Is it active surveillance, as my previous speaker, Professor Dano Hassan, has already mentioned and finally discussed about all the active surveillance process of ETC, then surgery, radioactive iodine, external beam radiotherapy, thyroxine therapy, or chemotherapy. So active surveillance may be offered as an appropriate management option for some patients with clinically T1A, N0, M0 papillary thyroid carcinomas, and shared clinical decision making between the patient and clinical team regarding risks and benefits of this approach is essential. And ultrasound guided percutaneous ablation, it is already mentioned, may be considered as an alternative to active surveillance or resection for CT1A, N0, M0 papillary thyroid carcinoma in selected patients. So these are the basic definitions of the surgery that we usually do. Total or hemothyroidectomy, near total thyroidectomy, or what is total thyroidectomy. So operative approach for a biopsy diagnosed for differentiated thyroid carcinoma. When resection is performed for patients with thyroid cancer less than 2 cm without gross extrathyroidal extension and without metastasis, the initial surgical procedure should be a thyroid lobectomy unless there are bilateral cancers or other indications to remove the contralateral lobe. For patients with low risk unilateral thyroid cancer greater than 2 cm, greater than 2 and less than 4 cm, thyroid lobectomy may be the preferred initial surgical treatment due to the significantly lower risk and side effects. However, the patient and treatment team may adopt total thyroidectomy to enable radioactive iodine administration and enhance follow-up based on disease features, suspicious contralateral nodularity, and or patient preference. For patients with thyroid cancer greater than 4 cm, cancer of any size with gross extrathyroidal extension or clinically apparent metastatic disease, the initial surgical procedure should include a total thyroidectomy with gross removal of all primary tumor and no dissection unless there are contraindication to this procedure. This is the actually the extent of thyroidectomy, a surgical procedure which is advised by HSCC, including the staging of the differential thyroid cancer. You can see the clinically T1, N0, M0 unilateral preferred surgical treatment is lobectomy, that is hemithyroidectomy, at least CT1, N0, M0, total thyroidectomy, and CT2, N0, M0 bilateral total thyroidectomy, and CT4, N1 or clinically metastasis 1, that is total thyroidectomy. So when we advise for thyroidectomy, considered to address persistent primary malignancy, facilitate radioactive iodine administration, and enhance follow-up based upon higher estimated risk of recurrence identified postoperatively, accounting for recurrent laryngeal nerve functions. And completion thyroidectomy for metastatic thyroid carcinoma may be considered based on indications like other histological types of differential thyroid cancer. And prophylactic central compartment lymph node dissection should not be performed for most small non-invasive clinically node-negative papillary thyroid carcinoma and for most follicular thyroid carcinoma. Prophylactic central compartment neck dissection may be considered in patients with papillary thyroid carcinoma and clinically uninvolved lymph nodes who have advanced primary tumors like T3 or T4, or for whom the information will be used and further steps in therapy. But this approach should be weighted against the risk as they evolve during thyroidectomy. And therapeutic central compartment, that is level 6 and upper level 7, neck dissection for patients with clinically involved central nodes should accompany thyroidectomy, clear disease from the central neck. And therapeutic central compartment lymph node dissection, with dissection of the ipsilateral central compartment lymph nodes is recommended to accompany lateral compartment neck dissection and thyroidectomy for patients with clinically involved lateral neck lymph nodes. So this is the risk stratification, that is dynamic risk stratification, defined by the American Thyroid Association in 2009. When we consider these are the low risk or high risk, thyroid carcinoma, no local or distant metastasis, all macroscopic tumor has been resected, no tumor invasion or local-regional tissues or structures. The tumor does not have aggressive histology like tall cell, Hobnell's variant, or columnar cell carcinoma. No vascular invasion, clinical N0 or less than 5 pathologic N1 micrometastasis, less than 0.2 centimeter in large dimension, intrathyroid encapsulated follicular variant of papillary thyroid cancers, intrathyroidal well-differentiated follicular thyroid cancer, vascular invasion and no or minimal vascular invasion, there is less than 4 foci. This is intermediate risk, microscopic invasion of tumor into the perithyroidal soft tissue, radioactive iodine avid metastasis foci in the neck on the first post-treatment whole body radioactive iodine scan, multifocal papillary microcarcinoma with extrathyroid extension and BRAF600E mutated. And high risks are microscopic invasion of tumor into the perithyroidal soft tissue, gross extrathyroidal extension, incomplete tumor resection, distant metastasis, postoperative serum thyroglobulin suggestive of distant metastasis, pathologic in one with metastatic lymph nodes greater than 3 centimeter in largest dimension, and follicular thyroid cancer with extensive vascular invasion. The remnant ablation, it's a matter of question. When we advise for remnant ablation, is not recommended routinely after total thyroidectomy for patients with low risk tumor. And remnant ablation, the radioactive iodine adjuvant therapy may be considered after total thyroidectomy in patients with low, intermediate, and intermediate high risk of recurrent differential thyroid carcinoma. And also it is recommended routinely after total thyroidectomy for patients with high risk DTC and patients with an initial diagnosis of DTC with distant metastasis. Radioactive iodine therapy is recommended routinely after total thyroidectomy. What should be the initial TSH goal after total thyroidectomy according to the risk stratification? Is if we do the lobectomy, the initial TSH goal should be the 0.5 to 2 microinternational urine, and initial therapy is total thyroidectomy. Then the initial TSH goal, if not stimulated PG, is not greater than 0.2 milligram per ml, then the maintenance TSH is 0.5 to 2. Initial therapy, total thyroidectomy, therapeutic neck dissection, and plus minus prophylactic central compartment neck dissection. Initial TSH goal is 0.1 to 0.5. So this is the take-home message that personalized care is increasingly emphasized for patients with differential thyroid cancer, and modern approaches use genetic information and careful risk assessment to determine who will benefit most from surgery, radioactive iodine treatment, and ongoing monitoring. So I'm going to, can I have 1 minute? Okay. So I'm going to show some short video clips that's the patient, 56 years old male. Actually, he presented to us with the swelling over the chest. And FNC revealed it's a metastatic carcinoma, thyroid. Then we excised the, we did total thyroidectomy, and with the help of thoracic surgeon, we excised the external part here. We can see it's only involved the sternum, body of the sternum. And after excision, here we can see the right lung, left lung, and the pleura. Then we actually requested my anesthetic colleagues to inflate the lung. This is the lung. This is the postoperative features. The thyroid is almost normal, and this is the metastatic portion and the postoperative videos of this patient. Another case is also a retrosternal goiter. Here we can see the retrosternal portion in contrast enhanced CT scan. Portion we can see the beating heart. Operative pictures. So interesting things. Both cases, the histological diagnosis was papillary microcarcinoma of the thyroid. Papillary microcarcinoma of the thyroid. So that doesn't mean the papillary microcarcinoma is not much good always. So thank you very much. Thank you all for question sharing.
Thank you, sir. Thank you. A nice presentation here by the rotational extension as well as the metastasis to lung or the chest mediastinal space. Thank you very much. We are actually back of 1 hour. Actually, we have to running short of time. Our next session will be start soon. Before that, we have another announce for the presentation. We have the 12th presentation, and there is a prize of free prizes, but all participants who join this in presentation will our organizing committee decided to prize also for them for encouraging and enthusiastic this type of activities, because presentation is an art of any congress or seminar or symposium. That's why this culture will be started and it will be continued for the next session on congress and conference also, for encouraging of the youngsters or who are interested to present this type of presentation. I am in this session request Professor Hassan Jabari Prasad to come on the dais for the purpose of the third presentation prize giving ceremony. I am mentioning the name. We have 12. We had 12 presentation. 12. Out of them, we have the prize of first, second, third, but we are decided to, the organizing committee decided to give the prize for all participants. There's been 12 persons will receive prizes from our respected teachers as well as our director, sir, Professor Hassan Zaborifat, Professor Jadulnam, Professor M. Abdullah, sir. Junaid Sharkar. Junaid Sharkar. Please come on the right, Junaid. Junaid, medical officer and INT. Now, Rashid Manjur. Rashid Manjur. Shahnawaz Khan. Okay, তুমি first, second, third দিয়ে দাও। Declaration করে দিচ্ছি। Shahnawaz Khan. Rajaul Karim, research officer NINT. Rajaul. Okay, Rajaul. Isolated lung amyloidosis, a rare clinical entity. Rajaul Karim. এটা শুভেচ্ছা স্মারক তার জন্য। Rajaul Karim. আমার এখানে নাম যা আছে। Junaid Sharkar. Outcome of tracheal sleeve resection, and end-to-end anastomosis for advanced thyroid carcinoma with full thickness tracheal invasion, a case series. United Sarkar. Next. Next, Dr. Salahuddin Al-Azad, Registrar NINT. Salahuddin Al-Azad, T-cell lymphoma, a non-healing ulcer in the nasopharyngeal region with a diagnostic dilemma. Dr. Salahuddin. Next, Shamaddoa, Borishal Medical College. Namsuddoa, 11-year-old girl with a nodular goiter and the ectopic thyroid tissue, a case report. Shamsuddoa, Borishal Medical College. Niaz Rahman, Assistant Registrar of Mugda Medical College, a 19-year-old male with thyroid hemiagenesis and ultrasonographic diagnosis. Dr. Niaz Rahman, Assistant Registrar, he is a DLO examinee also. Dr. Niaz Rahman. Afsana Akhtar, Dr. Afsana Akhtar, resident head and neck surgery division, Department of Bangladesh Medical University, Almastic MTC with Hashimoto's thyroiditis, the enigma of calcitonin negative cases. First, second, third. Now third, Rashid Manjur, Acha Tamid, Kamab Ras, on behalf of Rashid Manjur, reconstruction of heart palate defect due to synovial malignancies by nasolabial flaps. Tamid, on behalf of Rashid Manjur. Third, এখানে ছিল দুটা প্রেজেন্টেশন একই নামে একেএম মুশফিকুজ্জামান এফসিবিএস পার্ট ট্রেনিং এনআইএনটি bilateral carotid body tumor a diagnosis third prize AKM Mushfiqujaman FCBS Part 2 training. Both these two poster presentation was third prize. AKM Mushfiqujaman FCBS Part 2 training NIENT. Congratulations to you. Give a big hand please for encouraging of this our youngsters. Now second, Dr. Bodiul Alam Bhuiya, President NINT, reliable alternative of free flap reconstruction for maxillary, oral and oropharyngeal cancer surgery defect, a second prize. Second prize. Dr. Bodiul Alam Bhuiya, second prize. Now the first prize, Major Habiba Nasrin. Major Habiba Nasrin, voice rehabilitation outcome after total laryngectomy using Provox Vega voice prosthesis. A review of 98 patients of Department of HNS CMS Dhaka. It was 10 years of study. First prize. Mentor, year mentor, Azad Bhai with us. 10 years study, voice rehabilitation outcome. Thank you and congratulations, Major Habiba Nasrin. Thank you, sir. I am requesting Professor Jayadul Alam sir say something about this session. This is long session and race session. Definitely, sir.
Thank you very much. We were talking, I was talking with Abdullah that time and endeavor has changed everything. What we have done in our early days with thyroid surgery and now what you are doing with thyroid surgery is great difference. And I appreciate this session was very valuable. We have enjoyed it and we have earned a lot from various lecturers from abroad and from our own society. And I must thank everybody that they have attended very early and they are keeping their attendance and patience for long hearing. Thank you very much for giving us this opportunity to be in the dais with you again after a long time. I think Professor Abdullah will
Thank
say
you, sir.
something.
Now, Professor Abdullah, sir, founder director of NIENT, requesting you.
Good morning. Delighted to be here today in the morning. Passed a very quality time with all ENT surgeons. This is very interesting to see the ENT surgeons are organizing dedicated thyroid seminar. What is really amazing to me, when we started our career, it was very difficult to think that there will be a dedicated thyroid uh, clinic or thyroid seminar in future. Today, it is. I am also amazed seeing the that organizers arranged the seminar in such a way they connected overseas speaker and those who enlightened us with their uh, long experiences and this will be helpful for our young generation and this will guide the young generation to learn and practice the thyroid management. And this is all about. Thank you once again, everybody, for allowing me to come here and decide this session. Thank you very much.
Thank you very much, sir. As you present here to director, this definitely this session is enlightened and delighted session. I am requesting you, sir, to take the seat on the audience. In this physical situation, also you have come and enlightened this our program. Thank you very much. Now, this session is the next, and moderator by Dr. Rokun Bhai. That's been Mustafizur Rahman Rokun Bhai.
Our profound thanks go to our distinguished chairpersons and the moderator and speakers for their valuable
I am
contributions.
requesting Dr.
I
Mustafizur
would
Rahman
like
Rokun Bhai come on the podium and
I would like to request the honorable sirs to take their respective seats in the audience and enjoy the rest of the
I am
session.
requesting Rokun Bhai and.
We'll now move on to the next session, which will continue to explore more critical advanced topics in thyroid diseases. This session will be chaired by Professor Dr. A.F. Mohidin Khan sir, former head of Department ENT and Head Neck Surgery, Dhaka Medical College Hospital. Professor Dr. N.K. Sinha sir, former head of Department of ENT and Head Neck Surgery, Sylhet Osmani Medical College, and Dr. Muhammad Ashfaq Ahmed sir, Associate Professor of Chirong Medical College Hospital. And the moderation of this session will be done by Dr. Mustafizur Rahman Rokon sir, Associate Professor, Sir Solibullah Medical College and Midfoot Hospital. Now I'd like to invite respected chairpersons and moderator sirs to come up on the stage and continue the second sessions. For your kind attention, the tea break is already ongoing from 10:30 p.m. a.m. If anyone is still haven't taken the snacks, please continue. Have your tea break now. There will be not a separate tea break, so it's a working tea break. We are eagerly waiting for our chairpersons to take on the stage.
Permission of chair, I want to start this session. Please, sir. Today's presenter is Dr. Muhammad Saifuddin. Your topic is precise and space endocrine roadmap following thyroid surgery. Please, Dr. Muhammad Saifuddin, come to the dais and present your topics.
Assalamu alaikum and good morning to ladies and gentlemen. It's an honor for me to be present here and deliver a presentation on precision and peace endocrine roadmap following thyroid cancer surgery. So this is very important, especially for the ENT specialist, how to manage endocrine dysfunction, especially for having thyroid cancer surgery. I am Dr. M. Saifuddin, Associate Professor, Department of Endocrinology of Dhaka Medical College, also General Secretary, Bangladesh Endocrine Society. Three things are mostly composed regarding endocrine care. Number one is radioactive iodine therapy. Number two is how we should keep TSH in a patient after surgery. And number three is calcium management following surgery. So first of all, I discuss about role of radioactive iodine, patient preparation for the radioactive iodine, how to counsel and minimize risk of AVI side effect, classification and clinical response to surgery, appropriate degree of TSH suppression in patient treated with differentiated thyroid cancer, calcium management following thyroid cancer surgery or total thyroidectomy, and some take-home message. So this is the classification of thyroid cancer as all ENT consultant. So yeah, I think it's not needed to discuss with you regarding the very basic things of classification of thyroid cancers. So regarding the role of radioactive iodine, damage ablation is not recommended for patient with American thyroid association low risk cancer. AVI adjuvant therapy may be considered in patient with ATL low to intermediate or intermediate to high risk of different thyroid cancer. Radioactive iodine is recommended routinely for patient with American thyroid association high risk differentiated thyroid cancer. In patient where the diagnosis is differentiated thyroid cancer with distant metastasis, radioactive iodine is recommended routinely after 12 thyroid. So previously what we have practiced is all kind of patient coming with thyroid cancer go for radioiodine, but this is not the fact. In case of low risk, there is no need for radioiodine. In case of low to intermediate or intermediate to high, when there is suspicion, in that case, depending upon the clinical judgment of the physician. This is a coordinated decision by ENT specialist, endocrinologist, also nuclear medicine specialist to treat the patient whether they take iodine or not. So what is the dose regarding radioactive iodine therapy following total thyroidectomy of thyroid cancer? In case of low risk, usually radioactive iodine is not recommended, but if you decide to give it, dose is very minimum, 30 to 50 millicurie. Intermediate low or intermediate to high, dose is a bit higher. In case of high risk, there is dose is 100 to 150. When there is presence of distant metastasis, the dose will be very high, 100 to 200, treatment of non-disease and remnant or considered for ablation. So how you prepare a patient for radioactive iodine therapy? In patient with differentiated thyroid cancer, in whom radioactive iodine remnant ablation or adjuvant therapy is planned, preparation for recombinant TSH stimulation is prepared over thyroid hormone withdrawal. But in our country, recombinant TSH is not much available. We use very few patients that is very high priced, imported from Thailand or Singapore or India, very high patient, very limited patient also. Also, it is imported in the wrong way. So there is a chances that it may not be quite thin or there is a chances of discrepancy. So in that case, typically what is practiced in our clinical practice is withdrawal of the levothyroxine. In patient with differentiated thyroid cancer with any level of significant comorbidity that may preclude thyroid hormone withdrawal prior to radioactive iodine therapy, recombinant TSH preparation should be considered. So all high levels of ENT consultant and our teachers are here. So I request everyone to work together regarding the availability of recombinant TSH therapy, especially by any pharmaceuticals of our local industry should come with recombinant TSH therapy. But they're not interested because this is used in very limited number of patients. So they are not interested. They are interested more with the PPI and nothing else. So in thyroid hormone withdrawal is planned prior to radioactive iodine therapy. What we are doing in our clinical practice, we withdraw levothyroxine for 3 to 4 weeks. If it is withdrawn for more than 4 weeks, substitution of levothyroxine can be done, but this is also not available in our country. And ideal TSA should be more than 30 before giving radioactive iodine. In patient with non-distant metastasis, either levothyroxine withdrawal or recombinant TSA should be given. Low iodine diet, although not much practice in our country, a low iodine diet approximately 1 to 2 weeks should be in, especially in patient you are planning to give radioactive iodine therapy. And low iodine diet means restriction of iodine consumption to less than 50 microgram per day. Although low iodine diet is a bit cumbersome or unpalatable, but there are some risks of developing of the hyponatremia when you prescribe low iodine diet, especially in patients who are on the elderly or thyroid hormone withdrawal metastatic disease treated with thiazide diuretics or on low iodine diet for longer than 1 week. How to counsel and minimize risk of radioactive iodine therapy side effect for the cerebral and retinal gland? Patients should be informed that there is a chances of acute or chronic cerebral gland morbidity, retinal duct stenosis, potential risk of secondary malignancy. For prevention of this, general measures include hydration are recommended in patients with xerostomia or increased risk of dental caries. Discuss regarding preventive studies with healthcare professional. Surgical correction may be needed when there is nasoretinal outflow obstruction. Counseling regarding the risk of second primary malignancy after giving radioactive iodine, especially in patients with intermediate or high risk when dose of iodine is a bit higher. Second primary malignancy after radioactive iodine treatment, absolute increase in the risk is very minimum. Does not warrant additional screening for second primary malignancy. So this is a you should inform the patient, but this is not worth giving appropriate dose of radioactive iodine therapy to a patient of thyroid malignancy. Counseling regarding pregnancy, nursing, and gonadal function. Female patient. Previously, we advised the patient to avoid pregnancy for the 1 year, but according to the latest American Thyroid Association guideline that is published in August 2025, they recommend at least 6 months. But to be on the safe side, you can suggest the patient for 1 year, definitely. Radioactive iodine therapy should not be given to nursing female patient. Depending on the clinical situation, the therapy should be deferred until the patient stop breastfeeding or pumping for at least 3 months. A diagnostic iodine 131 scan can be performed in recently lactating women to detect any breast uptake that will help you deciding whether you want to give radioactive iodine in lactating women. Male patient should be informed that when the dose is much higher, that means more than 400 millicurie, there is a chances of the potential risk of infertility. In developed country, when the dose is very higher, they keep their sperm preserved for the patient. But in our country, although the facility is available, but a bit more expensive, and most of the patient cannot usually agree to do it definitely. But you should inform your patient that facility is available. You can keep your patient, especially when radioactive iodine dose is very much higher. Female patient receiving radioactive iodine therapy should be counseled that such therapy has not been shown to impact future partners. So in case of female, there is no ovarian impairment, but in case of male, there is a chances of sperm quality destruction or apparent abnormality, or there is testicular dysfunction. So regarding the classification of clinical response to surgery, according to the latest ATA guideline, excellent response, intermediate response, biochemical incomplete response, and structural incomplete. So as all our ENT professors here, so I'm not think it's going to be much. This is needed because I will show you how TSS should be targeted. So that depends upon this classification. So excellent response when the post-total thyroidectomy and neck dissection with radioactive iodine therapy, when non-stimulated thyroglobulin less than 0.2, stimulated thyroglobulin less than 1, and negative imaging. And when there is without radioactive iodine ablation, when thyroglobulin is less than 2.5, TSS should be kept within reference range. In case of intermediate, also TSS should be kept within reference range. But especially when there is biochemically incomplete response, that means there is higher TG or higher antibody level. In that case, TSS should be kept below normal references. Also, in case of structurally incomplete cases, you should keep TSS below target range. So, when the response is excellent, in that case, you should keep, or there is low risk, you are not giving radioactive iodine. In that case, TSS should be kept within normal limit. Normal range of TSS is 0.5 to 5. You just keep FT4 and TSS within target. But when there is biochemically incomplete response or structure incomplete response, only in those two kind of patient you should keep your TSS suppressed. So what's the appropriate degree of TSS suppression in patient treated with differential thyroid cancer? This is an individualized decision to initiate TSS suppression below the reference range recommended based on potential benefit and risk, recognizing the patient with high risk disease more likely to benefit from TSS suppression. Long-term TSS suppression is not suggested in case of low or intermediate risk disease when there is no evidence of biochemical or structural recurrence. Risk versus benefit of TSS suppression and TSS both should be evaluated with them, because there are some adverse effects you suppress TSS, especially there is a chances of the angina, ischemic heart disease, situation, cardiovascular mortality, increased pulses, and possible fracture, especially in case of postmenopausal women. So what we seen in our clinic is till now, yes, patient comes to us with a history of thyroid cancer, go for radioiodine and keep TSS very suppressed. This is our usual practice. in all kind of patient, there is no need of TSA suppression. TSA suppression needed only structurally incomplete or biochemically incomplete person. In this kind of patient, you should keep you TSA suppressed. But you should think the patient regarding the assessment of whether we will get more benefit by TSA suppression or keeping the TSS in the normal range. Whether there are any chances of age of patient, there is chances of chances of fibrillation, any kind of age of patient. You should clinically judge patient whether you should keep your TSS suppressed. So this is the individualized decision to be made on individual basis depending upon the risk factor of the patient. What is the target level for your specific TSS patient? So routine TSS suppression you should get out of it. Regarding calcium management following thyroid cancer surgery or total thyroidectomy, development of acute hypocalcemia after thyroid surgery lags behind before the decline in PTS7. The patient has been discharged before the hospital, before calcium reached a nadir, which may occur 24 to 72 hours after thyroid. So, just after thyroidectomy, it takes time. If you remove parathyroid, it takes time to parathyroid hormone to come to low. It may come low a bit after 24 to 72 hours, but due to advanced surgery, surgeon like to discharge the patient maybe within 1 or 2 days. So, patient may have hypoparathyroidism, but it may not be evident before the discharge of the patient. Therefore, it is important to anticipate the possibility of progressive hypocalcemia and should take necessary steps to institute and prevent development of hypocalcemia. Empirical prophylactic approach should be done in all settings because there is a doing PTS levels is not available in on all the hospitals. Also, if you send PTS, the report will comes after calcium on PTS level. So in case of mild to moderate hypoparathyroidism, when PTS is less than 15, calcium less than 8.5, ionized calcium less than 1.1, you should think of giving post-bulk calcium supplementation. When the patient is progressive hypoparathyroidism or symptomatic hypothyroidism or calcium less than 7, you should also check magnesium level. Especially after thyroid surgery or parathyroid surgery, it is good to add magnesium level. Magnesium is available in our country. 325 tablets you can give 2 or 3 times. Later, after checking magnesium level, you can discontinue. Otherwise, patient may develop hypocalcemia with tetany. The long-term management of hypoparathyroidism aim to maintain serum calcium within asymptomatic range, avoid significant hypocalcemia or hypercalcemia. In order to minimize the risk of symptoms, serum calcium should be maintained in no normal range, and serum phosphorus should be maintained no higher than upper. So calcium should be maintained in the normal range along with phosphate. With phosphate a bit upper end of normal, with calcium a bit lower end of normal. But this also depends upon the symptoms of the patient, what kind of symptom patient is complaining. So this is the dose recommended by American Thyroid Association in their management of operative hypothyroidism paper. It is published in 2018. Empirical prophylaxis, you should give calcium 2 or 3 times daily with calcitriol 0.25 or 0.5 mg 2 or 3 times daily, 2 times daily. In case of mild to moderate hypoparathyroidism, calcium carbonate along with calcitriol should be given. When there is progressive and symptomatic, there is you should give IV calcium 1 to 2 gram calcium gluconate followed by continuous IV infusion. Sometimes the tetany or hypocalcemia is so much evident that you should continue IV infusion of calcium, say for 5 or 10 ampoule of calcium gluconate in 1000 ml of normal saline or DA for 1 or 2 days, whether you should gradually taper and discontinue calcium, or usually you can maintain up to when you are confident that the patient parathyroid has been now successfully found. There is a term parathyroid staining. When the surgeon do the operation, parathyroid is handled, that is stunt, no hypothyroidism, but due to stunning, the patient develop hypocalcemia and tetany. But after 2-3 weeks, you will see that without calcium, patient maintain normal calcium level, also PTS become normal. So I have seen 3 things here regarding the endocrine roadmap: radioactive iodine, TSS suppression, and calcium replacement. So take home message from my today's presentation: a structured endocrine roadmap ensure continuity of care after thyroid cancer surgery. Risk adapted follow-up thyroglobulin and imaging enable early detection and intervention. TSS suppression should be individualized to balance cancer control and overall health. So this is very important regarding the TSS, especially in the setting of osteoporosis and atrial fibrillation. And molecular insight and precision approach refine prognostication and treatment decision. And long-term patient-centered follow-up promote both endocrine stability and quality of the care. So this is collaboration between the ENT surgeons and endocrinologists to keep the patient good endocrine health, especially after endocrine surgery. Thanks and gratitude to National Institute of ENT. Our sincere pleasure and thanks to all the ENT specialists on behalf of Bangladesh Endocrine Society. Special thanks to Professor Abdul Karim Mithu sir to invite me to deliver my presentation, and also to you, Director Hassan Jafari sir. And thank you everyone for your kind attention. Cancer is a word, not a sentence, and we should always work together with great empathy to thyroid cancer patients to make them a good and healthy life. Thank you so much for your kind attention. Thank you so much, sir.
There are many questions towards Dr. Saib because we have already time short. You take two questions, Dr. Dian Hassan sir and Dr. Noor Alam sir. Two questions, short questions.
Please.
Just I want to add few words.
Yes, yes, definitely, sir.
Nowadays, instead of doing parathyroid hormone level, we do intact parathyroid hormone level estimation. And if you do a intact parathyroid hormone level estimation after 24 hours, specificity and sensitivity is 98%. And again, if we get below 10, then only we can start calcium and vitamin D. Otherwise, you need not to give any, in the empirical, no need of, because you are putting unnecessary calcium on the patient. This is one. Second, regarding calcium, it's better to measure albumin corrected calcium than that of gross calcium, because gross calcium will not give you actual picture. So it's better if you can do free calcium, but unfortunately in Bangladesh there is no institution there do free calcium. Even in Harvard they don't do free calcium. So it's better to do a albumin corrected calcium. Thank you. Thank you for your.
Thank you, sir. Sir, যেটা বলবো, I definitely agree with sir. When your institute or your working place have the ability to do IPTH, you are 1,000 times ahead than other institute regarding the management of calcium. Because there is you just intraoperative IPTS also can be done. Also, just after surgery, you can send an IPTS and decide whether calcium supplementation should be given. In case of other than Dhaka city, I think in the district level, there are lots of ENT consultants are working in the district level, and patient will die there rather than coming to National Institute of ENT. Patient goes, sir, you are the boss. Next to God, you are the main thing, so you can do whatever. So this is very appropriate that when the facility of IPT is available, definitely. And ionized calcium is the best thing. That is not we are not doing. And albumin, always all kind of calcium should be corrected with the albumin. Also checking magnesium level. Thank you so much. I completely agree with you.
Thank you, Dr. Saifuddin. I have one question. If I, as an operating surgeon, if I confident enough, I have preserved parathyroid gland with vascular supply, is it necessary to prescribe empirical calcium or prophylactic calcium in the post-operative order?
And definitely, sir, that's very good thing. If the ENT consultant is confident on he has done or she has done total thyroidectomy and he is confident that parathyroid gland has not been handled. Definitely, in this case, if you just check in calcium and IPTS, after that you don't need to buckle. But you should inform the patient that whenever he develops any kind of hypocalcemia symptoms, he should immediately consult. Because a good number of patients, after doing surgery at Dhaka city, they will go to Gaibandha, Boishal, and the remote places. They can't come down. Usually, I don't give my phone numbers to the patient to emergency communication. So sometimes they may feel the challenge. But there is also another term, if parathyroid is staining, also in that case, there is a chances of the hypocalcemia.
Most of the cases, we see that the maximum surgeon prescribe post-operative calcium. Most of the cases, without measuring parathyroid hormone or calcium, is it justified?
If you check the American Thyroid Association recommendation, to be on the safe side, because if the patient develop acute hypocalcemia or tetany, it is sometimes very troublesome to manage it other than Dhaka city level. So in that case, if the surgeon a bit more defensive by adding calcium, I think it's not a harm to the patient.
Thank you, Dr. Saib. We'll arrange another scheduled program with you, 2 hours or 3 hours session in National Institute of ENT.
Thank you very much for Dr. Saifuddin for your brilliant and informative presentations. Our next presenter is Professor Dr. Muhammad Shiawak Chaudhary. Your topics is radioiodine resistant differentiated thyroid carcinoma, when to diagnose and treat, nuclear medicine approach. Please, Professor Dr. Shiawak Chaudhary, come to the dais and present your topics.
Thank you, everyone. So first of all, I would like to extend my sincere thanks and gratitude to the organizing committee, especially of NINT, especially Dr. Karim for giving me this opportunity to deliver this talk. So this whole session has been fantastic since morning, and we have seen the uh, uh, direction of thyroid cancer treatment. There has been a huge paradigm shift. So now the less is more. And I think the previous talk kind of covered much of the radioiodine things. So I will delve a little bit of basic and more into the new risk stratification of ATA, which I think has not been covered as extensively. So let's give the junior people in the audience an idea that radioiodine therapy is a very old thing. Started in 1930s, and the first treatment was not a thyroid cancer but a hyperthyroidism patient, and was given by Saul Hirsch, and he is known as father of theranostics. Now theranostics have gone beyond thyroid cancer, and we have outgrown it. But here the journey starts. So for the juniors, why iodine 131 is used. So, but stable iodine has a mass number of 127, right? So 131, it's like a higher mass number. That means it's like a more neutron rich, and it has therapy and the gamma emission used for imaging. So the previous speaker, I think, had mentioned something called iodine 123. So that's a pure gamma emitter, and it is used only for imaging. However, unfortunately, this iodine 123 is not available in India, and I doubt it is available in anywhere in the subcontinent because it requires a high energy cyclotron to produce, like a 30 MeV cyclotron. And there is only one that is in Kolkata, VECC, who are not producing it. So so this is basic mechanism, how radioiodine works. It gets trapped inside the cell, transported inside the cell via the NIS transporter and organified, and thus it gets trapped inside the cell and continues to irradiate. So that's why it's a good theranostic agent, because it has an intracellular trapping. And now the heading of my talk was radioiodine ablation. But we have to understand that radioiodine ablation is not a catch-all term. So there are three things we have to understand. One is remnant ablation, one is adjuvant therapy, and one is treatment for metastatic diseases. So I think radioiodine treatment or therapies would be a better term. The remnant ablation just means that the surgeon has operated, some residual microscopic thyroid tissue is left behind, doesn't mean it has any disease. So you are just ablating that. Why are you ablating that? Only reason for it is that the follow-up with thyroglobulin will make it much easier, because normal thyroid gland will also produce thyroglobulin hormone. So, but in the current era, with the highly sensitive TGSs or immunometric assays, second generation immunometric assays, which have a very sensitivity of less than 0.1. So in that assay, so the role of this indication of radioiodine therapy is going down. And next is the adjuvant therapy, which garners the most controversy, where adjuvant therapy is self-evident, microscopic disease left behind. So you are killing it, and you are basically reducing a theoretical risk of recurrence. And treatment for metastatic disease is self-evident. So after the 2015 ATA document that was published, there was a lot of controversy regarding iodine amongst endocrinologists, nuclear medicine alternative. So there was a collaborative document that was published by ETA, ATA, SNM, ENM. This called Martinique principle. So this kind of highlighted the role of radioiodine in different modalities. So here you can see the role of remnant ablation is only initial staging, and the post-therapy scan you can stage the disease and risk stratify. And rest are the other indications for the other two goals. So this was the 2015 risk stratification. I'll not go into detail, and much of the emphasis was given compared to 2009 risk stratification into the nodal staging. Some of the nodal staging went into higher risk, some of the nodal staging went into low risk. When in 2009, all the nodal staging was in the intermediate risk category. And actually, Dr. Randolph gave one of the fantastic talks. So one of his seminal paper that was published in 2000, I think 11, that kind of summarized all the lymph node data at that time, and from which ATA 2015 got this stratification. So now we are coming to the ATA 2025. So what happened? So now the things have changed quite a bit. So what happened between ATA 2015 and 2025? Main thing that happened was that AJCC changed, and AJCC 8th edition came out, and the WHO 2022 happened. So that absolutely changed the paradigm basically for thyroid diagnosis. So now we don't say that thyroid cancer, differentiated thyroid cancer are mainly two types like PTC and FTC. We will say that it has like three types, or PTC, or rather four types: PTC, FTC, or IFB PTC, and OTC. That is the oncocytic thyroid cancer. So I didn't think that I would dwell on this slide, but I think I will. So just going through the gross thing, so what I could find that what extra has happened is that intermediate risk category has been divided into a low intermediate and to a high intermediate based on focality of tumor, focality in the single lobe versus focality in bilateral lobes. Then margin, we never used to give that much importance in thyroid surgery, but they have said that posterior margin positivity, or R1, in that sense may confer a higher risk. And then 2022 WHO classification has been incorporated, where the BRAF-driven tumor, that PTC, which will normally come back with a neck nodal recurrence, has been given a separate category, and FTC and IFB PTC, which were previously being reported as PTC with follicular variant of PTC or something like that. So they have, which are RAS-driven tumors, which have been given a separate category. And these two other entities that Asawadi ma'am has very nicely delineated, PDTC and AGTC, that is the high-grade differential thyroid cancer, which have been put in the high-risk category. And the oncocytic carcinoma has been completely separated from FTC, which was earlier put under, plus Hurther cell carcinoma under FTC, and put into separate category. So I would just, and in FTC or IFB, PTC and OTC, the main thing that has happened that this terminologies like widely invasive and encapsulated angioinvasive and minimally invasive, these things from WHO 2022 they have adopted and put it. So widely invasive means like a lot of capsular invasion. Ashwari ma'am, you can correct me if I am saying anything wrong. And encapsulated angioinvasive can be, or minimally invasive, like minimal capsular invasion. Encapsulated angioinvasive, like capsule is more or less intact, but there is vascular invasion. That vascular invasion can be more than 4 or less than 4. If it is less than 4, then it is a low intermediate. If it is more than 4, then it is a high risk category. And similar thing has been done in oncocytic tumors as well. However, I would just like to point here, I have not put it in the PPT, but I would like to point out a little bit thing that regarding this oncocytic tumor and PDTC and AGDTC, that traditionally these tumors are considered RAI refractory or low avid. So oncocytic tumors, there have been a lot of conflicting study. One of the largest studies have been done by Dr. Bal from AIMS. So there he saw that 50-60% of the tumors can be RAI positive, and FDG positivity in those group of patients kind of heralded RAI negativity. So similarly, PDTC and AGTC, so they also 50-60% those can be positive. So there have been an analysis done where they saw that patients of PDTC or AGTC or high-grade follicular defined neoplasm who have undergone a R2 resection or a distal metastasis, when they underwent a RAI scan, they saw that patients who had a RAS mutation, more chance of them having RAI positivity compared to patients who have a BRAF mutation, or patients who have more follicular preserved architecture, they had a higher chance of RAI retention compared to patients who had a background tall cell architecture, which had more RAI negativity. So coming to ATA low risk, so I will just go through some of the seminal papers which has come out and made ATA low risk not amenable to RAI treatment. So one of the first, two papers, one was high-low and one is estimable first variant. So they divided these patients into 1:1:1, 4 groups, 30 millicurie versus 100 millicurie of RAI, and also thyroid hormone withdrawal versus RHTSH. So in all mostly low risk patients were taken, and they found that the modality of RAI ablation or RAI therapy, be it 30 millicurie, 100 millicurie, or the modality of TSH stimulation, didn't affect the RAI ablation success rate. Then they had a follow-up of those studies. So initial studies were just to look for 1 year ablation success rate, but they had follow-up studies between 5 years follow-up where they saw this between these two low iodine versus high iodine, there is 30 versus 100 millicurie. There is no significant difference in recurrence rates. So now these two other phase 3 trials have come. One is estimable 2, one is ION trial. ION trial is recently released, and both of them show that they are non-inferiority phase 3 trials. They showed that one arm was given 30 millicurie and one arm was given no treatment, and they showed that 30 no treatment, no RAI treatment is non-inferior to 30 millicurie. Here, one thing is important here is that in ION trial, the cases that were included were much more broader, and they had a 9% N1 and also PT3A. So in that trial, they saw that this group, this PT3A group, and the patient who are N1A, they had a much higher risk of recurrence, or I think 8% risk of recurrence in that trial. So more or less, we can conclude from this is a very high quality of evidence. In thyroid cancer, this kind of evidence generation we cannot think, because outcomes will come 10, 15 years later. So no, there is not much trial data. So we can conclude that RAI therapy is not indicated. Now coming to intermediate risk, which is the most controversial group. So there have been a lot of studies, but mostly retrospective or prospective cohort studies. Some show there is benefits, some show there is not benefit. So in this, there is this one particular systematic review where they show 11 retrospective studies were included, where 5 were intermediate risk. The 4 studies show OS benefit with RAI. One study failed to show any benefit. So one of the studies that I have shown here. So surprising that OS benefit was shown, but no disease-specific benefit was shown. So probably there was some heterogeneity between the both groups, some other confounding causes that may have led to OS benefit. We don't know. So just to understand, so this is my approach. So this approach will be personalized based on the patient that you are seeing, discussing with the patient. You can come to this approach, but this is the approach that we follow in TMH. So this high intermediate group, most of the cases I will consider for adjuvant RAI therapy, probably with 100 millicurie. And for the low intermediate, if it is FTC or IFB PTC, if there is vascular invasion, no matter if it is less than 4 foci, I will still consider adjuvant RAI therapy, probably with a lower dose, because we have seen such patients recurring down the line 3-5 years with skeletal metastasis and such. But low intermediate, you can, I think, observe this patient as well. And I think this can be a individualized decision. Or even if you are giving therapy, you can just give a remnant ablation of 30 millicurie. And high risk, so there is the quality of data, I won't say is very high, but there is pretty convincing evidence that adjuvant RAI may help, and especially in metastatic patients who are concentrating RAI. RAI is the best systemic treatment that you can give to those patients. So there has these few studies I have quoted. So most favorable outcome as seen in pulmonary micrometastasis is less than 2 mm. So basically in anatomical imaging, you are not seeing anything, but you are doing a scan. The scan lights up and there is high TG level. So these patients can virtually be cured with RAI. And even though bone metastasis cannot be cured, in vast majority of cases, mortality is decreased with RAI. So while treating patients with distant metastasis, few things need to be taken into account. If the bone metastasis is involving critical site like spine, skull with intracranial extension, then decompensative surgery or radiotherapy or angioembolization should be paired with RAI or given before RAI, or maybe sometimes even before surgery. And if you are giving RAI in this patient, steroid cover has to be given. And in single site oligometastasis metastatic patients, direct tumor, direct site directed treatment like a ablation or a metastaectomy is valid approach. In that case, you can still give RAI with more of an adjuvant intent. And obviously, concomitant use of bisphosphonate for skeletal metastasis should be considered. So this chart I think was shown in the previous talk also, but this is also very subjective. I think only data is there for remnant ablation, that 30 versus 100, but for other, how much activity you have to give, there is not much data. One phase 3 trial has been started in our institute where PN1A and 1B tumors are being randomized into two arms, 30 millicurie and 100 millicurie. We'll see if we can recruit enough patient and what is the outcome of that. So most of the treatment that we give follows the fixed dose approach. But certain centers do follow dosimetric approach. So there are two approaches, maximal safe dose method and lesion dosimetry method, but these are cumbersome and not followed in all centers. In our centers, we follow it sometimes if it is under any study. So this is the kind of like a algorithm of, so I think this have been discussed. So I'll not go factors, low iodine diet. This has also been discussed. But I would just mention one thing. I think surgeons, when they send patients to us, they are too much worried about this low iodine diet. They will ask the patient not to eat anything. But you did not be so harsh with the patient. Even if the patient can even take table salt also. Studies from AIMS that have shown the table salt, when they are adding it while making the food, not at the end of the food preparation or as like an adjunct, it is perfectly okay. And most issues probably we see with vitamin supplements, protein powder, expectorants. These are the rather than food. And one small note about thyroglobulin. Now, the thyroglobulin is achieved at 4 weeks, and anti-TG antibody assay with thyroglobulin is absolutely mandatory, especially in current generation when second generation immunometric TG assays are used, where interference rates are very high. And these values, even the TG values can vary from lab to lab, so or assay to assay. So it is ideal that you follow it from the same lab or from a same assay if you know that. And anti-TG values are not standardized at all, so you need to know the cutoff that has been given in the reference of the report to interpret the result. So TSH stimulation, this is, I'll just go a little bit. It's most cost effective. RSTSH we use in India, it is available. Cipla is the company that is supplying RSTSH, but one dose of injection costs almost 90,000 rupees. So it is not amenable to most patients. And RSTSH data is also mostly in low to intermediate risk patients. You can treat metastatic patients also with RSTSH. However, from my experience, from our experience, we have seen if the metastatic sites are involving your like cord or like a big lesion with impending fracture, chances are that the post THS simulation there may be fracture or she may complain of a lot of pain, and theoretical risk of cord compression is also there. So you have to be careful in those, and probably you have to add steroid if you want to treat those patients. And also patients who are having functional thyroid metastasis, there is a theoretical, I have never seen, theoretical risk of hyperthyroidism or thyroid storm down the line with RSTSH, but I have not seen, and I think not much reported in the literature as well. LT3 supplementation in our setup at least has been shown beneficial, especially for metastatic patient or skeletal metastatic patient. We see patient come to us after 4 weeks of complete TSH stimulation. Many of times you will see this metastatic lesions have grown in size and complaint of pain. Say a jaw metastasis, little bit when you do the surgery. 4 weeks later, when the patient has presented to us, it has become big. So in those settings, I would advise, if it is available to you, for 10 days, 10 to 12 days is enough to achieve the required TSA stimulation. That way, the period the patient is under TSA stimulation is less. And this is one practical area where we have found that it may be of beneficial. So there are some few images that I am showing. So this is a normal, so this is like a post-treatment scan. So this is normal take in the stomach, intestine. This is the thyroid remnant that is left behind that can be remnant ablation. Here you can see the thyroid remnant plus a node. So this patient ideally should be sent back to the operating surgeon for a salvage neck dissection if it is amenable to surgery. And this is lung metastasis. So we see these things quite often. And these are the bone metastasis with starred artifact. This is a kind of artifact. If you see, we know that this patient will do very well with treatment because it indicates these are very highly avid tumors. Follow up, I'll not go much because they have already been discussed. But just to say that with the advent of DRS, dynamic risk stratification, we see a lot of patients who have been treated with like high intermediate or in high risk patient will have excellent response. We had a study that published from our department only where 140 patient roughly, so almost 40% of the high risk patient had an excellent response down the line. And then another 20% had an indeterminate response. So all of these patients would go on to do much better than compared to their initial risk assessment would have warranted. So take home message, this we have gone through, the has 3 goals. All DTC patients are not amenable to treatment, should be individualized, and low risk patients should are not needed treatment usually. And for adjuvant treatment should be reserved ideally for high risk patient, and for intermediate risk patient it can be individualized based on the specific histopathological characteristics. And patients with lung metastasis and bone metastasis should be treated if they are RAI avid. Thank you. So there is another presentation I have. Right? Thank you. So I am staying a bit more. So, oh no, so this is not the presentation. There is another presentation.
Differentiated.
That case-based. This one. Correct. So yes, thank you. So this talk I have made more like a practical approach and little bit of advancement that we have achieved from nuclear medicine side over the years. So what I'll cover, diagnosis of RRDTC, when to treat, and some recent updates on theranostics. So radioiodine refractory thyroid cancer has a normal differentiated thyroid cancer has a very good prognosis, but till it concentrates radioiodine. Radioiodine may not help the patient, but if it loses radioiodine, then it is a bad thing. So, and as has been discussed in previous talks also, as RAI avidity goes down, FDG avidity brings up, and a lot of mutations, this tumors aggregate, epigenetic changes also happen. And there is no clear-cut definition for radioiodine-resistant DTC. ATA 2015 had given these criteria, right, that tumor should not concentrate RAI, like one of the criteria, should not concentrate RAIs from the beginning. And tumor initially concentrated, then they lose the ability to concentrate. Then some lesions concentrate, some lesions don't concentrate. And in spite of them concentrating, disease is progressing. So, and patient has reached like the maximal dose of RAI. So what can be given? So that varies like 600 to 800 millicurie. It's given in ATA in India. I think most people give 1 curie, one iodine 123 scan or a iodine 131 whole body scan. So iodine 131 can be used to do a whole body scan also. So we will give a much lower dose. So 1 to 3 millicurie is the normally given. For treatment, we'll give 30, 100 like that. Okay, uptake is present in some lesion, but not in all. So, and they have also drawn a hard line that if the patient has not received a single cycle of RAI therapy, then you cannot diagnose RAI refractory. There's a good practice statement. So now I'll go through a case. So this patient had undergone a hemithyroidectomy PTC, then developed a local site recurrence, and FDG PET was done at the time, no distant metastasis, and had a basically salvage surgery, and this was the histopathology, multifocal tumor deposit, a lot of tumor deposit. With PTC tonsil is the main histopathology. Largest tumor is 4 centimeter, basically a high risk disease already and recurred. And TG is 758 nanogram per ml. So most of us would assume that there may be some bone metastasis at least. Or so this patient was given 200 millicurie, and this was the post-therapy scan. So you can just see remnant uptake in the neck, and rest are the physiological uptake, no other side. So now, what should we do in this patient? Do we do straight away a FDG PET? Do we do some other imaging? So, so let us see what ATA 2025 says. So this treatment kind of was like an empiric treatment because we did not have a evidence of RAI avid metastatic disease, even though the TG was high. We treated the patient, and the patient only showed a neck uptake, but nothing else. So ATA 20, so empiric treatment is not common, and it's not preferred in our community at all. However, it was a surprise to me that in 2025, ATA has donated quite a lot of emphasis on empiric treatment. So they have mentioned that if the patient has a rising serum TG level, but no disease in cross-sectional imaging, so in case-to-case basis, empiric treatment can be given. And in certain cases, there may be noticeable disease in the post-therapy scan. And if in the follow-up, those post-therapy, so those diseases that are seen in the post-therapy scan have decreased or shown some response, then the patient can be treated again probably. So much of the references, so when I went through the references in that recommendation, so those are old references where they showed that some patients, like 63% of patients may show some in the post-therapy scan, and some 50% of patients may show some fall in TG or some response. However, none of the studies have showed any survival benefit. So I don't think we should consider empiric treatment as a standard of care and only reserve it for a very few cases. So this is the patient. Let us coming back to what happened. So after 6 months, so we have already treated the patient, and there was a PET scan done beforehand. There was no disease, so we kept the patient on follow-up, and we wanted to see what happened after 6 months. So we did another scan. This is completely negative. The remnant is ablated, and the TG has come down, as kind of was shown in some of the papers. The TG would come down even if nothing is seen that much, or probably the remnant is ablated. That's why the TG has come down. So this is a classical scenario, which is colloquially known as TG elevated negative iodine scan, one of the type of radioiodine refractory thyroid cancer scenarios that we can say. So in this kind of thing, we usually will do a USG neck. So USG neck is done for routine follow-up for all thyroid patients. So it shows some suspicious thyroid bed lesion. We also did a FDG PET to rule out if there are any other site at this point. So this is the FDG PET. You can see FDG avid thyroid bed lesions, and this patient underwent FNAC, which confirmed, and then the patient was referred for surgery. So this is the algorithm that we follow. So if we see a tennis where that is TG is elevated, but iodine scan is negative. So first we have to rule out iodine interference and heterophile antibody interference. Heterophile antibodies are like anti-TG antibody, but they do the opposite thing. That means they may show falsely elevated values of TG. We do see these things, but we don't have any tests that are available in most centers that can detect heterophile antibodies. So most of these are theoretical. So if you get an AQSG done, if it is contributory and operable disease is found, surgery is the treatment. If non-contributory, go ahead with the FDG PET. And if it is operable disease or a localized metastatic disease that can be taken out by metastalectomy or ablation or RT, go ahead with it. If not, and nothing is seen, then you can keep the patient on TSH suppression. That is enough. And so let us see another patient. So this is a patient, 35-year-old female, initially operated, then with under PTC, underwent 102 millicurie of RAI, follow-up LDS is negative. After 1 year DA5, patient had a recurrence, underwent nodal dissection. After surgery, the TG is still elevated. Again, treated with 125 millicurie of RAI, but post-therapy scan showed no uptake. and at that time the patient had presented to TMH. So possible reason, what can it be? Could it be iodine interference? Could it be poor resolution of whole body scan because we have given a very little activity, because iodine 131 has a poor imaging characteristics, or interference variant heterophile antibody, but there is no way to prove because no assays exist, or incomplete surgery. Maybe notes have been left behind, like as was being discussed, and like some notes sometimes are left behind, then they come back and recur, and radioiodine refractory DTC, RRDTC. So what can be the next step? So patient was thoroughly counseled about iodine interference and called after 3 months. The TG is now 45. So it has increased a bit. So, and this is the, and we did the scan. Again, the scan is negative. So iodine interference probably it is not. So what should be the next step? Active surveillance, or should we do a FDG PET-CT, because USG is also negative. So we did FDG PET-CT, but that is also negative. Now, what should we do in this patient? Next step. So this is a classic case of biochemical incomplete response, right? Biochemical incomplete response from the studies of Tuttle, Littler, and Vassim, and we know that 30% of the patients will spontaneously normalize. So you don't have to do anything. 20% may need some additional treatment because something has been discovered, like USG, and 20% will develop structural disease. So it was kept on active surveillance and a TSA suppression. And this is the TG level of the patient overall. That anti-TG is not elevated, and S is stimulated, and non-stimulated NS is not stimulated because the values are different, right? So you can see that TG level has gone down. So this patient has been followed up for 4 years, and the TG levels have normalized. This highlights that in this kind of setting also, less is more. You have to keep your patients and observe the patient, thoroughly counsel the patient, put it on the this is most important than to understand when to treat. Asymptomatic, stable, minimally progressive disease do not require treatment. And patients do not have any directed treatment like surgery, metastatectomy, ablation. Those things you cannot do. So you can refer. And can be monitored on TSH suppression therapy and serial imaging. Some patients may come from a rural background. They may not come back to you for serial follow-up. In that case, you want to do something. There you can give some kind of treatment. If you know that the patient will come back again and again to you and as a very compliant patient, then you can give patient on follow-up. When to treat? So A has defined them as determining the extent of metastatic by imaging studies. FDG PET-CT should be done if critical sites are involved, like a spinal metastasis, or with the impending cord compression, or impending fracture, kind of like that. Clinically assessing patient for symptom, or determining radiological progression based on RECIST version 1.1. Not a molecular progression, but a morphological progression. So does TG have any value? Some studies have said that shorter TG doubling time may herald a earlier radiological progression. So, but we don't use those this thing. So one such case I want to show that the papillary PTC operated mostly intermediate, high intermediate risk, TG 144, NCCT thorax was done, multiple lung nodules. I have only just shown 2 here, but bilateral lung nodules were there, looking suspicious, rounded, and patient received 200 millicurie. So only remnant uptake, nothing in the this thing, lungs. So 6-month follow-up, again nothing. NCT thorax was done. You can see the nodule size has remained same. So one nodule only I'm following here. There are multiple nodules actually. So, and the TG has also come down. It is 42 now. And USG is negative. So in these patients, we will keep the patient on TSH suppression and keep the patient under follow-up. And now the non-stimulated TG is 4.5, is still elevated because 1 is the cutoff. And you can still see that the lung nodule is still stable. So this patient at this point doesn't require any aggressive treatment, and we can keep the patient on follow-up. So we had done a FDG PET also at that time, this time around, and no FDG avid disease. So I will just go on and recent up, and I will take 2 minutes just show that, because this is the area where AT also recommends you should, if there is approaches for research, you should do it. From nuclear medicine side, from medical oncology side, there have been remarkable this thing, especially with the advent of BRAF and MEK inhibitors. It has literally changed the game. On also the Libretto trial that has come up for sulpercatinib. So for nuclear medicine, we initially used to try, because these patients are, because we are now normally we are people whom patients are referred, but now we have become the referring in this kind of cases. So we used to try all of these things that we have available, dotatate and PSMA, which are used for prostate and neuroendocrine cancers. They never did anything. So these few molecules that have come up in recent years, RGD, FAPI, and MOIS 439, that we will not discuss much, and redifferentiation therapy. Redifferentiation therapy, I feel, may come back in a big way, since the MEK inhibitors and the MAP kinase pathway inhibitors. So a lot of studies are going on in this area. So I would put one such study that is done from, I think, MSKCC only. So there they put patients on MEK, RET, ALK, and BRAF MEK, that is regorafenib, trametinib. And what they found is that RAS-driven tumors like IAB-PTC or FTCs had the highest amount of redifferentiation post this redifferentiation treatment compared to BRAF-driven tumors, which the PTC, that is only showed 42%. So this might be significant. So there are good studies being planned in Australia by the Andrew Scott team. And from India also, we have some molecules which mainly target the tumor microenvironment. Integrin is a type of neoangiogenesis marker. So that can be tagged with gallium, and that can be tagged with lutetium as well. So for imaging and therapy, so some preclinical, some preliminary studies have been done, and this particular study has garnered a lot of attention, at least in India. So here they are targeting the tumor microenvironments, cancer-associated fibroblasts, basically, through this protein called fibroblast activation protein. So this can also be tagged with gallium and lutetium-177, which is a therapeutic isotope, and some phase 1 studies have shown some benefit. And finally, this is my last slide. So this is interesting because this year only published, and probably in India we may get this through the VCC cyclotron. This is astatine. So certain RAI refractory will continue to show iodine uptake, but they will be progressing. So if we, instead of giving them beta emission, if we give them alpha emission, which has a higher linear energy transfer, so can it affect? So astatine, if you remember your periodic table, it is a halogen. So it can be taken up by the thyroid cancer cells via the NIS transporter. So it's a phase 1 study which showed that it was like a dose finding study, and there they showed that thyroglobulin is going down. And the take home message for this talk would be that the diagnostic RRDTC should involve careful consideration of diagnostic whole body scan, post therapy scan, and cross sectional imaging. And in the absence of structural disease, even with elevated TG, treatment is only TSA suppression. Role of empirical RAI is controversial and should be decided in case to case basis. Asymptomatic, stable, minimally progressive RRDTC do not require treatment unless focal ablative therapies are available. And in case of tennis, if FDG is negative and if you have tracers like FAPI or RGT, you may try it. However, I don't know what will be the next step if they show some disease. And preliminary data do suggest radionuclide therapies may be helpful other than iodine, but they need more data. With this, I'll end it. This is my department from outside. This is called RRU in ACTRAC. It's one of the largest theranostic centers in South Asia. And next year, we are hosting a IAEA training program for theranostics. And I don't know if any nuclear medicine physicians in the audience, so they can attend. Bangladesh will be one of the countries that will be participating because it's a South and Southeast Asia forum. Thank you.
Thank you very much to the Professor Sheok Chaudhary for your brilliant presentation. Any question from audience. Our next presenter is Mr. Rockmangathan. He is basically a speech and swallowing therapist. Your topics is optimizing voice and swallowing function following thyroidectomy. Please, I welcome to Mr. Rockmangathan. Please come to the dais and present your topics.
Good morning, all. I'm glad to be here again and presenting on optimizing voice and swallowing function after thyroidectomy. Um, I'll be taking very short time in presenting the entire topic as we know we are running out of time. We all understand that there are multiple complications. One of the two complications that after the thyroidectomy is dysphonia and dysphagia, and out of 25% to 84% having risk associated with this post-operatively, and incidence of voice changes found to be as high as 84% in voice assessments of these individuals. The major cause is damage to the SLN and oral nerve, as well as uncomplicated surgical procedures also lead to dysphagia and dysphonia in these individuals. Mostly post-operative complications, laryngeal edema, surgical trauma, and any of these factors can cause this acute thyroidectomy complications, which is mentioned as post-thyroidectomy syndrome. And thus, we need to address all of these things systematically. So major thing in these individuals as speech language therapist and a clinician, we need to do the pre-treatment counseling with respect to the problems that patient will be associated after the surgery, and interventions that are available to the patients and available in the institutions. So counseling is of paramount importance prior to initiation of the thyroidectomy for these individuals, and we have to use patient-reported outcomes such as voice handicap index, which is commonly used across to understand the problems of the patients. So it is commonly used, and there are new developments that are occurring, and such questionnaires which specific to thyroidectomy also are now emerging, so that can be used. There is a 20-item questionnaire that addresses both voice and thyroid, throat and neck discomfort questionnaire, which is recently developed, and efforts have to be taken care to develop in regional languages. Moving to the voice therapy. So in need of the voice therapy in these individuals are established that the goal of voice rehabilitation in these individuals is intrinsic musculature is the goal, and next is improving the glottal closure without causing any supraglottic hyper function of these individuals. So coming to the voice assessment, according to the European Language Society in 2008, they have recommended all of these five parameters associated for assessment, for not just assessing the perceptual voice quality, having an acoustic voice evaluation, videostropic evaluation, spirometric evaluation, and patient-reported outcomes. As much as possible, at least have any one of two minimum to initiate with. So out of all the voice assessment and voice therapeutic modules, so physiologic voice therapy will help in maintaining all of these parameters, that is respiration, phonation, and resonance, because these are important in the outcomes of the voice of the patient, because all these things can affect the voice problem, not only the vocal cord status. So proceeding to the how I proceed for vocal function exercises, one of the function exercise that is described in this approaches, wherein which the posture is an important component of this voice therapy, and different steps that is involved in this function. I'd like to just demonstrate this as initiating with a warm up of just gentle phonation task of E, and then moving up to the stretching exercise of using the syllable U, and then moving to the pitch glides that helps to see whether the patient, for example, from low pitch to high pitch, like E. So like that we can initiate, and then adaptive strengthening exercise, use of both E and U's syllable, but E, U, E, U. This is just a simple 4-step exercise that can be initially given to the patient, but it's not a simple thing, but there's a set of things that we have to do when we are with the patient, and maybe funny, the patient may not like it initially, so multiple sessions are required. Thus, we, as a speech language therapist, as a clinician, we can have in one-to-one setup, and with multiple sessions, we can achieve these things systematically. So moving into voice therapy, for voice therapy, major urgent is we need a laryngoscopy will help us to understand the pathophysiology, not just voice therapy. The patient also to understand what is happening exactly, and it can be used as a biofeedback tool. Thus, strongly recommending that the clinician to use laryngoscopy as a voice therapy tool. So in our hospital, what is the protocol that we generally follow in pre-surgery? We either an endoscopy, rigid endoscopy, or flexible endoscopy to assess the pre-treatment status, and after the post-surgery, be it anywhere between second post-operative to fifth post-operative, we do perform a flexible and laryngoscopy to assess the status of vocal cords, and then and during that time, we assess not only voice as well as the swallowing to initiate if there is any issues with swallowing disorders. And we perform majorly flexible endoscopic evaluation of swallowing in these individuals as we expect majorly pharyngeal related swallowing disorders. And in follow-up procedures and regular endoscopy is performed. So there are different guidelines available with respect to management, and the recent guidelines that talks about the different time points, what has to be done. I'm not going to the major details. So next is the swallowing therapy related to these issues. So generally, clinical evaluation that we use is for swallow test and screening test to check for any cough or throat clearing in this patient, and we need to assess any risk of any silent aspiration, which cannot be very well attested only with clinical evaluation. Then we move in this patient, since patients having high risk for aspiration, we cannot directly move with 100 ml water solid test. Rather, we perform a modified water solid test, wherein we start with 2 ml, proceeding to 5 ml, then with maximum 20 ml to see if any risk. If there is any signs in this issue, possibly we have to submit the patient to the evaluation to understand the safety of the swallow and risk of the swallowing. So, and definitely I reiterate again and again that we use these commonly available, very easy to track the outcome that has functional oriented scale with respect to the tube dependency and oral intake, and as well as the normal step diet will help all the across the clinicians to understand the patient status. And of course, either use video fluoroscopy procedure or the FEES procedure in understanding the safety and aspiration risk of this patient. Majorly, we can go with the FEES procedure in this. This example, this patient who underwent total thyroidectomy with mild to moderate hoarseness, and after the clinical evaluation, we understood that there was a small post-swallow cough in the modified water swallow test and objective evaluation. I'll play the video of the FEES procedure we have done. As you can clearly see that right vocal cord is mobile, left is fixated with clotting chink, and we have given thin liquid to try. So as you can clearly see that patient had very mild penetration and was very well managed with just simple post-swallow cough. So that's why this kind of test is very much essential to understand if any of these issues are there, and helps us to take the advice. And the patient was advised to take continue to oral diet and with small post-swallow cough strategy, and also initiated vocal function exercise in these patients. Okay, second example, with a patient had a severe dysphagia post-thyroidectomy, and this is a female patient with 53 years old female. We have done the procedure at two different time points, 3 weeks post-op and 8 weeks post-op. I'd like to play a video. As you can clearly understand, there is a severe laryngeal and edema observed, which is secretion pooling across, and limited glottic gap observed. Yes, I can see clearly thin liquid, which his patient has swallowed. After the completion of swallow, there is clear evidence pooling across the vestibule and the pharyngeal, posterior pharyngeal space, as well as spilling over into the larynx. And it's clearly penetrating as well as bleeding, and there's no response to that. So that is the status at the 3 weeks post-op, and helps us to take decision whether to initiate ORU or not. And next, the same patient after 8 weeks post-op, there is some amount of reduction in the edema as well as the increase in the phonatory cap, which indicates there is some amount of improvement. And we have given the same liquid trial to and there is some amount of space that can be absorbed posteriorly. As compared to third week and eighth week, you can see that there is a reduction in the residue, as well as the patient has some amount of response to that. So with this, we are able to take some decision with respect to initiation of oral diet and what amount of consistency, what amount of quantity the patient can be taken. So last patient that I like present is post-operative 14. We have done the same phase procedure. Patient had a reported severe breathy voice, and you can clearly observe that there is large phonetic gap observed while foundation task, and we have given as a safety measure, we did not give a thin liquid as a to test on soft diet only, because we estimated thin liquid as a risk of aspiration. So the advice we have given for this patient to initiate the soft diet and also to initiate 2 strips of the thin liquid, and the advice will wait for removal of feeding fluid. So one of the most common strategies that is used in these individuals is the Chintet procedure, which helps to reduce the glottic, improve the glottic closure as well as improve the swallowing. So out of all the other techniques, this Chintet will be more efficiently can be used in this individual in early acute phase. So one of the study that we have done in a retrospectively, we understood that any patients who have above 55 years, we need to subject the patient into all of these evaluation and in systematic approach. And I'd like to conclude that early voice and the swallowing rehabilitation is essential to improve the functional outcome in these individuals, and FEES is preferred to evaluate acute pharyngeal phase. We need to initiate voice therapy, and I'd like to also I'd like to thank you. The small that I want to say request is that having a speech therapy can be more beneficial to the team, to the patient, to the I request please to have one speech therapist who dedicatedly work in onco rehab. So I take this message that we are going to conduct a national program in tracheostomy course in February 2026. I welcome you all to this program, and the registration has started soon. Please visit our website to register your course, and who are interested, please come to work and attend this course. Thank you.
Thanks to Dr. Rockmathan for your nice presentation. Our next presenter is Dr. Siddharth Shah. Your topic is remote access thyroid surgery. I welcome to Dr. Siddharth Shah for your presentation.
Thank you. I think I'm going to. So after all exciting sessions for the day, probably this is the last talk of the day. And that's why I suggested that we put it at last, because this is the advances in the way we operate thyroid surgery. And Mehboob from your place is doing this technique. So congratulations to him. Now we know that we deal with this era of increasing cosmesis and more cosmetic needs. There has been refinements in every surgery in GI, in head and neck, everywhere. We do functional endoscopic sinus surgery. We were doing earlier open surgeries in the neck, in the nose. We used to open up for medial maxillectomy, doing lateral rhinotomy incisions and all. Now we have put on endoscopics to do medial maxillectomy, DCR. We do endoscopic ear surgeries as well. We do a lot of microlaryngeal surgeries. So we are going more and more of minimal invasive or endoscopic approaches to improve our outcomes, to improve our results, as well as to give more of a cosmetic outcome to the patient. So yes, at the same time, I remember my bosses when I was in PG, when they used to do lateral rhinotomy, it is hardly possible for them to see. It was difficult for us to see they are doing. Okay, so now when they were doing otology, we don't had side cameras or screen. So whatever the professor would show me, okay, this is the chorda. Okay, this is chorda. I don't know what I was seeing. Okay, so now with the help of this endoscope, screens and microscopes, you have a monitor which can be shown and defined that, okay, this is the structure that you have to see, and it becomes easier for training as well. So this new advent of endoscopes and has really improved the training of the students, and that's a really boon for the teacher students. So for otology, rhinology and laryngology, we have accepted minimal invasive or minimal access approaches. We use functional endoscopic sinus surgery, endoscopic otological surgery, as well as MLS surgeries. For neck, endoscope is a real challenge. The reason, all the other structures, they are rigid structures. There is no space compromise. You have to drill the bone, cavity will remain wide, it will not collapse. There are important structures which you can really take care. But for neck, it's a collapsible structure. There is no permanent way that you can keep it up, separate. The skins will keep fall. At the same time, the space available between the structures, the skin and the soft tissue, is very minimal. You have vital organs, great vessels in the neck. You have major cranial nerves. You have thyroid. You have larynx. So these are all vital and important structures in the neck, and they are tightly packed. So it was difficult that you can do some minimal invasive or a minimal access surgery in this region. But techniques evolve, strategies evolve, and so with nowadays probably with more of laparoscopy that we are doing GI surgeries, gynec surgeries. Similarly, we are able to do neck surgeries using endoscopes. So we know that for thyroid, the definite indication for surgery I'm putting, I'm not saying we are not going falling into the contraindications of doing thyroid surgery or when not to do, but these are definite indications or reasons that we would be doing. So this was in past in Turkish era, Mughal emperors. But what we do is now do an open thyroid surgery. We open up the neck, remove the thyroid, and close the neck completely. That's what we practice right now. But what are the limitations? It's an external approach. We have to put a skin cut on the especially a most beautiful area of the body, which is the neck, which is very visible to the eye, and it cannot be covered by any means. Rest of the body part we definitely cover for the rest with our clothes, but the neck is always remaining open. Every individual is a different person. Every individual has a different healing tendency. You may do a best surgery, best closure with the best suture material, but the internal healing or the patient's outcome depends upon the internal healing power. There will be skin edema up and down the flap, skin flap, which will lead to a lot of fullness in that region. Patients concern giving how when this will edema will going to go down. Patient will have hypoesthesia in that skin area. At the same time, over a period of time, especially in females, the scar line gets shagging down. It keeps on shifting down in the neck, lower neck. So these are the major challenges when we do an open thyroid surgery. So is there any way that we can, for select group of patients, I will just very categorically put select group of patients. So you can have a very beautiful scar which is hardly seen, and my lot of colleagues do argue what is the need of this remote access thyroid surgery. Scars heal very nicely. There is no need of butchering. This are yes, very beautiful scar, but there are certain ugly scars also. And this thing is not in our hand because that's an internal healing capacity of the patient. And this, if it is done for a benign condition, probably that is where we will be seeing. So now what is the future? Future of thyroid surgery. You go through a keyhole and remove the thyroid. So what is it, why you want to do, and how you can do it. So here you approach thyroid from a remote location, from an extra cervical region. So you don't open up the neck, you reach the neck from a different location. So you can use axilla or the chest wall, you can use postauricular region. Ravi had very nicely demonstrated on the first day retroauricular approach for a neck dissection. So you can use the postauricular approach, you can use the axillary approach, you can use the chest and areolar approach for reaching the neck from all these areas. So you can reach Dhaka from different locations, but you can be in Dhaka from different areas. It's like same. But this ultimately leads to a cut on the skin somewhere on the body part. It is not visibly located, but somewhere on the skin, and the similar healing issues can happen on that location. So that's why this is not a scarless approach, but it's a remote access approach for a thyroid surgery. It gives an excellent cosmetic neck feeling that there will be no neck scar in the body, but there will be some scar in the body somewhere else. Why you need to do remote access surgery? So majority of our thyroid nodules, they are benign thyroid nodules. We have gone thoroughly through this entire journey of when to operate, what to operate, what not to operate, but we assume that this patient needs a surgery for one or the other reasons. Either it's a follicular Bethesda 3 or 4 follicular neoplasm, or for a younger patient who is due for her matrimonial and she needs it for cosmetic reasons. We don't put right now malignancy as the reason. So we commonly see thyroid nodules of around 3 to 4 centimeter in a younger patient. We do get often FNAC as Bethesda 3 or 4 category, and we are helpless what to do. We don't have capacity to undergo molecular testing, and again the scar is a concerning. So how we do it? There are remote access approaches. So minimizing the scar, you put a very minimal scar of 2 to 3 centimeters and do a video assisted thyroid surgery. You cut that area and you use your sinoscope and do the entire thyroid surgery, the video assisted thyroid surgery. Shifting the scar from where you can shift from the neck to an extra cervical region. So breast areolar approach or bilateral breast areolar approach or into the retroauricular area. Or you do not put any skin scar at all, and that is known as NOTES, natural orifice transluminal endoscopic surgery for the thyroid. Here there is no skin cut placed. And this has been the evolution of the remote access thyroid surgeries. Started in 1998 till 2016. There has been a different approaches has been developed. Finally, what is considered as truly scarless is the natural orifice transluminal endoscopic surgery, which is TOETWA. That is what we do is the transoral approach. Because here the incision is nowhere on the skin, it is in the vestibular mucosa, which is the oral cavity mucosa, and we use this natural orifice. We, as an ENT, we use nasal cavity, which is a natural orifice, to perform functional endoscopic sinus surgery, FAST, DCR, skull-based surgeries. We are using that natural orifice. Otologists use natural orifice of external ear to perform endoscopic surgeries. Gynects use natural orifice to perform their lap hysterectomies, even GI surgeons. So these are the natural orifice where you don't have to put any string as an opening. Similarly, oral cavity is a very good, we do tonsil from intraoral, we do stylodectomy from intraoral approach, we do not cut from the neck. Similarly, oral cavity, where the vestibular area is the route which we can utilize, perform the neck surgery. We can pass through that region into the neck and perform the surgery and come out from that area. So final incision rests on the mucosal part of the oral cavity and not on the skin, and it will heal within 5 to 7 days very nicely. So ideal case selection for beginning the transoral thyroid surgery is a benign thyroid lesion, approximately 2.5 to 3.5 centimeters of maximum size, benign condition, thyroid cyst, solitary nodule, multinodular goiter can be as you grow your experience, follicular neoplasms, Graves' disease, early papillary CA. As you grow in, this is like as you grow in your experience, you can add on to your basket the number of the category of cases that you can take. But limitation as of now is the nodule size. Up to 5 centimeters or max 6 centimeters with a volume of approximately 45 to 50 cc is the current limitation of performing this surgery. Anything larger or beyond this is the strict no-no for a Toyota approach. So how does it work? So most importantly, otherwise it doesn't need any extra investment. Being in a hospital, multi-specialty hospital, probably you will have a GI department with you, and they already have the laparoscopic system with them, with gas insulator, endoscopic system, laparoscopic instruments and everything. These are the same instruments that you would be requiring for your endoscopic approach for the thyroid. Doing a robotic, you need a robotic instrument. That's a different ball and game. But then you can start with laparoscopy. The the setup here is you stand on the head end of the patient. The staff entirely is on the head end of the patient, and the cart is on the foot end of the patient. And this is how you operate. So in the FAS, you keep the cart on the opposite side, and you stand on the side of the patient. Here, you stand on the head side of the patient, behind the head of the patient, as you can see here, and the cart is at the near the foot end. So major steps I would say is you start with putting your mucosal incisions, then reaching up to the submental area, try to connect from the oral cavity into the neck, create a subplasmal tunnel. The way we raise and the platysma, and then we start raising superior and inferior flap subplatysmally. The similar plane is to be achieved from the intraoral approach. We need that area to remain open or widely so that you can maneuver your instrument. So you require CO2 insufflation for this patient with a very minimal pressure of 6 to 8, but a high flow rate, so that because there is an incisions are open, there will be continuous outflow of the CO2 happening. So you need to completely push the CO2 in that. So there will be high flow rate, and entire surgery of the thyroid is similar to the open thyroid surgery. Most important critical thing is the incision making or marking of this instrument, and this is considered as the safety triangle, the safe triangle in the region between the premolars and the midline frenulum, middle part of the lip is a triangular area which is considered safe to apply your central incision, which is the largest, around 10 millimeters. You need this incision for putting your camera so that it becomes central vision, and the sides you can work with the instrumentation. Now this is the path of the mental nerve, which is the major concern of this surgery, whether you will be damaging this nerve or not. So as you can see, this area, this triangular region is a safe to put the incision. There is no nerve fibers which are coming. They emerge between premolar area, and then they ascend entirely towards the midline. So that path is safe. In between the two nerves, there is a safe path for putting the 10 mm trocar. And the lateral incisions will be between these nerve fibers, this near the angle of mouth, around centimeter anterior and inferior to the angle of mouth. So these are the locations for the mucosal incision. So this is how you want to create the tunnel. This is the central tunnel. These are the two lateral tunnels for instrumental work. And this is the entire space or the cavity that you would want for the thyroid working space. So we start with this vision, and the ultimate goal is to open up the entire subplatysmal plane, muscle to muscle on either side, sternocleidomastoid to sternocleido, and inferiorly up to the suprasternal notch. This is a short brief video which will explain you this approach. So it was a 45-year female with a Bethesda 5. So it was a suspicious papillary CA. We start with creating the working space. I will not put the port insertion part, just to be quick. So we are exposing the strap muscles and lifting the flap anteriorly. So wherever I'm right now working is the foot end of the patient, that is towards the suprasternal notch, and I am coming from the neck oral cavity side of the patient. This is left and this is right side. So right side, left side, and this is the caudal part of the suprasternal area. So I'm gradually separating the subplatysmal plane from the strap muscles. These are inferiorly the strap muscles in the base. So once the strap muscles are identified, we divide them in midline. That we'll be doing in open as well. We separate them in midline so that we can create the working space of operating. That's the cricoidal cartilage. That's we are using energy device, harmonic scalpel. It is mandatory. Now identify the lobe. You kind of deskeletonize the lobe of the entire strap muscles which are stretched over it, and you try to reach onto the lateral margin of the thyroid gland. Create a space in that lateral gutter so that you can work here. So this is what we are doing right now. So this is the superior thyroid pedicle. It's the superior thyroid, probably vein. So you keep separating, keep lifting it, and try to create a space between the muscle and the nodule. And then you insert a traction suture, which is a lateral door traction, we say, so that in open thyroid surgery, we put a Langen bag to retract the strap muscles. In endoscopic, I don't have, I have only two hands to work with. So to help me with the traction, this is a suture which is part from externally and it gets pulled. And so the muscles remain retracted. So now I'm graduate, this is the artery, superior pedicle. We take the artery that will free off the superior pedicle of the superior pole. Now this gives you a very beautiful vision of very important even the minor vessels. So these are the parathyroids. This is the parathyroid that I am dissecting. That's the vascular pedicle of the parathyroid. So you do a very good capsular dissection in this region so that your parathyroids get separated inferiorly and they get fall back into the thyroid bed. That's the tubercle of Zuckerkundl, which is our landmark for parathyroid as well as for recurrent laryngeal nerve. So as I go down, I keep separating thyroid the strap muscles and reach toward the lower pole. Now, this is the region where you will be finding your nerve. These are the inferior thyroid artery. Just medial to the inferior thyroid artery will be our nerve. This is the nerve which is seen. So once we have identified the nerve, we know that the nerve is in here, the thyroid is here. We have still ligament of Berry and the isthmus still attached, but I have identified the nerve. I'll just try to separate the nodule laterally. Once I am satisfied the nerve is in the entire length and intact here, we'll go towards the midline for doing the isthmectomy. Because we'll come here last part because that will be the only part attached towards the end. Now, most patient will have a pyramidalis. It may be smaller in length, it may be larger, but majority of the patient will have pyramidalis. So you always try and look for the pyramidal lobe. Take pyramidal lobe, just keep following it and you will find the isthmus. So once I separate the isthmus, the thyroid is free from superior, lateral and medial midline attachments. And then I have it easy for me to handle it. So now I'm doing the isthmectomy. So I'm going beyond the midline towards the opposite lobe. So that's the midline isthmus joining the nodule. So I'm keeping a soft tissue margin or the thyroid margin cuff onto the nodule side. So now that's the Berry's ligament which is keeping and holding the thyroid with the trachea. I know that my nerve is here. Safeguarding that nerve, I can easily remove the rest of the thyroid which is attached to the ligament of Berry. This is the nerve here, lower down. We need to make sure this is the nerve, this white structure. The the harmonic has an active blade and an inactive blade. The white coating is the inactive blade, but the other one is the active blade. So we should try and protect the nerve every time we are using this. Keep the non-active blade towards the nerve. Now this is the bag to retrieve the specimen. We cannot just pull the specimen, otherwise it will get broken somewhere or it may have some tissue left behind in the track. So we always put this in a bag. This is a simple plastic bag. This also ensures that there is nothing left behind. Even if this breaks while removal, tissue is still within the bag and it doesn't spill. So finally, you have to pull the entire specimen out from the same oral central incision that was used for camera port. strap muscles in midline. Here also the reason is if we keep this open, once the healing happens, this overlying skin will get tethered to the trachea. It will give some pull effect. So we again approximate the strap muscles. This is barbed wire, the V-lock or the Stratafix that is being used by gynecologists for laparoscopic surgery. So you approximate and the needle comes out from the anterior skin flap. So ensure the hemostasis is done and this is the final specimen. Similarly, it can be done robotically. The same procedure, same thing with the use of robotic system. I'm not going to go in detail, but you get the benefit of this is the end-to-wrist movement of the instrument. You saw difference between the laparoscopic instrument and the robotic. Here, it moves like my wrist. It can rotate like my wrist, while the laparoscopic were only vertical instrument movement. So you can see it rotates like my wrist. That gives more comfort during surgery and more precise removal. Now, so I would like to take pose. This is preoperative vestibular mucosal part, and this is postoperative healed vestibule. You can see hardly make out the difference. This is 1 week, sir. 1 week. So this is the healing that you get after the surgery, and this is the only mucosal cut we are taken in the body. So this technique is considered as truly scarless thyroid surgery. So these are few patients. Finally, nothing is without complications. 1 minute, just last minute. You nerves related to organ damage and other like bleeding and hematoma. It's possible. Only thing is with experience you try to reduce your complications. I would put remote access thyroid surgery versus open surgery. The only benefit is the cost basis. As of now, there is nothing else that you would rate it. And yeah, it needs a learning curve, but it is doable. Thank you. And finally, I would like to invite you all for our upcoming conference, which is on a recurrent head and neck cancers. Whosoever interested, we have Dr. Vin Paleri, who is master in recurrent head and neck cancer from UK. Hisham Mehana, Mark Zafiro. You must have noted certain articles quoted Mark Zafiro in the morning Dr. Shah's presentation. So he has done a lot of work on thyroid recurrent cancers. So they are all going to be part of the conference. So that's on 28th Feb and 1st March. Thank you.
Thanks to Dr. Siddharth Shah for your brilliant and informative presentations. Now, two of our chairperson, one of Dr. Muhammad Ashfaq Hussain, please say something about the session.
Assalamu alaikum. Many thanks to the brilliant presenters for their informative presentation. We have many things learned from their presentations, especially the younger surgeons. Overall thing is preoperative intelligent assessment of a patient with brilliant counseling, hormonal assessment, ultrasonography, and radiological assessment is very important prior to surgery. Intelligent assessment plus operative assessment is very important for a brilliant surgery. And a brilliant surgery is very important for a happy postoperative life. Postoperative management will give a very nice postoperative follow-up and a very happy life. We have learned many things from the brilliant presenters, especially younger surgeons, and we, older surgeons. also have gained many things from these lectures. I hope this is a very fruitful session. I give many thanks to all the audience and presenters. Thank you very much.
Thank you for Dr. Ashfaq Hussain sir. Now I am requesting Dr. Ahmed Rakib sir to say something about the session and conclude the session.
Thank you. We are in the Thyroid Day. It is the third day of this Congress, and we heard in the session some brilliant presentation from the presenters regarding the management of post-operative patients of differentiated thyroid carcinoma. And we heard from the speech and swallowing specialist from Tata Memorial. And we heard from Dr. Saifuddin about the precision and, of using endocrine and management postoperatively. We are definitely benefited from this discussion. We learned many things, and I thank the presenters and the audience for their patient sharing. We are already running short of time, so we are going to the next phase of this presentation, and through this we end this session. Thank you.
Thank you, our distinguished chairperson, moderators, and speakers for their invaluable contributions and for sharing their expertise about thyroid cancer with us. Your insights and knowledge have made this Congress truly enriching. I request the honorable sirs to take their respective seats in the audience and enjoy the rest of the session. Now we move on to the deep dive session, and that is the panel discussion. And the topic is From Observation to Operation, the Challenging Landscapes of Thyroid Cancer Care. In this panel, I invite Dr. Siddharth Shah, Professor Dr. Asawari Patil, Dr. Shayak Chaudhuri, Professor Dr. Suman Kumar, Professor Dr. A.K.M. Fozlul Bari sir, he was the director of NINMAS, Dr. M. Saifuddin, Associate Professor of DMCH, and Dr. Abdul Karim sir, uh, to take on the stage. This session will be moderated by Professor Dr. Muhammad Abdul Sattar sir. I request our honorable sirs to please come on the stage and take their seats. Our moderator, Professor Dr. Muhammad Abdul Sattar sir, is a renowned otolaryngologist and head neck surgeon, working as a professor and divisional head of the head neck surgery division of Bangladesh Medical University. Sir has a vast experience in this respective field and participated many conferences in home and abroad, and also done fellowships, including Memorial Sloan Kettering Center in the New York, USA.
Good afternoon. Slide, please. Today, a lot of discussions on thyroid cancer. We like to moderate on some easy and practical points as a take-home message from our learned moderator and learned participant in this moderation. Our panelists are Professor Ashwani Patil, Dr. Shayak Chaudhary, nuclear medicine specialist, Dr. Siddhartha, surgeon, Dr. Saifuddin, our assistant professor from Dhaka Medical College, endocrinologist, Professor Fazlul Bari, director NIMAS, DMU, Dr. Abdul Karim, Muhammad Abdul Karim, our one of the is the going forward. I'm Dr. Abdul Sattar from BMU. So thyroid cancer, a lot of discussions. I will not waste much time. Just in USA, DTC in latest statistics, 14.9% in 1 lakh. This is latest information. So what is in our country? In our country, exact figure is not known. A couple of reasons. Number one, in our country, there is a statistics of cancer registry from National Cancer Institute, where Dr. Karim worked. In these statistics, thyroid cancer has not been included as because after thyroid surgery, we send the patient for radioactive iodine ablation to the nuclear medicine centers, the different centers in our country. So in that statistics from Bangladesh government and ICRH, in head neck cancer has been divided into 3-4 groups. Cumulative figure of that group is one of the top 10 cancer in Bangladesh. This study result from Bangladesh government funded project in BMU. In this we see lip oral cavity top 10 cancer in case of male. In case of female, thyroid cancer is the leading one. So total, if we see total scenario in Bangladesh, male, female, both groups in top 10. Interesting story is that there is initial in this study initially that was found number one. It is this study has been over in Kishoreganj. Now total number of participants about 4 lakh. If 5 lakhs, this will be country representative. This is going on, this study. So now we are coming to our slide is not changing. Sorry. Okay. So very easy. I like to share all of you a male of 42 years, thyroid nodule of 1 centimeter right lobe. Mobile, incidentally found, no lymphadenopathy. So workup we have to do. Please, Dr. Siddhartha.
So at such a centimeter thyroid nodule, we should not be digging behind to investigate it further unless there is a strong family history. Patient's family had some thyroid cancer patient or there is some relevant history in the finding which suggests that this patient might have a early papillary or microcarcinoma. Then only you investigate this 1 centimeter nodule of the thyroid. You can keep the patient on a close follow-up. At the max, you can do a baseline ultrasound neck evaluation just to be sure that future you can have a comparative evaluation of this ultrasound. That's the and TSH.
Okay.
Only 2 things.
So this is consensus for all over the world now. If it is like 1 centimeter, we have not to do just keep it in follow-up. So now, Dr. Karim, how long we will follow up this patient?
We usually follow up 6 monthly. We usually follow up 6 monthly. If thyroid TSS level is normal and tumor size is not growing, I think then 1 yearly is possible.
So if this lesion is proceed increasing in size, what is the cutoff point to intervene?
Usually, if 30%, more than 30% is
okay. So in guideline has written this guidance roughly 3 millimeter if increase, time has not been cleared, we can intervene. So now, Dr. Saifuddin, what biochemical investigation we have to do in such cases?
Thank you so much. Thanks, and it's honor to be here. And definitely 1 centimeter thyroid nodule on the white tube. Definitely, I agree with them that we can keep the patient in follow-up. And regarding thyroid function test, you can just check FT4 TSS whether the patient is euthyroid or not. But one thing I like to add here, when you palpate a thyroid nodule that is around 1 centimeter, listen to your hands regarding the consistency of the nodule. So I agree with both my previous speakers that we should keep the patient in observation. But if I always listen to your hands. If you think this is consistency a bit firm or towards hard, in that case you should details evaluate to exclude the malignancy. Because in our country, a good number of patients, they deposited money, comes to Dhaka, see the investor, and they will come back to follow up you after 2 or 3 years. So definitely in that case, definitely you should be very cautious not to miss any kind of unusual things. Regarding thyroid function test, only FT4 TSS is, I think, very much okay. Thank you.
Okay, thank you. Now, Professor Fazlul Bari, I like to request, I'm skipping some questions according to specialty. A thyroid scan is necessary in such a cases.
Thank you, dear audience, learned audience. Basically, if it is less than 1 centimeter, still we have to do first line investigation, the ultrasonogram, high resolution ultrasonogram, and thyroid is very important. In case of if it is less than 1 centimeter, still we have to see the margin and the consistency, and is there any calcification or not. If microcalcification is present and irregular outline, then we have to proceed for further. We can do the elastography as well as, because the 48 to 68% sensitivity for the normal ultrasonography. But whenever we do elastography, we can differentiate whether it is benign or malignant up to 90%. So I think so we can do a high resolution ultrasound as well as elastography with Doppler, and then we go for next planning. Then we do the thyroid scan also. But nowadays, thyroid scan, around 5 to 8% case, 5 to 8% cold nodule can be malignant. But a normal ultrasound is superior than thyroid scan for diagnosis. But thyroid scan is very important for follow-up, post-therapy scan, LDS, and the follow-up. So I think so ultrasound, Doppler, and elastography is superior than the thyroid scan to differentiate
So
any
in
malignancy.
such a scenario, we have not to do thyroid scan initially.
Yes, yes.
Okay. Now I like to request Dr. Shayak Chaudhary. Yes. Would you please explain us to do TG, NTDG, or calcitonin in pre-operative scenario in a thyroid nodule cases?
In pre-operative scenario, TT is not recommended.
Okay.
And TT also is not recommended.
Okay.
So we will not do calcitonin if there is a index suspicion for like MTC. However, preoperative calcitonin is also not recommended in most cases without a FNSA suspicion of MTC, or if there is a family history of MTC and a high suspicion of this patient being one of the syndromic. Then
Is there
probably
any
calcitonin.
possibilities to assess preoperatively by assessing NTTG for post-operative baseline scenario? Is there any scope?
No, I don't think so. I don't think guidelines also say to do teaching.
So TG and NTDG is not recommended pre-operative scenario. About calcitonin in our country, where FNSC report is not uniform all over the country, is it help to predict medullary carcinoma if we do it earlier? We get some help from calcitonin pre-operative scenario. So I now request Professor Ashari Patil ma'am you have said a lot during your talk. So to analyze this, what is the impact of FNSC? What are the indications in this scenario, and what are the findings interpretation?
So I can say this is 1 centimeter mobile incidentally detected nodule. And FNSC will not be done unless and until this is radiologically suspicious or there is any family history of, or there is any radiation history, I'm sure Dr. Suman can always throw more light on that. But if at all the patient fits in any of this category, any clinical suspicion or any radiological suspicion, so FNAC may be done on this one.
Okay. So less than 1 centimeter, we have not to do, just keep this follow-up. Okay. If more than this size, what would you do? And you already talked, but we like
Yeah.
to know.
Again, more than this size means just 1.1. I'm sure clinicians will take, because actually that was decided by the radiologist and the clinician. They will take a call. Most of the times it's clinical suspicion. Size is one important, but clinical suspicion and radiology suspicion is more important in that case.
In Thyroid's recommendation, there is 2.5, something like that
So
recommended.
that's the thing.
But in ATA, we see that this is 1 centimeter, something like that. So
again,
how will you?
So again, I think what I would suggest Dr. Siddharth or Dr. Karim to take this question, and again Suman also. But I think these are the gray zone areas, and that every clinician or radiologist will take a decision based on their findings.
Okay.
ATA guidelines says 1.5 centimeters, but latest ACR guidelines, they have found out that if it is more than 2.5 centimeters,
Yes.
if it is a Thyroid's 3 lesion, then you can do FNAC.
Okay.
And if it is a Thyroid's 4 lesion,
Yes.
then it should be more than 1.5 centimeters.
So we have to correlate with previous ultrasound findings and others.
Yes.
Thank you. So I like to request Dr. Shumon, he's from radiology, importance of cross-sectional imaging like CT, MRI in this scenario, or a bit advanced stage, just for discussion.
So the nodule size and location is also very important. If it is located posteriorly or if it is located close to the trachea, then you would want to see if there is an extrathyroid extension or not. And if there is an extrathyroid extension on ultrasound, then the chances of middle compartment nodal involvement is also high. So size, location, and the nodal status. And then if at all if you're not able to assess the central compartment on ultrasound, then cross-sectional imaging is required, like a CT scan of a neck and thorax, just to assess the central compartment nodes when you are contemplating the extrathyroid extension and infiltration of the trachea.
What are the level of lymph nodes? Usually not confidently comment that this is present or not. What are the levels? Could you please clear us?
Normally, the spread is towards the lateral compartment. That's, level 4 and level 3 are the first nodes to be involved. And if it is located medially, then the chances of a central compartment node, level 6 nodes will be involved. And the size criteria, according to the guidelines, is 8 to 10 mm. But irrespective of the size, if they have microcalcification, if they have lost their architecture and they become rounded, then we call it as a suspicious node, and FNAC is recommended for those nodes.
Okay, thank you. So, ma'am, again, your talk was on genetic testing. When will you recommend for genetic testing?
So genetic testing in these cases, unless and until you have FNAC, say Bethesda 3, TRBT is 3 or 4, or sometimes 5, then and then only. In our countries, most of the times we will tell you what it is. AUS, if we say Bethesda 3, you may want to go for the molecular testing unless and until if you have any clinical suspicion of like high probability of carcinoma. If there is no high probability of cancer, I think the clinicians can take, or surgeons can take their call.
Just other than diagnosing, what we can get benefit from this molecular testing?
So molecular testing in thyroid tumors, we can say two broad categories. One is diagnosis, as we said earlier, which is based on FNAC and in particular categories. Second is when we call frankly malignant and larger tumors, or sometimes we say sporally differentiated anaplastic. Definitely it has a place to find out the actionable mutations for targeted therapy. So there again, molecular testing for therapeutic decision is required.
Question to next one. what are the importance of, in this scenario, there is a recommendation from 8825, 11. We may observe or we may some sort of continuous ablation. So, role of continuous ablation.
I don't think I am the right person to take this
Okay, Professor Bari. Okay, please.
Percutaneous ablation I mean, there is no strong recommendation for percutaneous ablation.
This is low certainty evidence, conditional
yeah,
recommendation.
conditional recommendation. Yeah, that's what is recommendation. Only if the patient is apprehensive and then he doesn't want to undergo a surgery and he
Okay.
wants to get it removed, then you can offer a percutaneous ablation, and the chance of recurrence and regrowth rate is less than 5%, and then complications rate is also low. So it can be offered only if the patient is apprehensive about that surgery and doesn't want to keep the nodule.
Okay, this is very right.
I think
Okay,
we just
please.
make a strong message is, as of now, even the intervention radiologists, they fear or maybe they refrain from ablating a PTC or a malignant lesion.
Yes.
The reason is it's still a very emerging specialty or the technique. We don't have long-term follow-ups available in this. It's just almost 4 or 5 years old technique. And there are so much as of now whatever studies they have been done or papers have come out, they have suggested that or shown that after around 3 years the nodule grows resizing. I mean, it starts regrowing. So unless they are sure that this is going to be a benign nodule, they are not going to take a patient for ablation. Not even Bethesda 3 or 4. So if it is Bethesda 2, they'll be ablating. So I think that should be the message conveyed, that because ablation is a technique, new modality coming up in terms of avoiding the major surgery. As of now, there is a strong case selection of only benign lesions.
So we get the message. Okay, please.
Role of ablation in this case is just cosmesis, is it?
Yes, it's only cosmetic. So avoiding a major surgery, avoid jeopardizing the nerve and parathyroids like that.
Okay. So
I want to add something.
Okay, please.
Radioiodine ablation now is very good method.
No.
This was RF ablation.
Percutaneous.
Radio frequency, sorry. Radio frequency ablation in Korean Thyroidology and Radiology Society have a guideline. We can do radio ablation benign as well as the small cancer, micropapillary cancer also, if it is well outlined and sonographically it is 3 or 4, we can do it.
Okay.
At the same time, we can
message
do
is,
all benign lesions.
So message is not to recommend. And interesting story is, after recommendation, there is a discussion on recommendation 11. In this para, they strongly discourage to do it and tell that if you do that, before that, discuss with patient that subsequent surgery will be difficult. Okay. Now we come to again Dr. Karim. Size has been increased now, 3 or 4 centimeter.
Okay.
What will you do?
Okay. Usually recommendation is if more than 1.5 centimeter, then we will do fine needle aspiration cytology. If less than 1.5 centimeter, but tidus 4 or 5, then we will do fine needle aspiration cytology. But size is increasing. Now its size is almost 4, but benign. Then in case of benign, when you offer this patient for surgery, number 1, cosmetic purpose. Number 2, any compressive symptoms.
What will be the size? Usual size. No compressive symptoms and others. What will be the standard size to offer him or her surgery?
Usually more than 4 centimeter will offer him surgery. Because chance of malignant.
In case of benign.
In case of benign.
So in case of malignant?
In case of malignant, usually less than 1 centimeter we active surveillance. And more than 1 to 4 centimeter we will do. If size criteria and no extrathyroidal extension, then we will do hemithyroidectomy.
Okay. So when will you offer total thyroidectomy?
Extrathyroidal extension patient, lymph node metastasis, or
multifocality.
And
multifocality.
Definitely multifocality.
Multilobe.
Multicentric.
Multilobe.
Multicentric. then you offer him. Or age less than 15 or more than 55. 55. Size more than 4 centimeter.
4 centimeter.
Extrathyroidal extension.
Extension.
And also aggressive histology.
Aggressive histology. Okay.
See central compartment nodes on both the sides, even though there is no structurally identified disease on the opposite lobe, you will still contemplate total thyroidectomy.
Okay. So, next I'd like to ask a question, Dr. Saifuddin. What assessment will you offer after thyroid surgery for endocrine perspective? You already, I already said, but
Yes, sir. Regarding radio frequency ablation, I like to add just one point. As this is a critical decision, as this is a I already mentioned, this is a newly emerging techniques and specialty. Not so many papers have been published. So in that case, discussion with the patient regarding the going these things is a having what the patient recommend or suggest for you. This is a shared decision between the clinician and the patient, definitely. Regarding surgery after total thyroidectomy, definitely thyroid function should be checked. And there is a one fear of the hypoparathyroidism, whether it's developed or not. Calcium, magnesium, and thyroid function test.
okay.
These are the
With
things.
reference to your previous talk, I would like to support you in recommendation in ATF 25. There is some discussion on empirical, empirically to give calcium and reductrol or metabolic
Definitely, in our setting, if you consider other than few good ENT hospitals where the practices, other than this institute, in the most of the times, IPTH is comes maybe 2 to 3 days later, and also the quality of test is the one of the important. In outside Dhaka, this kind of tests are not available. They will send it to Dhaka. They will come after 7 days. So empirical, I suggest, it's my suggestion to ENT consultant, just don't afraid of adding empirical calcium and vitamin D. After 1 or 2 weeks, depending upon the calcium level symptoms, you can discontinue definitely, and you can take help from endocrinologist also.
Is there any tool to assess or to predict hypocalcemia day 1 after surgery?
Predict whether the patient has any symptoms, and number 1. Number 2, I always suggest
before appearing symptoms.
Yes, yeah, I always suggest ENT surgeon to check the blood pressure by himself. Definitely, this is a good tool by checking whether the patient have any tingling, numbness, or any kind of tetany, vortex, and these are the good things. So whenever ENT consultant I meet after, especially total thyroidectomy or parathyroid surgery, I always request the consultant, when you visit your patient, say for once a day, just check the blood sugar by yourself. Ask the patient about the symptom, check blood sugar, not by the duty doctor, by yourself. Then you can detect a bit early of whether the patient has developed hypocalcemia.
Is there any role of assessing parathyroid hormone before surgery that compare with after surgery, day 1 or like that?
Especially in thyroid cancer patient, usually that is not indicated to check the thyroid hormone before surgery. Definitely, there is no need unless there is evidence, CT or imaging indicate that there is a associated involvement of the parathyroid. Otherwise, there is no indication.
There are some papers, not here. There are some papers. If it drops by 1/3 with previous one, day 1.
You can definitely, but in our settings, and I think this will add more expense to the patient. In fact, I usually don't practice checking thyroid hormone before total thyroid surgery. But if the patient is affordable, patient convinced, patient stated to you, I like to check, I am very concerned. Some of the patient has gone through internet a lot, and they find, just be careful about my calcium and IPTS. In that case, I suggest, okay, check baseline calcium, albumin, IPTS, and magnesium. After 1 day, we'll check again to be
Dr. Gorim, will add something?
I add one thing. Just like this operation, total thyroidectomy done by high volume surgeon. Then
will you qualify high volume surgeon?
More than 100. Okay, more than 100 thyroid surgery in here.
Okay, anybody?
So there was.
Okay.
So
in I utilize add something in 88-15. It was 100, more than 100 per year. In 88-25, 25 to 50, 50 per year. This has been clearly written.
There is a paper by Duke Health System. Okay. It's a French system who assesses the efficacy of this thing. So they have graded how many is considered as high volume. So less than 25 is low volume. Above 25 they are considered as high volume. So at more than 25 thyroid surgeries a year is considered as a high volume.
Correct.
Then you are high volume surgeon. Then you have done total thyroidectomy. Then not empirically calcium and dicalcium such like things. You just advise in recovery room parathyroid hormone and serum calcium. Then decision accordingly.
Okay.
One thing I just checked, according to American Association of Clinical Endocrinologists, who has done more than 40 thyroid surgery per year, is known as high volume thyroid surgeon, and endocrinologists are advised to send such type of surgeon to any kind of thyroid surgery. So in our country, in front of my eyes, I saw no one is no volume, because there are lots of surgery they are doing. Maybe 100, everyone is high volume surgeon, I think.
So some small questions to surgeons also, please. শেষ করে আসুক। Operatively, what important points you have to be very cautious to save nasal nerve and parathyroid in our scenario, like where neuromonitoring and autoflows is not available.
So yes, very importantly, you have to clinically be confident about, or you have to clinically judge that your nerve is functional. Nerve monitor and everything has come just recently. Autofluorescence also has come recently. Now, autofluorescence helps you to identify. It cannot prevent. It can just tell you that the parathyroid. Yeah, it cannot see unless you put an ICG and then you trace the vascular supply and then you prevent. But otherwise, autofluorescence.
Too costly for our scenario.
Agreed. So this becomes helpful in recurrent cases where you want to locate, or when a thyroid malignancy central compartment nodes are extensive, you want to identify which one is parathyroid so that you can safeguard. So autofluorescence will help you there. Otherwise, you need to be.
Have you any suggestions for juniors how to save nerve, especially
So the most important thing is you have to go capsular dissection. So once you do the capsular dissection, your parathyroids are safely preserved. And you identify your tubercle of Zucker condyle, which is the most constant landmark for your nerve.
Very important point.
So once you identify your Zucker condyle, just underneath it, between the ITA, that is infrathyroid artery, medial to that you will have your nerve. There is lot of stress of finding the nerve during surgery. I would recommend not to hunt for the nerve. If you stick to your steps, automatically you will discover your nerve. So because people start digging in that TO groove to identify the nerve, and that creates some neural injury to that nerve. So if you stick to the thyroid, stick to the capsular dissection, and go slowly hugging to the thyroid gland, you will invariably find the nerve in the TO groove underneath the tubercle of Zucker condyle. So I will just say that don't try to dissect it out. If you are, and it is important that you don't dissect the nerve in the entire length also. If you have identified the supply for the nerve. So if you try to delineate the entire course, you are damaging the vascular supply of the nerve. So you should be very sure that, okay, this is the nerve, and thus you have to stay medial to it and superior to it.
Okay. So I like to ask Dr. Karim, you like to add anything, or I like to?
I like to, sir, add one thing. In case of superior pedicle,
yes,
we usually claim
yes,
blindly. We usually claim blindly all vessels, and I think there is parathyroid gland also. I think it should be ligated separately, and many time there is no ligation required in superior parathyroid gland. If you do it capsular dissection.
Okay. Karim, 1 second. I like to add one word in ATA 15 and 25. Both mentioned that recurrent nasal nerve should be identified, and external blood subsequent nasal nerve may be identified. These two words are different. Okay, so I like to request. Time is running. I like to request Dr. Karim, which patient will you refer to Professor Bari Ninmas for radioactive iodine ablation?
Today we have lots of discussion
Yes.
regarding this.
Just in brief.
In case of low risk cancer.
We should not do intermediate risk plus minus,
never.
and
Usually,
high risk we should do. We should set.
never.
Dr. Siddhartha,
Usually, in
would
my
you-
practice, I never refer this patient in NINMAS. But if you refer this patient in NINMAS, I think every patient get some sorts of radioiodine ablation. But radioiodine ablation is highly recommended in certain cases. And today's lecturer, Professor Ashok Shah, also said in differentiated thyroid cancer, day by day, radioiodine ablation is less important. Okay, thank you.
Dr. Siddhartha, would you like to add anything?
I think in my practice, I do consult the nuclear medicine guy just to be on a similar page that we discuss out the case whether this patient needs any evaluation also or just an evaluation and no therapy. So that in future coming times he is aware about the case. So in that terms, we do send this patient for evaluation by the nuclear medicine people so that they are aware about the thing and they can guide us about how or when we should kind of intervene. So from the level, so once we operate, we keep the patient off thyroid supplements, measure TG, anti-TG at the baseline. The TG value will guide you whether you will need to do any further evaluation.
Any points of high risk, like fixed tissue or extend up to the straight muscle and others? Would you say?
Sir, we are talking about low risk patients where we do need to investigate or evaluate on. So high risk, there is no query
No
about.
question.
There is no question about it.
Okay.
Just to piggyback on Dr. Siddharth, in the current ATA guideline, they have this data system, right? Like you do something, then you assess. Previously, the initial assessment would be typically after surgery and radioiodine therapy. But now they are saying that even after surgery, you assess it.
Yeah.
So assessment would be typically by TG. So now there is levels for everything. For all levels of what type of surgery you are doing, TG levels are there. And even for lobectomy also, there is no TG level, but they have given guidelines for what can be constituted as a complete response or what can be constituted as a structural incomplete response.
Okay.
So based on the assessment, if this is an excellent response,
We do also anti-TG because whatever is there any chronic changes in the tissue, then maybe cancerous. That's why we also do the anti-TPU antibody and the anti-TG also, and then we also depend on the histopathology report. Because we have to see the cancer tissue invade the margin or the already invading and neovascularization crossing the margin. If the histopathologist mentioned, then it is easier for us to calculate the dose as well as for the decision. So I think so.
Okay, Dr. Shai, would you add something?
hardly ever do now because local
Average
patients are not
100 to 200.
No, if at all I have to do remnant ablation, I would give 30 millicurie, not more than that. This was there was a long time back. There was a study done by Dr. Bal in AIMS, New Delhi. So he had periodically given some higher dose of activity like 15 millicurie, 20 millicurie, 30 millicurie, up to 100 millicurie he went, and he saw that the remnant ablation success rate that is happening in 100 millicurie is same as what is happening in 30 millicurie.
Yes, very correctly. That has been mentioned in the ATA guideline.
80 guidelines as well.
So I like to request another question for Dr. Bari. In our country, what will be easy to practice regarding dosing of radioactive iodine ablation?
Oh, radioiodine ablation. In our country, we have the starting dose. We start from 30 millicurie and up to 150 if metastasis is present. And is there any only local metastasis or the cancer variant, whether it is papillary or follicular? And is there any distal or lungs metastasis? We use the variable doses. We calculate extension of disease, histopathological report, and the site of metastasis.
Dr. Siddharth, would you like to add something?
No, I have to ask them too. Say your post-operatively anti-TG is higher than normal 50 and your TG is around 10. Now, whether do you consider significant or how will
We
you
are,
kind
we are,
of
we are
take
coming
it?
to that point.
Yes,
Later. We like to go to sequentially. A lot of our students and junior colleagues are here. So we have to go to sequentially. So radioactive adaptation is done. Please.
In our institute, like for adjuvant therapy, where like in high intermediate or high risk patient where there is no other distant metastasis, the tumor is R0 resection, R0 probably R1 resection. So there, adjuvant therapy, normally we give 100 millicurie. So we don't usually, maybe 100, 120 millicurie, depending on how much activity we are getting. For metastatic patients only, we go up to 150 to 200. For lung metastasis, maybe a bit less, but bone metastasis, we will give till 200
Okay.
millicurie.
I like to ask
Sir,
ma'am.
just, that means we want to go a consensus. In low risk thyroid cancer, we will not require any radioiodine ablation.
Ablation. Okay.
But is there any comment, sir, from your side?
No, this is decided.
I just like to add one point. In our country, irrespective of differential, irrespective of the grade, all the patients are getting radioactive iodine. This will never found in
nowadays
any developed
it
country.
is not correct.
But you
in
should,
our country, we are sending only intermediate risk and low risk. And previous director
but what happens? Patient comes to separately. Yeah, Abdul Karim Mitu sir told there is no need of radioiodine. So, what's your opinion?
we have to ventilate this information today that all patients should not get radioactive ablation.
Yes. I think a good number of patients who are not candidate for radioactive iodine are getting radioactive iodine. Patient comes to separately to ENT consultant, endocrinologist, and nuclear medicine specialist. If any one of them says it's better to give it, patient will give it. So we should make a separate consensus statement, consist of ENT consultant, nuclear medicine specialist, and endocrinologist. What kind of patient should get radioiodine in our setting?
Yes.
If until we publish our own consensus, otherwise there the discrepancy. That's what going on. We continue to go on. Thank
Now,
you.
I like to ask ma'am to tell us radioactive iodine have been given. It is recurring. Oh, another question. I like to ask both of you, a nuclear medicine specialist. How average? How many patients are radioactive avid? Average as a whole, all thyroid patient.
So the TTC patient that we get in our clinic, so depends on now it is a bit variable depending on histology and all, but on an average, more than 85 to 90% patients.
This is a bit higher. You are telling
Will be
probably.
radioactive. But
There-
I am
there-
obviously
there- there is
excluding
a-
the poorly differentiated.
There is
and
a reference
this
in
thing.
ATA guideline 25. They told that. There is a there is a comment on ATA guideline 25. Roughly, 60% patient are radioactive iodine avid. Those who are thyroid malignancy with metastasis, and 1/3 of them are resolved with repeated radioactive iodine treatment. This has been written in this.
So the thing is that that I was not taking the only the metastatic disease.
Yes.
I was taking the patients whom we like think that they are radioactive avid because of there is a remnant.
Okay.
Okay, so I was counting those patients as well because we are treating those patients thinking adjuvant therapy.
Okay.
And based on there is some remnant, we are saying that this patient probably would have gotten the treatment. So if we include those patients, just not the metastatic patient. I'm talking about the patient who have been operated and now only the neck bed uptake. So if you take that into account, it is pretty.
Okay. Small question. What are the patient good candidate for radioactive iodine ablation? Small question. What are the patient?
We have a study in NINMAS last 5 years, the low risk patient, because I think so is the initial information for the ENT head neck specialist. And we have around 250 patient, and after one group we give the radioiodine, and another group just follow up every 6 month follow up. Then 97.2% of patient we got no significant difference. So I think so it's information for us, and only around 2.5 percent patient have the recurrence.
Okay, ma'am, I like
have
to
the
ask you
recurrence. So-
why, what genetic backup compared to recurring the cancer?
I didn't understand. I mean,
What genetic backup, established genetic backup compared to recurring the
so actually that is not something like any molecular test can define.
BRAF and others?
So BRAF have definitely worse outcome, BRAF positive papillary thyroid carcinoma. But otherwise, it's like there is not a single other molecular test that can tell you which one will
Anybody
become.
supplement anything for this question? Why recurring after ablation? What genetic backup?
So,
So it is difficult to predict, but there are like the risk, whole ATA stratification is the, that is what, that we can use as a template, like which tumors.
so everything is dependent on all the risk categories.
What genetic backup? Question is what genetic backup? BRAF positive, others? In written here, RAS and RAT is good candidate
See,
for ablation.
yeah, no, RAS and RET, actually RAS is kind of like follicular
Yes.
pattern tumors, so follicular carcinoma,
Yes.
thyroid carcinoma, they are there. But papillary, again, there are differentiated tumors, they are good. And tall cell and other variants, some hobnail variants, they are aggressive. But then if you look at the risk categories, it's not only the genetic, they don't include that much. It is the type of the tumor, number of vascular emboli, extrathyroidal extension, number of nodes. That is more important, I think.
Okay, thank you. Now I'd like to ask Dr. Shumon. After recurring, TG is rising and anti-TG is normal range. So what imaging will you suggest to check this situation?
Again, I'll start with the ultrasound of neck.
Yeah.
And if at all, if there is any definite evidence of a nodule or a recurrent or residual node, then that would be the cause of TG levels. And if there is no suspicious node or recurrent nodule in the thyroid bed, then I would ask for a CT scan evaluation of thorax to look for any metastatic lung nodes, lung nodules.
Okay. So time is short. Can I give some discussion on medullary thyroid carcinoma? This is very much.
Sir, Sattar sir, one question from the audience to Dr. Saifuddin. If after total thyroidectomy, if in what basis our doctors will prescribe calcium supplement? It is the serum calcium level, or it is the patient symptom, or combination? And if it is serum calcium level, what is the cutoff? What is the cutoff? In which level the patient we will prescribe calcium supplement, or is the only symptom?
Definitely, it depends upon the combination. Your clinical judgment and lab report, both are important. Definitely some calcium, magnesium, albumin. Also, if you have ability or if you have facility to do an IPTS and also clinical assessment, depending upon all of these things, you can suggest calcium and
Say
vitamin D.
calcium
But
level
if
is 6, patient is not symptomatic.
now, still, you should suggest because on biochemistry, so still may symptom, but patient may not be symptomatic at this moment. But you don't know when the patient will go home, say for 400 to 500 kilometers from here. Definitely, in that case, you should suggest.
I like to
Thank you.
conclude by showing three pictures that are in thyroid. This is external metastasis. We have done this patient. Professor Rajiv was shown this case. Thyroid lesion was microcarcinoma. Another case, these three patients we have treated previous month. Another patient also total intrathoracic and microcarcinoma. another patient with metastasis of the sternum and microcarcinoma. So microcarcinoma not always safe. We have to keep a good look on that cases. So I like to conclude the session after.
Just one comment. According to WHO 2022 classification, now the microcarcinoma comment is out. We know that up to 1 centimeter we used to call it, but now we have to specify what type of carcinoma it is, because if it is aggressive histology or other parameters are there, it is no more microcarcinoma. So we are not reporting any as microcarcinoma. We'll say it is papillary thyroid carcinoma less than 1 centimeter size or so on.
Sir, at the diagnosis was multinodular goiter preoperatively, your case, sir? Your case diagnosed was multinodular goiter, retroexternal extension, sir?
Yes.
Multinodular goiter, retroexternal extension.
No, there was only 1 centimeter lesion in thyroid.
Okay.
We did not do this FNAC. In thorax, there is a big lesion, and that was biliary microcarcinoma.
That means.
So this may happen. We have to keep in mind. Reality, but this, yes.
He has shown indolent character in case of low risk micropapillary carcinoma. But if a micropapillary carcinoma, what this guy has told, if it close to recurrent nerve, if it invades, trachea, if it is a high variety, these are all high risk variety. So this can metastasize even.
Sir, so sir, I want to share with very much important things with you. In my combat military hospital, one of our officers lady, she was 40 years old lady. She was limping with her shoulder problem. She was repeatedly visiting the shoulder problem in physiotherapy department. Unfortunately, nothing solution was given to her. Incidentally, she got a thyroid nodule. Incidentally, I did a FNA. It comes papillary thyroid cancer. Then I have done surgery, and because this scenario repeatedly we are getting.
Okay.
1 centimeter nodule paraoperatively, if you get a single
our
node,
country, okay.
single node in the central commander, it is high risk.
We get the point,
So,
sir.
size
In
is
our
not
country,
only-
in our country, thyroid cancer management has been paradigm shifted to there are surgery to ENT. So I like to all our ENT colleagues to get more academic knowledge and expertise on this subject. I request all of you. Number one. Number two, medullary thyroid carcinoma and aplastic carcinoma, some sort of discussion is there today also. But no medullary carcinoma today, full day. So I like to request all of us to practice on it, to just give a look on this scenario. This has been taken from a standard book. So easily you can diagnose this. Just keep in mind serum calcitonin. So though it has not been recommended in many books, I like to request do a small investigation like serum calcitonin, you will get it. Thank you very much.
Sir, one small announcement.
Yes, please.
Yeah, there is a thyroid preceptorship program that happens in Tata Memorial Hospital every year. So if you are interested, then it's a 7-day workshop with surgery and pathology and radiology program. So if anybody's interested. So if anybody is interested, then you can always apply and then attend that.
Okay, thank you very much. Thank you everyone.
এখন আমাদের একটা এক্সাইটিং সেশন আছে, প্লিজ লাস্ট 10 মিনিট। এটা হলো আমাদের কুইজ কম্পিটিশন। ছাত্র স্যার থাকেন এখানে, ছাত্র স্যার ভাই স্যার দুজনে থাকেন।
Thank you, respected panelists and the moderator, sir, for enlightening us, exploring new ATA guidelines and treatment strategies of the thyroid cancer. I humbly request our honorable sirs to take their seats in the audience and be with us in the next part of the session. Now it's quiz time. Get ready, think fast, and let the challenge begin.
Hanif sir, please come to desk.
Everyone, it's quiz time.
Okay, yes. Thank you.
Dr. Mahbubul Haq sir and Dr. Nassim Muhammad Ishadullah sir, please come on the stage and conduct the quiz session.
Respected chairperson, panel expert, my dear teacher. teachers and colleagues, Assalamu alaikum. Welcome to you all to this quiz competition. I would like to request our sir, Dr. Najib Mohammad Ishadullah sir, Associate Professor, Department of Hematology, National Institute of ENT, to start the session. যারা গতদিন কুইজে অংশগ্রহণ করেছেন তারা তো রেজিস্ট্রেশন করেছেন, আজকে নতুন করে রেজিস্ট্রেশনের প্রয়োজন নাই, শুধু কিউআর কোড স্ক্যান করে আপনারা মোবাইলে কোশ্চেন দেখতে পাবেন। আবার একটু রিমাইন্ডার দিচ্ছি, 5টা কোশ্চেন থাকবে, 5টা কোশ্চেনে প্রতিটা কোশ্চেনে 1000 পয়েন্ট থাকবে। 1000 পয়েন্ট থাকবে, যে যত দ্রুত আনসার করতে পারবে তার পয়েন্টস তত বেশি বাড়বে। ধন্যবাদ। আজকের টপিক হচ্ছে থাইরয়েড ক্যান্সার বা থাইরয়েড। কিউআর কোড যারা স্ক্যান করেন নাই করে নেন।
আসসালামু আলাইকুম। হ্যাঁ, ধন্যবাদ।
স্ক্যান করা শেষ? আমরা কি নেক্সট স্লাইডে যাব?
নাম দেবেন, যারা আগে কখনো রেজিস্ট্রেশন করেন নাই পুরো নাম দিয়ে
রেজিস্ট্রেশন করবেন,
প্রসিড করবেন, তাহলে রেজিস্ট্রেশন হয়ে যাবে।
স্টার্ট করেন। নেক্সট
আমরা প্রশ্নে যাচ্ছি।
জি স্টার্ট।
শুরু করছি আমরা।
কোশ্চেনটা পরে মনে রাখতে হবে, নেক্সট স্লাইডে কোশ্চেন থাকবে না, শুধু আনসার থাকবে। নেক্সট স্লাইডে যাব?
সময় শেষ, আমরা ফলাফল দেখি। প্রায় সবাই সঠিক উত্তর দিয়েছেন। পরের প্রশ্নে যাচ্ছি। আমরা উত্তরে যাচ্ছি।
আমার কি পড়া শেষ? নেক্সট যাবো। নেক্সট পেজ গেলাম। I'd like to request our director sir, Dr. Mohammed, Professor Dr. Mohammed Hassan Jabbar sir, to come to the dais and join us to prize giving ceremony.
আমরা সঠিক উত্তরটা দেখি। এখন ফলাফল ফার্স্ট সেকেন্ড থার্ড যারা হবেন তারা মোবাইল নিয়ে সামনে চলে আসবেন, স্ক্রিনটা অফ করবেন না।
যারা ফার্স্ট সেকেন্ড থার্ড হয়েছে তাদের জন্য জোরে একটা হাততালি।
চরম প্রতিদ্বন্দ্বিতা, 3782 দুইজন পাবেন এটা আশা করা যায়নি, তবে দুঃখজনক ভাবে কেউই সবগুলো সঠিক উত্তর দিতে পারেননি।
আমরা ওই স্ক্রিনে যে ফার্স্ট হয়েছে তাকে আমরা প্রথম পুরস্কার দেব। প্রথম হয়েছে ডক্টর বিজয় শ্যাম, দ্বিতীয় হয়েছেন মোহাম্মদ আলী মিতুল, থার্ড হয়েছেন ডক্টর মোহাম্মদ শাহ সিকান্দার তুহিন। সবাইকে স্টেজে আসার জন্য আমন্ত্রণ জানাচ্ছি। প্রথম তৃতীয় দুই পুরস্কার নেবেন, তৃতীয় থার্ড পুরস্কার। জি ডক্টর শাহ সিকান্দার তুহিন ভাইকে ফজলুল ভাই স্যারের কাছ থেকে পুরস্কার নেওয়ার জন্য অনুরোধ জানাচ্ছি। পুরস্কার গ্রহণ করছেন শাহ সিকান্দার তুহিন। সবাই হাততালি। দ্বিতীয় হয়েছেন মোহাম্মদ আলী
মিতুল, দ্বিতীয় দ্বিতীয়
দ্বিতীয় পুরস্কার নেবেন আরিফ স্যারের কাছ থেকে। দ্বিতীয় পুরস্কার সবাই একটা হাততালি। ফার্স্ট পুরস্কার গ্রহণ করবেন আমাদের ডিরেক্টর স্যার প্রফেসর ডক্টর মোহাম্মদ হাসান জাফর স্যারের কাছ থেকে ডক্টর বিজয় সেন। বিনয় সেন এবং পরিচয়টা দিবেন, আপনি পরিচয়টা দিবেন। হ্যাঁ, পুরস্কার গ্রহণের পর।
আসসালামু আলাইকুম, আমি ডাক্তার বিনয় সেন। আমি সিলেট মেডিকেল কলেজে ফেজ বি রেসিডেন্ট হিসেবে আছি। আসসালামু আলাইকুম।
ধন্যবাদ। পরবর্তী সেশনে অংশগ্রহণের জন্য ধন্যবাদ জানাচ্ছি।
Thank you for exciting quiz. Now we are moving on to the next exciting part of our program.
আমি ডক্টর মোহাম্মদ আলী মিতুল, সহকারী রেজিস্ট্রার হিসেবে কর্মরত আছি নাক্কান কলেজ ইনস্টিটিউটে।
আসসালামু আলাইকুম, আমি ডক্টর শাহ সিকান্দার তুহিন, কাজ করছি জুনিয়র কনসালটেন্ট হিসেবে শহীদ মেডিকেল কলেজ।
Thank you.
ধন্যবাদ সবাইকে। পরবর্তী সেশনে অংশগ্রহণ করার জন্য আমন্ত্রণ জানিয়ে আজকের প্রোগ্রাম শেষ করছি। ধন্যবাদ।
Thank you and congratulations to all the winners of the quiz session. Now we are moving to the next exciting part of our program, that is the live surgery session. This is a unique opportunity to observe the expert surgeons in action, learn advanced surgical technique and gain valuable insight for real-time procedure. This session will be chaired by Professor Dr.